Wel, bore da, a chroeso cynnes iawn I drydydd symposiwm ATiC. Good morning and a very warm welcome to the third ATiC Symposium, Catalyse 2023, co-creating the future of health and technology. I'm Professor Ian Walsh, Director and Founder of ATiC, the Assistive Technologies Innovation Centre, here at the University of Wales Trinity Saint David. So I'm the warm-up act today, okay, so you'll be pleased to know. There's some practical information, first of all. We're not expecting any fire alarm tests. If the alarm does go off, we need to make our way to the nearest exit, which is going to be the way you came in and down the stairs, or over the trip hazard here, over the wires and out the door, and then make your way towards the muster point, which is at the front of the building. For those of you trying to access Wi-Fi, if you haven't already read the guidance notes, if you look for UWTSD guest wireless network, you just select UWTSD guest, no security key required. You'll be redirected to a registration page, pop your details in, reason for access, Swiss bank account number, and make your deposit, and then you'll be on the Wi-Fi. Yn anffodus, ni allwn ddarpru, here we go, cyfieithu ar y pryd heddiw. We don't have any simultaneous translation today, but the booklet or the program for the day is bilingual, so you should be able to follow in the language of your choice. Now, we are recording sessions today, so again, if you don't wish to be photographed or don't wish to be recorded, then please make that clear, particularly if you're on the witness protection program. Okay, it could be a bit embarrassing for you. But no, seriously, if you don't want to be recorded in terms of in the room, please let the photographers know. Well then, before I introduce our Vice-Chancellor, I'd like to say a few words, and I'd like to take a few moments, really, to tell you a story, the genesis of which goes back to around 2008, when a group of product designers, academics and staff began working closely with the charity Cerebra to design products to help children with life-limiting conditions, particularly neurological conditions, and to improve the quality of life. Out of that initial cluster of activity was formed the Cerebra Innovation Centre, which has turned into a successful 15-plus years partnership, resulting in hundreds, if not thousands, of children in the UK and around the world receiving life-enhancing interventions created by the CIC team, often with the collaboration of design students and academic staff. I mention that because in the establishment of the Cerebra Innovation Centre, we find the seed which was planted, which would eventually become the Assistive Technologies Innovation Centre, or ATiC. Back in 2014, ATiC came together as an informal cluster of academics, designers and PhD researchers working on initially student projects linked with maybe live projects from industry or health boards, some of which progressed on to become commercial R&D projects. And as a team at that point, we also formed a relationship with Hywel Health Board. I think I've been on the R&D committee now for longer than I care to remember, but quite a long time. But the key turning point came in 2018 with the launch of the Accelerate programme, led by the Life Science Hub Wales, with £24 million of funding from Welsh Government and the European Regional Development Fund. Accelerate brought together the medical schools in Cardiff and Swansea with an unlikely partner in the form of ATiC at UWTSD's Swansea College of Art. But with this unlikely partner came a huge array of possibilities. ATiC quickly established itself as a valuable and dependable contributor to the programme by creating a bridge between the clinical innovators and product developers. Now, typically, collaborations between universities and industry in the life science and health spheres are seen as three-way partnerships. The ABC, if you like, academia, business, and clinicians. What ATiC has successfully done is to add the letter D to the formula for success. D for design thinking, bridging the gap between academic research, business opportunity, and clinical need. I'd go even further to say we've added an E to the equation, experience or user experience. Give us 20 years and we'll get to Z, okay? But the key thing is that we've been able to forge partnerships with life science sector, with health boards, with industry, to help bring that design thinking mentality and that user experience or usability engineering processes into the design of products designed to improve the health and well-being of the nation. Whether it be devices, systems, or spaces, ensuring that those in their design meet the fundamental needs of the users and also deliver sustainable and commercially viable solutions. So here we are, 15 years on from the creation of an idea which has come a long way, an idea which has overcome numerous challenges, funding, credibility, we need to establish ourselves, Brexit, even a pandemic. A messy journey, but one which I'm sure will be familiar to many of you, whether you work in the health sector or work in the commercial business and manufacturing sectors. If you've committed yourself to the pursuit of innovation, to enterprise, to making a difference in people's health and well-being, it's often a very messy process. Innovation isn't a straight line. Somebody described innovation not as a pathway, but as a jacuzzi a few weeks ago at a meeting I was at. Lots of ideas bubbling together, and somehow out of it, some good will come. So I'd like to thank you for joining us this morning, and I hope that we will all learn something new today as we each take another step on our own personal innovation journey. So diolch yn fawr, thank you very much, and I would like to hand over to our new Vice-Chancellor, Professor Elwyn Evans, KC.
Thank you very, very much. Well, there's a thought. Welcome to the jacuzzi this morning. Croeso cynnes iawn I chi gyd. Falch iawn o'ch gweld chi. I see the usual pattern has been well followed. Everyone sitting in the back. But I'm sure there will be opportunities during the course of the day for you to come further forward. Diolch yn fawr iawn I chi am ymuno efo ni. I've been given very strict instructions this morning. I have a terrible habit of wandering around when I'm talking, and I don't like microphones. But you'll see, I'm having a thumbs up over there. I've been told, as this is being live streamed, that please will I stick to the microphone. And probably Ian would say stick to a script. So here I am on my 8th week as Vice-Chancellor of the University of Wales Trinity Saint David. And it is a real, genuine pleasure to be sharing today with you. Lots of people ask, what does the Vice-Chancellor do? Haven't quite worked it out yet. But one of the things that certainly is a real privilege is being able to be involved in events such as today. Because if we are not in the business of changing lives, then actually we're not doing the job right, are we? And this is the sort of work which fundamentally is at the heart of what we need to do as a significant partner with a significant agenda at a time when it is incredibly important that we maximize those relationships and those opportunities. And so it is a genuine pleasure. The words we overuse, aren't they? Pleasure, privilege, but it is. It absolutely is. And you will know that ATiC and the work that ATiC does is one of the very many things that we are very, very proud of as a university. And this event is held in collaboration. Again, and we were talking a few minutes ago, it's one of the really important words that we are using as a sector, as a country at the moment: collaboration. For me, what we need to do isn't just to use the word, but to absolutely demonstrate and evidence what we are doing is genuinely collaborative. We can't solve the problems of the region of Wales, the country, more broadly on our own. It is only through genuine, heartfelt, profound, meaningful collaboration that we can start to progress and build on the successes that have already been achieved. And so we're collaborating today, and I say it with enormous pride, with Hywel University Health Board and its TriTech Institute. Of course, also collaborating with a wealth of other organisations, bodies and people. I'm going to name some names, but please, in doing that, I am not being in any way exclusive of anyone. It is a real joy to see so many here, and of course those who are joining us online, and everyone is welcome. But some names, if I may, because they will reflect the programme that we will be following during the course of today. To our keynote speaker, Dr. Rob Orford, the Chief Scientific Advisor for Health for Welsh Government. You are very welcome, and we are very much looking forward to your keynote speech. I'm delighted to welcome Professor Phil Clur, and I will be handing over to him very shortly now, the Medical Director and Deputy Chief Executive Officer of Hywel University Health Board, and also delighted to welcome Professor Chris Hopkins, Director of the TriTech Institute, key partners with us, with ATiC. There are 4 themes, I'm sure you will have read the programme, but just to remind you, 4 key themes in our sessions today, including co-creation and partnerships, immersive technology, medical technology, digital technology and big data, all incredibly relevant key topics. And it's a fabulous programme that's ahead of us today. So, welcome to you, invited speakers from Wales's health and higher education sector, from within the United Kingdom, and indeed internationally, with some of the enterprises here today, including Bloom Standard from the US and Cyberdyne from Japan. Welcome. I can't emphasize enough the pride we take in our partnerships, in our relationships with health boards across Wales, and one, of course, of the bodies we are delighted to welcome and work with, Digital Health and Care Wales, a national organisation building and designing digital services for health and care in Wales. Digital Health Ecosystem Wales, a collaboration between Life Sciences Hub Wales and Digital Health and Care Wales. Lots of names, but the secret is in bringing everyone together, the working together. And so that is a wonderful array of industry, clinicians, policymakers, academics, innovators, and even funders to create an environment of digital innovation in Welsh healthcare. So a fabulous opportunity today to showcase how collaboration between academia, the NHS, industry, deliver real benefits, real outcomes. And I started off by saying the real privilege of my role as a Vice-Chancellor is to support and ensure that the academics within our university are working with academics across the sector, but also with all of you. And why are we doing it? Yes, because it's very nice to meet and talk and network, but it's wonderful to have the opportunity of changing lives as well. So thank you very much, enjoy the day, and I look forward to ensuring that at least we, as a university, will continue to demonstrate, as ATiC has done over the years, genuine collaboration and genuine delivery. Diolch o galon I chi gyd. Mwynhewch y diwrnod.
Well, Bwrdd I chi gyd. Good morning, everyone. I'm Phil Claw, Medical Director, Deputy Chief Exec at Hywel Dda, University Health Board. And I think I also, therefore, need to stand by the microphone and can't walk about, is my habit. So look, it's amazing to join you here and to be in the jacuzzi with you, apparently. So thank you, Ian, for that image. Trying to imagine that right now. So look, I will also try and stick to the brief. One of the things I think I'd like to do is just to reflect on health and care at the moment. And when you think about the planning that went into place when we were dealing with the pandemic, actually that was relatively simple compared to managing the aftermath, which is a huge, huge challenge everywhere across the world, not just here. And at the moment, it touches everybody's lives, doesn't it? There's people waiting for procedures, tests, assessments. GP surgeries are full everywhere, not just in West Wales, everywhere. Hospitals are full, social services are struggling. So it's a really big challenge that we all face. And I suppose that sounds significant, but then if we look forward to a sort of 20-year horizon, what will we see over the next 20 years? And apologies for giving a rather sober view at the start, but I'll try and lighten it up later. But at 20 years' time, in fact, 2044, it's predicted that we will see peak death. I know that tends to get people's attention, but it's at that point that it's predicted we'll see the most people dying in the UK, and that's because of the sort of baby boomer population. Peak mortality is probably a sort of more fair word to use. But that's really significant, not just because there'll be the most people dying, but also because we'll see the largest number of older population about and the smallest number of younger population about. So the demographic will be a proper triangle at that point with a really large older population. And that's not only a problem because there won't be enough people to care, because at the moment we've already got challenges, haven't we, with carers in society. So we have an even bigger problem with numbers of people to care. But there'll also be a challenge around a smaller number of people relatively who are economically active. Now, if we couple that with the challenge around climate in 2044, how many people make estimations about how many bony fish will we see in the ocean, those sort of challenges, plus what will tech and digital look like in 20 years' time? It's difficult to predict that in 5 years' time. Actually, there's a huge amount of change going to happen to our society. And what I feel is, one option is to sort of meander our way towards that over the next 20 years. The other option we have, and I feel we're doing that together, is take some positive, energetic steps towards tackling those real societal challenges that we're going to face. And that 2044 isn't something that's going to happen in 2044. Suddenly, it's there. It's a ramp towards 2044. And in that time, we'll see rises in long-term conditions, and we've seen that prediction in the recent Chief Scientific Officer's report. There'll be higher rates of cancer and dementia. So there's all sorts of things that we will need to face as a society, not just the health service and not just social care. And as I'll talk about in a minute, that isn't going to be solved just by a medical model of health that we have at the moment. If that's what we rely on, then we're going to need to build a lot more hospitals. And of course, we know that can't be the answer, because for one thing, we won't be able to staff them. So there's got to be something else that we need to do. So I think we need to harness, as I feel we are, the technological and social innovations that are within healthcare, but also within other industries. I think our work with UWTSD is an exemplar in how we bring together the university sector, industry sector, and healthcare sector in facing these real challenges and coming up with solutions. So Leighton Phillips, I need to credit him with this because it wasn't my thing. He reminded me of an African proverb, which I think is really apt for us when we're thinking about this. It is, travel far by travelling together, travel fast by travelling alone. So when I look about me in my daily life, I see a lot of people travelling fast, and most of them are travelling fast around a hamster wheel, doing exactly the same thing, rushing round and round and round. And that clearly is not going to solve the challenges we face now, let alone in the future. So I feel we are joining up our appetite for innovation in healthcare with UWTSD's thirst for application of evidence and insight to real-world application. As your new Vice-Chancellor said, one of your key aims is to demonstrate genuine impact on people's lives. And I think, we have a real opportunity to do that. So look, our collaboration, because, we use that word, as you said, Vice-Chancellor, we use that, it's bandied about everywhere. But I think we are doing this in practice. Through TriTech, I see absolute evidence of that. We've done that through bringing together our teams, our structures, and our processes, and aligning them together. And it's been really powerful. So it's important, of course, that we celebrate some of the fruits of this collaboration. And we'll see today, through all of the presentations of the projects, evidence of real innovation and impact. I think one of the challenges, though, today, is if we test ourselves a bit further, might be to consider how we might look at social innovation. Because if you look at healthcare, it's only responsible for 15% of people's health and well-being. The other 85% of people's health and well-being is built on by the social determinants of health. And health and well-being tends to be created within communities. So I think the challenge for us over the next 20 years is to consider how we work on social innovation. And of course, tech can be applied to those communities, but more and more I think that's where we'll need to be. So look, I'm really looking forward to today and hearing more about the projects, and I'm really looking forward to growing our collaboration even further as we go forward. So look, thank you very much for inviting me here, and I think I'm handing over to Rob Orford. Welcome. Thank you.
Wow, I can see you all at the back now. And thank you ever so much for the very kind invite to come and speak to you today. I was invited last year to come, and I couldn't. Unfortunately, I was waylaid by preparing for the public inquiry, and I've been waylaid ever since. I finished my last statement on Saturday morning, so I'm free again. Whilst I've been looking backwards, my group in Welsh Government, which is called Science, Evidence, Advice, have been looking forwards, and I'll touch upon some of the areas that Phil introduced. They're worth saying twice. In this reflective period that I've had of thinking in much slower time in forensic detail about our actions and activities during the pandemic, it's been really useful to think about what's coming and what we've seen. So one of the first questions that we were asked in those early months of 2020 was, how big would that wave be? When would it arrive? When would we see peak demand? When would we see peak deaths? And in those first projections that were absolutely woeful, it suggested as a reasonable case that would be 28,000 deaths in Wales in that first wave. And the things that we had available to us were rather blunt tools that caused significant harm, but they would take pressure off the NHS and they would protect people in Wales. And for those measures to work, we absolutely needed the collective actions of the whole of the public and whole of society. And we did that because we thought it was important to protect the most vulnerable in society. We did it to protect our loved ones, and we did it to protect the NHS. We think health is important, and we'd forgo our liberties to protect others. So those blunt tools that were brought to bear on the population were soon outcompeted by tools and interventions that caused more balance, that created less harm. Lateral flow testing, therapeutics, and then vaccines. They were very much science-led, and they were very much evidence-informed. And we saw that necessity is the mother of invention and innovation. So I think today and tomorrow we're in a very similar position. Not that we're facing an epidemic. COVID is still here. It's not gone away, and it will invariably come back in different guises. But now we're facing a syndemic. We're facing a number of challenges that are combining and presenting significant harm on our population and our health service. So very recently, my team, while I was busy with my pen, my quill and my parchment in my loft, wrote a paper looking at what the future might look like in Wales, asking what the health of people in Wales will look like in 10 or more years' time, people that we work with, people that we live with, our loved ones. And they asked, what would this do to our health service when it turns 85 years old? And we were asked this question so government could see whether its policies were in the right places, whether our assets in the NHS and social care were aligned for what might be coming. And I think you could all take a very well-educated guess of what's coming. We've just heard from Phil. It says we live in an aging population, and it says the prevalence of various conditions, long-term conditions, will increase. And there are conditions like dementia, diabetes, cancer, musculoskeletal conditions that are significant. And some of those conditions, like cancers and dementia, are a consequence of us living older. Fewer people are dying of communicable diseases. But we know that there'll be an increase of people living with 2 or more long-term conditions in this period. And there'll be a doubling of people living with 4 or more complex conditions. And many of those will have mental health issues. And for people with 4 or more complex comorbidities, they will go to an outpatient appointment about once a month, which is a significant burden on the NHS. From the projections, as we did in COVID, it looks like some of the diseases will increase more swiftly, faster than the age of the population. Conditions like dementia, heart failure, osteoporosis, chronic heart disease, asthma, hypertension, anxiety disorders, and diabetes. Diabetes alone, it might increase by 22% for 260,000 people in Wales alone. And some of these increases are preventable. Obesity is projected to rise, and itself is a risk factor for many conditions like diabetes, dementia, and hypertension. We know that for every £1 that we invest in prevention, we get a £4 return and our £1 back. We know if we do this at a national level, we get a higher return again. We learned that in the pandemic. We learned that local interventions, whilst they were effective, they weren't as effective as national interventions. So we really need to think collectively. We know that people living in disadvantaged areas are more likely to have multiple conditions. And there's a stark difference in life expectancy between less affluent and more affluent areas, with people living on average 9 years less long. And in those same areas, people will live in ill health much longer, 22 years versus 13 years. So the evidence is telling us we have to invest in prevention, and that's very difficult with the challenges that we have today. And the evidence is telling us we need to address social inequalities and health inequalities. It says we have to diagnose earlier. It says we need to treat people as a whole person rather than a pathway, and we need to do more with people closer to them at home in the community. And none of this is new. This has been writ large by other organisations, Academy of Medical Sciences, the Health Foundation, the Bevan Commission. None of this is new. We also know that many people are out of work because of long-term conditions. That adds a sea anchor to our economy. It reduces our prosperity. It decreases our resilience to threats that come along, like pandemics and climate change. We know the workforce is ageing. We know people will need to be in the workforce for longer, so it has to be a really good place to work. And we know we're living through this technological age of precision medicine and AI and robotics and medtech. So what's the answer? And I'm hoping I'm going to hear from you today. My job and others in government are to create the policies to support the landscape, to create the environment for life sciences, for technology to prosper. Paul Nurse recently wrote a review of the RD&I infrastructure, and he said we have to focus the beam. We've got enormous activity, we've got enormous potential, we've got incredible strength in our universities, so we have to channel that on the problems that we have. We have a UK life science vision, and we've got missions where all of the research councils are coming together and saying, how can we address dementia? How do we go after cancer vaccines? How do we think about ageing in a more sensible way? And there's a time for Wales to come together and go after that environment and work collectively and collaboratively. Lord O'Shaughnessy said recently, we need to do more commercial clinical trials. We need to work in trusted partnerships with NHS, with industry, with academia. We need to make clinical trials a standard of care because it improves outcomes. We have an innovation strategy in Wales. We're developing a life science plan that sits beneath that. We have a healthier Wales that articulates all of these challenges, and that was written in 2018. And we have a Wellbeing of Future Generations Act. So we're committed to think about the future and not discounting it. So from my perspective, I think we have the policy landscape, we have the opportunities, and in Wales we need to brace those opportunities by working collectively. When you think about those challenges, you can kind of feel hopeless that this is a foregone conclusion. But we have changed health trends in the past, whether maternal mortality, childhood illnesses, or communicable diseases through the introduction of vaccines. I think what's different about this syndemic is that we will all need to work collectively. The NHS cannot take all of the burden itself. So we need to work collectively with the public, with charities, with industry, with academia. Everybody needs to work together on this collective idea of changing this trend. And I hope if we work collectively, we can show that getting older doesn't necessarily mean getting unwell. And I think that's really the challenge that we have. I hope you have a fantastic day today. It's a real privilege to be here, and it's great to be at my loft. So thank you for your time.
huge thank you to our initial speakers, and thank you, Rob, and thank you, Phil, for kick-starting our day. We're moving through into session 1 now, and actually before we start session 1, I wonder if a couple of colleagues could maybe lower the blinds a little bit, because those of us sitting in the front row are getting rather hot at the minute. We just drop it down a bit. The sun's... The jacuzzi. Can somebody turn the jacuzzi down, please? And so, we're moving into session 1 now, which is co-creation and partnerships. We have 4 speakers. Professor Chris Hopkins, head of the TriTech Institute, and also key partner with us in ATiC. John Carrington, Chief Executive of NGPod Global Limited. Anna-Marie Saranen, Chief Executive Officer and co-founder of Bloom Standard. And then, no name for speaker here, ATiC and NHS Wales Rehabilitation Engineering Services. Is that going to be Sean, I take it? Yeah, Sean. Yeah. So modest, he hasn't put his name on the brochure. So, I should say, actually, a bit of housekeeping as well. For those who need to take some Teams meetings or Zoom meetings through the day, we have some rooms available up on the second floor of the building. So if you see one of my colleagues at the reception desk, they can direct you to those rooms. So if you need a bit of peace and quiet to take a Teams meeting or whatever, there's a space for you to work upstairs. So then, first speaker, Professor Chris Hopkins. Where are you, Chris? Come forward, please. Come on down. Thank you, Chris.
I'm going to have to stick to the mic now. Good morning, everybody. First of all, thanks to our Vice-Chancellor, Hywel. Thanks to Ian, thanks to Phil, thanks to Rob. But in particular, thanks to all of the ATiC team. I normally make them stand up at this point and take a round of applause. I'm not going to do that, but I think we all need to remember what goes on behind the scenes, really, to pull an event like this together. So my thanks to you all. So, I've got a few roles. I've got 2 NHS roles. I work in Hywel University Health Board, and I also work up in, I've just taken on a role up in North Wales within Betsy Cadwaladr University Health Board. But I'm also clinical director within the ATiC team within UWTSD as well. And that gives me a number of opportunities, really, to really forge these alliances and these partnerships. So I've got a bit of a random presentation for you today. I've got 2 parts to the presentation. I'm going to go back in history a little bit, first of all, just to sort of look at some of the themes around partnership and research and innovation. And then I'm going to share with you then a specific example of an AI model that we worked on in collaboration with a number of partners around prostate cancer. And I hope this works. Okay, going back to 2022, we sadly lost Queen Elizabeth II during this year. And I am going to stay on piece today. I'm going to read from the notes, okay, because I normally tend to go off on all sorts of tangents. So we sadly lost Queen Elizabeth II during this year, but we also celebrated 70 years of her accession to the throne. Images in the media of the Queen in her younger days probably bring back flashbacks for those of us that are old enough of what the UK was like in the first half of the 20th century. But by any account, it was a period of astonishing change for the UK and for the world as a whole. I told you it was going to be random. Comparing life then and now, the presumption is all too powerful that progress is the assured course of human history. However, if we reach further back in time, we'll find that progress is in fact a rather young concept. People in the past thought of the body of human knowledge as somewhat contained, because indeed there was not much else to study at that particular time other than theology and metaphysics. But a monumental development in our Enlightenment was the opening up of nature as a field of study. The theory of evolution by natural selection was first formulated by Charles Darwin's book, which was published back in 1859. In his book, Darwin describes how organisms evolve over generations through the inheritance of physical or behavioral traits. Because nature does indeed operate according to constant laws, these laws can be known to us through measurement, mathematical description, logical reasoning, and empirical verification. What has become to be known as a scientific method gave both impetus and structure to our human curiosity. Nature became the subject in which new knowledge could be had, and the scientific method became the standard by which knowledge could be validated. Okay, first test of the day then. Easy one first of all. Who's the gentleman on the right-hand side? Show of hands. Einstein, wonderful. What about the gentleman on the left-hand side? Oh, there's a hand up. Faraday, Michael Faraday, indeed. So for the everyday person, science is somewhat obscure, and it can be quite baffling at times. But technological innovation became the means by which the everyday person gets to enjoy the new discoveries of science. We don't really need to understand Faraday's law or Maxwell's equations to enjoy the numerous electrical devices that are at our disposal, or the use of our mobile phones. And we don't really need to understand Einstein's general theory of relativity to be able to use our GPS devices. But it is by technology that science becomes tangible to the everyday person, and thus progress becomes practical to us all. And it was when society perceived the benefit of new knowledge that knowledge creation was transformed from being undertaken by isolated people working by themselves here and there to an institutionalized effort with colleagues working together. And this, I'd argue, was probably the very beginning of modern research. With innovation comes jobs and strength of the economy. And so tight is this linkage that there's now a new geography of jobs that is distinct from the former geography shaped by manufacturing and finance. We know that cities with strong research universities will be strong economic centres of the future. If the research function of the university produces innovation, it is the educational function of the university that produces the human talent that will sustain innovation as well as translate innovation into tangible benefits for society. Talent and innovation work in a virtuous cycle to support centres of economic strength. And the life science sector in Wales generated over 2.6 billion in turnover for the Welsh economy in 2020. That was up 12.1% from the previous year. Over 260 new businesses have launched in the Welsh life science sector since 2020, and the industry now employs over 12,500 people across Wales. And in terms of export, medicinal and pharmaceutical products were among the top 5 exports and have a yearly value of 1.1 billion. In November 2019, when the Royal College of Physicians published this document entitled Benefiting from the Research Effect, they suggested a number of ways that NHS trusts and UHBs can support staff to become more research active, and how this would benefit both patients, staff and our communities. It showed that the involvement by staff in research can improve their morale, but can also help us with the recruitment and retention difficulties across Wales and across the UK. And for me, research is far more than just clinical trials. Anything that provides new knowledge and improves patient outcomes should be considered research, delivered by multidisciplinary teams. It ranges from discovery science to epidemiology through to robust evaluation. And as we enter a new era of digitization, we're already applying new learnings in key fields such as AI and big data to solve major challenges facing critical industries like healthcare and like energy. Innovations are not only the collection and analysis of patient imaging and the application of genomics, but also diverse physiological and molecular measurements in individuals at a level that's not previously been possible. How effectively society as a whole is able to capitalize on AI in health will depend in part on how well this data is integrated by our clinicians and communicated to the public. Ian will be pleased I put the innovation matrix on this one. So collaboration between health, industry and academia is key. It's key to catalyse innovation and growth. While industry often focuses on addressing solutions that are of near-term commercial value, and academia and health focus on building new knowledge through research and imparting education to our students, the combination can yield an accelerated development of new breakthroughs. Industry partnerships are instrumental in advancing research and creating a skilled workforce. Industry gains work-ready talent with specialist knowledge and practical training, and universities and health benefit by having opportunities to work on relevant technologies and challenging problems. What is more expensive to society are the consequences of not supporting our universities, our industry partners, and our clinical teams. And here comes the preach. In a democratic society, governments come and go, and government funding priorities come and go. But an appropriately supported research and innovation culture endures. While our universities and health boards are being tossed to and fro through economic, financial pressures and changing policy, research and innovation serves as a ballast to give stability for our future, and more importantly, for our patients across Wales and across the UK. So for those that are not aware, the Innovation Matrix is being developed just over the bridge, and that will be an area where we can basically create this jacuzzi effect, let's say, where we all work together, health, academia, industry, to really work together on solving some of these complex problems. So, moving into specifics, this was a piece of work that we undertook over an 18-month period. It's a piece of work that, for me, exemplifies where partnerships can really support sort of the solutions around complex problems. So within this work, we examined the use of an AI model to support prostate cancer detection at that MRI stage. I put an example up here of the TriTech team. It's not just the TriTech team, it's academia, it's everybody we work with, really. But I'm very fortunate. We're very fortunate within Hywel to have a team like this, because if you look at the slide deck there, you'll see we have nurses, we have doctors, we have pharmacists. Dan will be speaking today. Clinical scientists, engineers, researchers. All of these bring something different to the various projects and studies we work on. And then added to that, our academic colleagues and our industry partners all support and bring something different to this discussion. So, we know that 1 in 8 men across the UK will develop prostate cancer, and that risk increases, particularly from age 50 onwards. Men typically present with prostate sort of related symptoms to their GP, where initially they'll receive a PSA test, which is a prostate-specific antigen test. This is part of the agreed NICE pathway across the UK. If that test is elevated, they'll then be referred on to MPMRI. So it's not just a standard MRI, this is multi-parametric MRI. And again, depending on the outcome of that MRI, they'll then be passed then for biopsy, which is considered really the gold standard for testing. However, there's a problem. There's a problem here, because all of the literature suggests that accuracy at the MRI stage is less than 50%. And on occasion, it can be as low as 30%. And there are a number of factors that cause this issue. Number one, the prostate as a gland is very difficult to interrogate, really, particularly at the early stages of cancer presentation. Added to that, we've got a shortage of radiologists across Wales. And on top of that, we've got a shortage of radiologists with a specific interest in prostate cancer. So we know there's a problem there. And what tends to happen is these patients, if there's a doubt at the MRI stage, these patients will be passed for biopsy, just to make sure we don't miss any potential cancers. But the biopsy presents additional risks for those individuals as well. So we had the opportunity of collaborating with a company called Gyd-greu to look at their Gyd-greu RDX model. Their initial results suggested 87% sensitivity and 67% specificity. But those results were obtained from various archived data banks across the world. What they didn't originate from was from actual clinical practice. And we know within a real-world clinical environment, MRI machines are different. We have different manufacturers. You have different strengths of MRI. You could have a 1.5T, you could have a 3T. You could even have, within Cardiff University, you could have a 7T MRI. But they're also configured differently. So we wanted to test and develop this AI model in a real-world clinical environment. Just to give you a sort of sample, really, when we do an evaluation, we follow a similar process to that what we'd follow really through a research study. So we applied inclusion and exclusion criteria, procedures are developed, data collection, we consider patient confidentiality to make sure that all of these images are anonymized before we sharing them with any industry partner. And we also undertook both quantitative and qualitative analysis during this study as well. And we also used the NICE meta tool. And the NICE meta tool allowed us to look at the evidence base surrounding this GIVA RDX model to understand where they are and where they need to be then as they move forward. So just a sample on the screen now on the typical sort of inclusion-exclusion criteria. We only looked at patients between the ages of 50 and 75. We looked at a range of Likert scores. So when a patient presents at MRI, they'll be scored. So 1 will be cancer not likely, 5 will be cancer significantly likely. So we wanted a range of scores to include in the study there. And where do we get to? So over that 18-month period, after various iterations of relearning and sort of adapting the model, we achieved then 77% sensitivity, 65% specificity, and 69% accuracy overall. Now, a number of you would sit there and go, well, we need more. Really, in an ideal world, you'd want 90% or higher around your sensitivity or specificity figures. But if I refer you back to the original slide, where current accuracy is sitting at 50% or even low as 30%, there's something there that we could potentially use at this stage. We can't use it at present because it needs to go through the MHRA for regulatory approval. But what we do know is, as we start to use this as a tool and we feed more and more images through this model, then that AI algorithm will get better and better over time. So, we've already discussed the sensitivity and specificity, but the qualitative aspect is really important for me, particularly around AI. So we surveyed 15 of the multidisciplinary team involved in the urology pathway, and 11 of the 15 responded. All 11 of them had a positive opinion of the AI model, which is interesting because if I'd asked that question of radiologists 5 years ago, they feared AI because they felt that AI potentially would take their role in the future. But they all recognize now that AI is a tool to support their decision making, and they recognize the opportunity. So they all highlighted the fact that the AI model could have on patient safety, on patient outcomes, on teamwork, communication, and efficiency as well. Unfortunately, of the 20 patients we surveyed, only 3 of them responded. All 3 of them responded in a positive nature. But when we dug into, well, why? Why didn't the other 17 patients respond? It was because they didn't understand AI. They had no idea what AI was. The only appreciation they had of AI is what they see in the media, which is unfortunately quite negative in some respects at the moment when they talk about world domination and sort of, all this sort of thing. So there's some work. There's some work that we need to do there with our communities to raise awareness around artificial intelligence. And the value case, we undertook a health economic assessment of the model, and that came back with a potential cost saving for the NHS over the duration of that pathway. So, just to conclude, we found that the model could also integrate into our systems as well. Furthermore, engagements with the clinical teams and patients, as we said, there's a positive impression there. We're now working with GIVA to support them through that regulatory approval process. The full evaluation, by the way, if you go onto the TriTech Institute website, the full evaluation is on the link there. So my thanks to you all for your time today. I hope the initial part of the presentation wasn't too random. I hope you've enjoyed the history lesson today, and I'm very happy to take any questions.
As ever at these events, everybody's a bit shy, so please grab hold of Chris over coffee. And as Chris has given me license now, if you haven't got your brochure, for the Innovation Matrix. Pick it up off the back table, check us out on the website. There is space available. Not much, but there is space available if you fancy relocating your business into the heart of our SA1 Innovation Quarter. Well, our next speaker is John Carrington, Chief Executive Officer of NG Pod Global Limited. John.
Hi there. Good morning. Unlike everyone else that's spoken before, I'm not used to this, so please bear with me. And I'm really preaching to the converted. We're a room full of innovators. So what I'd like to talk to you today is about our experience, particularly of implementing innovation in a healthcare environment, which as a business that's been around for 10 years and just in the commercialization stage, it's quite important that you guys understand how difficult sometimes this can be. So how do we get from here? So this is the 1950s picture of the NHS. That actually could be my mother there because she was in the NHS at that particular time. To here, which is a modern day, blank screen, modern day ICU. So there's a very simple answer to this. We've also seen a significant increase in life expectancy over the last century. And there's a very straightforward answer to this. It's not the only answer, but it's a very significant part of it. It's innovation. Now, innovation on its own is great to have, but innovation without implementation is useless, it's worthless. So we are talking today about the implementation in healthcare. And innovation only happens if we have change. So this is really our view of how change is perceived. What is change? There's some nice definitions here, courtesy of AI, strangely enough, from Bing. So to make something different or to modify, to replace something with something else, newer or better. And again, newer or better equals innovation. So there's a clever chap called Tony Robbins. He's an American entrepreneur. He's a TED talker. He does blogs. He's a YouTuber. He's quite well known. He came up with a very simple equation, which is change happens when the pain of staying the same is greater than the pain of change. Now this is quite an interesting one. Pain is very subjective. Now, pain is a feeling. It depends on the intensity of that pain, on how it makes us change. What are the consequences of that pain, and who is feeling? Am I feeling the pain, or is somebody else feeling that pain? Now, there's also another thing to be said that, in terms of this, is environment matters. Now, I've only been in the medtech industry for about 10 years. So before that, I've been in the toiletries and cosmetics industry, and the environment there is very, very different than the environment in healthcare. So I just want to do a very quick comparison between the two. So for consumer goods retailers, the customer has all the power. So they are very, very powerful. They dictate the terms. The profit margins for the suppliers are minimal, and the consumers have a choice of where to purchase. So there's a lot of difference between that and healthcare. So there's a constant downward price pressure. So retailers competing for market share, which drives extremely competitive supplier base. So the simple answer is, if you don't innovate, you do not survive. It's very, very simple. The innovators are the ones that progress. Everybody else just falls by the way, so either gets bought or basically they don't progress. In healthcare, it's very different. The customer, which is the patient, has very little power. As an individual, they have very little power themselves, and they're probably at the most vulnerable while they're sitting in a hospital bed waiting to be sorted out. We measure spend and how do we save money rather than profit, and how do we, so it's all about how we spend less. I mean, one of our customers, they have an objective to save 1% of their budget every year in an environment where inflation is running at 8, 9, 10%. So they are hugely challenged to do that, but it's a reality that we have to change. So that means we have to drive efficiency. There's no competition between healthcare providers at the point of care. You go to your local hospital. You don't have a choice unless you're fortunate enough to have private healthcare, which many people do. And change can be viewed as risk, which is fair. This is fair because we're dealing with people's lives. Accountability is not individual, it's by committee. So you don't have a CEO that's accountable ultimately for the success of their business. You have a number of committees that are responsible for the patient's safety and improving collaboration, including improving ways of working. Now, unfortunately, committees don't have a habit of working particularly quickly or particularly well. Now, I'm sorry if this is upsetting anybody, but it's a reality. Sometimes that can be a little bit blunt. So it's quite controversial. We have a hangover from a blame culture, a very strong blame culture that introduces fear. Now, if you look at a company as an example that failed to innovate, everybody remembers BlackBerries, those great handheld devices that were really cutting edge. They put your computer in your hand, in your pocket. What happened to them? They failed to innovate. They failed to see the competition. In 2017, they stopped supporting BlackBerry devices, and they had to switch their business model to cybersecurity. That's a huge change for an organization. So just going back to the pain point again, a never event. It's probably the ultimate pain point. Now, it's as a pain as a change driver, this is very, very significant. The problem is when we get to the point of a never event, which our device addresses a particular never event, when you get to a never event, it's too late. Somebody is being harmed. Somebody may have died. And that's too late to do anything about it. So we need to be acting before these things happen. And we're very on side of this as industry. And of course, we make money out of it. Let's not be coy about it. We're in business to make money, but we're also in business. Our business is in business to improve healthcare. Now, pain is interesting. It's something we hear too frequently. Can you come and see us? We've had a never event. We really need to do something about it. It happens all the time. Pretty much every engagement, and we have 120 hospitals in our pipeline, our sales pipeline. A lot of them have been driven by having a never event. The sad reality is if we don't respond quickly after that never event, the pain fades, it goes away. And by 6 months down the line, everyone's forgotten about it, which is really sad. So what do we do about this? What do you do as a manufacturer? So there's a very nice model by Everett Rogers from 1962, which is the year before I was born, so it's quite old, relatively, which is this graph. It's the adoption of innovation. So what we have to do as a manufacturer, we have to find these people, the innovators, because they're the real change drivers. They're the ones that aren't afraid. They're the ones that want to drive things forward. They're the ones that are willing to put their heads above the parapet and say, actually, we need to do something about this. Problem is they're very small. There's a small number of them. They're very rare, and we can never find them. And they're always very busy, because that's their nature. They're busy people. So this was our perception. And maybe I was a bit naive. Coming from the consumer goods region, area of business to this, I was maybe a bit naive, which is not a bad thing, but you know, we learn. So the perception's fairly straightforward. Our device, patient benefits. It's simple to use. It's safer than the current way. It doesn't need interpretation. It's obvious. It should be simple. That, in my simple brain, was how it should be. And why wasn't it? Well, the reality. Real factors that we observe. So this is our observation, and I'm not suggesting that everybody has the same experience, but these are our observations. So there's the weight of change. What flies in? Habit. So habit is very, very difficult to change. You know, we know that we are dealing with a process, so we are looking at a device that measures pH. The current method of measuring pH, to confirm correct placement of an NG tube is pH paper. It's been on the ward for 20 years. So in 20 years, people have just got used to doing the same process over and over again, even if it's inaccurate, even if it's sometimes difficult, even if they can only get an aspirate 60% of the time. They're so comfortable with it, it's easy to do. Look, it's not easy to do, to be fair. It takes half an hour on average, but it's something they're so familiar with. So how do we change habit? And you've only got to look at the example of the tobacco industry. It still exists. Why? Why does the tobacco? Because people have a habit and they can't break it. So we have to change habits. Time and resource. So we've heard today and we've experienced the pandemic was a nightmare for us. We launched our product about 2 days before the first lockdown. So we couldn't get into a hospital for 2 years. And since that point in time, there's been a hangover. There's been another 12 months where people have no bandwidth. It's not their fault. It's not their problem in some respects. They're still trying to put fires out all the time. And in doing so, they don't have the bandwidth. You know, it's difficult for them to actually even contemplate doing something new. And then fear. Fear is a huge driver. We know, and it's understandable, don't get me wrong, we understand it, but does this device work? How do I know it works? What if I get it wrong? What if I can't remember how to use it? All of those things build up in people's mind to make it really, really difficult. So these are the things that we're up against, and it makes change a real problem. So how do we as industry rebalance? Because it is our job to do this. We're not blaming anybody in the healthcare environment. We know the challenges. It's our job to make this happen. So we take that responsibility and we take it very seriously. So what do we need to do? Back to the balance again. Vision. It's really important in any change process. And you know, I'm not a change management expert, but if we create a vision of what life will be after implementation of a new product, and we can make that realistic and compelling, then we have a much greater chance of people understanding why they need to move this forward. The next thing is support. So support, we know from the TriTech study that we did, which is such a valuable piece of work. I can't emphasize how much we learned from that piece of work. If we support properly, if we support well, and we've actually reorganized our business on the back of this, when we do an implementation, we have people with their... How did that come in? Oh, okay. We have people on the ground. We provide somebody to stand by the clinicians as they are using the device. So when we're doing an evaluation, we'll have somebody on site supporting the clinical practitioner who is doing those tests for 2, 3 or 4 weeks. It costs us money, but it helps to provide the bandwidth, the reassurance, all of the things that we know that are absolutely necessary. So support is key. Then there's trust. So we are dealing with people's lives here, so people have to trust. There we go. People have to trust what they're seeing. So we've engaged with people. So engagement at the point of development. We had a team of 8 senior clinicians who were all involved in this particular area of expertise that helped us develop the product. We didn't have a bunch of engineers thinking, what can we sell to somebody? It was, what do the clinicians need? So engagement was absolutely vital. Evidence, having evidence to show that our device is trustworthy. We've got thousands of hours of bench testing. We have a clinical trial. We now have probably 10 or 12 separate evaluations that have been done in various organizations that give the proof that our device is reliable. It's more reliable, significantly more reliable than the current methodology. We also have experience, and we're open and honest. Now, the final one is cost. Now, this is something that we use to create the tipping point. It is not the main event. The reality of it is, though, if a new method of doing something is more expensive than the existing method, even if it's significantly better, there is automatically a barrier to entry. So we have to make sure our health economics work, and that there's actually a benefit from a cost point of view, an efficiency point of view. You know, we are about, I mean, what we do actually reduces bed stays. We have evidence to produce, that we can produce to prove this. It reduces delays to feeding patients. So a patient in our clinical study, they waited on average 4 hours. If they couldn't get an aspirate, they waited on average for 4 hours before they could receive any nutrition. That's a long time, especially if you're ill. The longest one was 72 hours. So, you know, this is just not right for patients. We reduce that very, very significant, so we improve the outcomes for patients. So what is it about again? So it's about this adoption and innovation. It's about us finding the innovators and working with those innovators. And fortunately, there's lots of them in the room today, so hopefully I'll be talking to you. Certainly 2 of you already. So yeah, it's really about us working with academia, with the health boards, with government, to actually show where we can provide this value and then support that value. So what happens if we don't embrace change? There's some really good examples there of people that fail to embrace change. You've probably seen them all before, but you know, it's a really graphic illustration of what happens if we don't move forward. But more positively, what if we do? Improve patient care. You know, our business is about patient safety. The reason we have this invention, which was, as it happens, invented by a Welshman, Sean Thomas, who is still with us in the company. You know, we get better patient outcomes. We improve the span and quality of life. We improve safety. We improve efficiency. I'm not just talking about NG Pod at this stage. I'm talking about innovation in general. You know, we have the efficiency drivers. We're talking about the pressure that's going to be on the health service, the aging population. Fortunately, it was in one of the first speakers' talks that we have to drive efficiency, otherwise it just will fall over. And improve working environment. So this is our colleagues. The stress involved in getting something wrong is enormous. If we can reduce that or remove it, we're creating a much better, less stressful environment for our colleagues. So how do we make change easier? So this is a very one-slide change management process for you. So hopefully you'll take it away. So reframing your mindset. This is, you know, seeing change as an opportunity rather than a threat. Really difficult to do. Very easy to say, but very difficult to do. So finding ways to move from uncertainty to certainty. This is where the evidence comes in. This is where peer-to-peer discussion comes in. Expanding comfort zones. Like me standing here is expanding my comfort zone. Thank you, Professor Chris, for inviting me. It's not what I normally do, but there you go. Seeking support. You know, there's people that are there to help support, to drive. You know, they want things to happen. And that support comes from an organisation, comes from colleagues, comes from industry. Use it. And do it in small steps. Big leaps are very difficult to do. Small steps are much easier. So do it step by step, pace by pace, and you'll get to the end, you'll get to the top of the mountain. And then by making change a habit, get used to change. Get an organisation used to change. Get them open to change. Thank you. I would love to know how we can do this better, because it is very slow, quite painful, but we have something that's very worthwhile that should be being used. I would love to know from you what your ideas would be. So thank you very much.
Thank you, John. I should have noted actually in John's bio, it said he started his first business when he was 23. So about 5 or 6 years ago, was it, John? No. But the key thing from John's bio is the fact that it's progression, it's innovation, it's challenge, it's not being settled with the status quo. Basically, your presentation, which I thought was very good. Although I did make the mistake of checking out what some definitions of pain and how people respond to pain. Anxiety, headaches, stress. I'm feeling it already. Our next speaker has come a long way, and I won't embarrass her too much, but I will embarrass her a little bit. So Anna-Marie Saarinen, Chief Executive Officer and co-founder of Bloom Standard Incorporated. I'll just read some of Anna-Marie's appointments. Appointed by the US Secretary of Health and Human Services under the Obama administration to the Federal Advisory Committee on Heritable Disorders in Newborns and Children. Anna-Marie also serves on the Every Breath Counts Coalition, the World Health Organization Medical Device Technical Series work group, the WHO MNCAH Research Network on COVID-19 in children, the board of the Pediatric Device Innovation Consortium, and is co-chair of the Newborn Foundation Research Collaborative. But I'd say to top that off, she's a very proud mum as well. So Anna-Marie, please come to the microphone.
Good morning. Bwrdd. It's bad, isn't it? I'm working on it. Thank you for that very kind introduction. Yes, it is embarrassing. So if I've got a flush in my cheeks, it's because of that and potentially just lack of sleep and, you know, rolling off the airplane and getting on the train. And what a great talk to follow. In a good and bad way, right? I don't know about my slides, just know I sent them en route, so thank you, technical team, but there could be just a few messy things there. I've just come from the Grand Challenges annual meeting in Senegal. I went home for a week, so my children are yelling at me about leaving again. You know, what an inspiration to apply this global health lens to all of the ideas being shared already here this morning. And I actually made a note here because I didn't have a slide on it actually, but I met the director of the Africa CDC, and he mentioned in his talk that even when you have a product, you're halfway to having a solution. I don't know if it's his quote or someone else's, but it's quite good, isn't it, that we're all facing the same challenge. And it truly is about my favorite buzz term, implementation science. And implementation science has to cover all of it, all of it. You don't get to just be a great product person or a good CEO. You have to be a lobbyist and a diplomat and an advocate. All of those things matter. Without it, you don't have trust, and without it, all of the amazing work happening here can't see the light of day. So thank you, by the way, to Sean and Chris and Ian. I think Emma Reese from Swansea is probably here, so somewhere. Hello. Really, one other thing on definitions. I use the term colleague very sparsely, because to me, colleague means something more than collaborator. It means you've reached a stage that you have a real trust fabric and what I would refer to as friendship. And I'm grateful that so many people in this room, after just less than 2 years' time of Bloom Standard expanding into this ecosystem in the UK and having a headquarters here in Wales, that there are many people in this room that I can now call colleagues, and I'm very grateful for that. Okay, so for who doesn't have a little bit of a background on the foundations of Bloom Standard and the Newborn Foundation, really, my NGO work prior, this is my daughter, Eve, and she was diagnosed in heart failure at 3 days old, but completely asymptomatically. So we were to be sent home from the hospital with a baby that we thought was perfectly healthy that wouldn't have survived to her 1 week wild child visit. So if that isn't motivation, I'm not sure what is, because she still was able to somehow persevere for those very critical first weeks and months, but really only because we were lucky enough to have access to a few critical diagnostic tools, a couple really smart nurses and frontline care pediatricians, and then of course the team that rallied around her at 4 different institutions to save her life as the youngest baby probably on the planet to have a heart ablation at the time and then survive an open heart surgery. So that led to a really interesting journey for me. I was already working in health tech and med tech. I'd already done some public health research, and I'm a health economist by background, but this is a space that was very near and dear to me, especially pediatric and rural medicine. So when I had this really profound personal experience with my daughter, I kind of leaned all in on like, what can we do as a community to advance earlier diagnosis of conditions that now have a solution, treatment, cure, pathway, whatever that may be, but we're not finding the conditions soon enough, or we're not appropriately diagnosing them. So in the newborn screening vernacular, we call this the diagnostic odyssey, right? There might be something a little bit off, but then parents are bumping around to here and there and everywhere before they can really find out what's wrong. And since you mentioned the Newborn Screening Committee, I also serve on my own state of Minnesota, the Minnesota Department of Health Newborn Screening Committee, and we meet twice a year. And yesterday was one of those days. So I was actually on the Zoom call till 10 p.m. last night, and I'm proud to say the state of Minnesota is now the first state in the country and the first place on the planet to implement universal screening for Duchenne muscular dystrophy. I say that because it took a lot of evidence and a lot of advocacy to get there, and Minnesota is known as sort of an early adopter on a lot of these conditions, but Minnesota is also an early adopter on newborn heart screening. And today, every baby in the United States gets a newborn heart screen before they leave the hospital. Most babies in the UK get that, but it's not yet required here. And in about 50 other countries, they've either implemented this as a standard of care or are in the process of implementing it across their population of newborns. That uses a pulse oximeter, which tells us only babies are hypoxic. The problem was, in my view, in the United States and elsewhere, that we didn't have the imaging tests that could confirm or rule out a true cardiac pathology. And we're talking about maybe 30 to 40% of infants that have murmurs that are otherwise assumed to be benign in most cases and not ordered for echocardiography or ultrasound of the heart. And this was a real problem because babies are not born in the places where this equipment exists or the technicians to use that equipment are stationed. That's true around the world. So Bloom Standards sprouted out of this sort of unmet need, which seemed acute in my own country, was certainly acute in the UK because I was working with the newborn screening folks here 12 years ago on this very issue, and is whatever the word is for beyond acute in the rest of the world. The global south, any low and middle income country you can point to on the map, of which there are many, actually, 80% of the countries around the world. And so we approached this unmet need by looking at what was already in the innovation ecosystem. Is there a way we could work backwards from solutions that were already there? So some handheld ultrasound was already coming out at that stage. Certainly transducers that could plug into laptops. What if we just got more of those out there and did more and more training? Would that solve the problem? But really, it was an image acquisition issue. Even if you donated all this equipment, it took a lot of skill, particularly to image young, tiny patients. So we tried to tackle this from both sides. Yes, AI. A lot can be done with images that are already being captured on these devices that are currently in play. But what about image acquisition? Could we automate it through a sort of self-driving transducer? And so we needed to go from this equipment on one side of the slide. That is what my daughter is seen with when she goes to the hospital. Like, it's really expensive, folks, and it's really big, to something that's really tiny, super intuitive to use, and serves not as the diagnostic for a 45-minute echo scan done by a truly well-trained technician or clinician, but a diagnostic aid for those on the front line of care, and you've heard that many times already this morning, bringing these tools to earlier in the patient stream. I don't know if these videos will play. I don't really know how to do it. Do you think so? I think they're quite short, and I feel like I've talked a lot already. So I wanted to bring you into the settings where my team works and where we're designing our technology for, and then how we kind of are using this backward approach of designing it for the most resource-poor settings, which in most cases makes it super convenient for the places that actually have higher resources, but bringing it out to rural and frontline care. If these don't work, that's fine, but we can try it. Shall I just? Oh, it does. Okay, so we thought before was no echo. So the regular pediatric ward doesn't run on echo. So they have a 20-year-old echo machine that they can move around here in pediatric emergency intake. And then they have about a 15-year-old echo machine up in the NICU, which is better than what most places have, to be fair. But generally speaking, those units they're going to stay pretty stationary here. So for a hospital this size with 3,000 beds, it's not going to address the capacity issues. But for a study, it's good that they have these two machines. Okay, so it was a little bit hard to hear in the beginning. So I think what I was saying there is we're walking into this room at the second largest public hospital in India. They have two functioning echo machines, semi-functioning, one functioning, one semi-functioning echo machine in the hospital. This hospital is a 8,000 bed facility, takes care of the newborns, the peds, the critically ill babies as well. And the fact that they have one is a step up for most of the rest of the places that see children in this part of the world. And so we further went into, and I wanted to shut off my phone because we're going into their version of an echo lab. But you know, this was my first opportunity to bring my engineers into a low resource clinical setting. Prior to this, they had been doing all of the development work and co-development work in higher resource settings, which is very normal for product development, right? This is how we do things, is at the tertiary level, and then you sort of work your way backwards. Two reasons for that. One, that's your patient population is there to get the data, and then two, you have to be able to have kind of those critical stakeholders at that level buying into your technology. Goes to the point said earlier, but this is where words matter when you're working on products pre-deployment. In the global health world, there was a lot of terminology around task shifting, and I think that is not very well received among cardiologists, neonatologists, radiologists, right? It's task sharing. We're trying to not only ease their workflow, ease their burden, but get kids to them at the right time. They are every bit as needed. There's nothing that's going to take away from their burden of patient load. It's just getting the right patients to them at the right time. So this task sharing idea versus, oh, we're coming in and we're trying to take something away from you is pretty important. This is the same hospital. So this is our actually our V2 prototype. So it looks a bit different today. That was being seen in outpatient clinic that day. We saw, I can't do it from this angle, 8 patients, I think that first day. This is the chief of pediatrics and one of the lead research pediatricians that's trying to just get some basic views. We were looking at that point at an apical 4-chamber view of the heart and a subcostal view of the heart, which are the two best windows for early, the simplest interpretation of what's going on with a cardiac, potential cardiac patient. These were all non-cardiac patients, by the way, but we're just trying to see them going through intake. I'll tell you, one of the children we saw that day, I don't have that slide in here today, but she was a 3-year-old that was in the hospital for diarrhea, and we happened to have her consented into workflow that day, and she was diagnosed with multiple ASDs and VSDs, which are essentially holes in the heart. She would have been sent home on diarrhea medication. Instead, she was scheduled for surgery within the next 2 weeks, and she's alive today because of that lucky find as part of our screening group.
Okay, morning of today because we're moving really fast. We're seeing babies that are very tiny and quite sick, and so our sense of frequency is going to need to get bumped up a little bit if we intend to do babies under, I'd say like under 3 kilos. It's going to be pretty low. Probably not our first target anyway, but it sure would be nice to make sure we have that option kind of moving forward, to be able to screen the smaller babies with the cardiography. So that's some really good feedback on form factor and capability to particularly get a subcostal view, which is one we know that we'd like to get, but the long axis, short axis, and apical view is still looking pretty good, especially on the ones that are above 2.5 kilos. So moving to the pediatric ward right now from the NICU, and we'll get a couple of check it out.
Okay, that also sounded really murky, but essentially I was trying to explain, and I do these recordings as much for my internal team as any external use, so they can hear like what I've really just walked out of a unit and heard from the doctors, because I don't tend to record as much when I'm right in there because I'm actively listening and taking notes. But basically what we were seeing in the NICU, because there were several premature babies, as one might expect in the NICU, that our sensors were not performing as well on babies under 37 or 38 weeks gestation. So under 3 kilos to 0.8 kilos or so. So this was a challenge for my engineering team to say, okay, look, what are we going to do with our chip-based sensors to optimize for this, because there's no universe where we deploy our technology into a setting like this in Delhi or elsewhere in India where it's not going to be used off-label. That is a fact. Nothing is going to change that, especially in LMICs. And so we need to account for it because it's going to be used on those little kids, and if all we get is a murky mess, then we're not really helping anyone. Okay, thanks for bearing with me while I showed a few of those. So I'm going to move pretty quickly from here on out. Get on the business side of things. Look, okay, I am not a CEO by nature. This is, I'm sort of an unlikely CEO, but I love being a CEO because I'm not an engineer. So I get to go to my engineers and my clinical scientists and researchers and ask for the impossible and do it with a smile on my face. Like, you can do that in a week, right? And they really can't really even get angry with me for asking, because I can just play the, like, I'm not an engineer, I don't know any better. I don't know how long I can stretch that out, but I'm just gonna keep kind of rolling with it for right now. But we're raising funds, right? Non-dilutive funds, and then you get into this other capital raising world, and there's nothing a true blue Midwesterner hates more than raising money. We hate asking for money. We almost hate asking for help. Fortunately, I'm a lobbyist, so I'm a little bit okay. Like, I can go in front of Congress and ask for stuff, and I'm okay with that. But, you know, asking for financial resources is really hard, and I've had to, it's a quality that I have to work on every day, because I realize it's part of the game. It's part of what we have to do to make sure we don't end up in one of those valleys of death and not be able to get out of it. And so I show you this slide because for the last 2 years or so, since we started raising any outside capital that's not non-dilutive or grant-based, we get asked the question like, well, what's the ultrasound market? How big is that market globally? It's quite big, actually. But that's the wrong question, because we're not trying to compete with Philips or GE or what's the known ultrasound market, right? We're trying to get into primary care We're trying to get into all the places where ultrasound is currently not sold nor evaluated as a market opportunity. And so I created, with the help of a couple of my advisors from Medtronic in the US, this sort of slide, which is not very pretty, but I'm trying to get my outside people that are new to Bloom Standard, their heads around this idea that traditional ultrasound is part of it, but it's more about POCUS, and it's more about the AI potential, right? Like, these are all markets that are converging around new technologies that can leverage unique and simple and low-cost ways to do imaging on the front lines of care with a software overlay. This is just a quick shot of I wish I had a prototype with me in a way, because it'd be fun to show people who come up afterwards. But in true startup fashion, all the prototypes we have are in clinical studies right now in different parts of the world. And in November, we will be putting out 4 more prototypes, which is a huge thing for us. It's expensive. You know, they each cost more than they should, but this is the world you live in when you're going from, you know, where you are, which is proof of concept, feasibility, validation, into that pre-commercialization stage. But our sensor, I wanted to show you that one because those little dots on that chip, each of them are a beating drum of ultrasound. We can't program each of those tiny dots, but we can program them as the lines, like, right? Think of them as pearls on a string in a way. And that gives us a lot of forgiveness. That's what allows this type of ultrasound to serve an sort of frontline and unskilled in ultrasound population to be able to work with patients in a way that traditional piezoelectric crystal technology, which is in all the ultrasound machines you see now, is kind of unable to do. And then on the AI and imaging side of things, so we have a hardware solution and a software solution. Those are 2 different regulatory pathways. They will be here as well, just like they are with the FDA. But each are important, and we can't really deploy into resource-poor settings until this AI clinical decision support software piece is validated and on board. Because if we deploy into those settings, and we expect the machine to tell a frontline user whether a heart or a lung is normal or abnormal, and they can't trust that answer, meaning they refer a bunch of kids that really have nothing wrong with them, or worse yet, they don't refer a kid that has something wrong, then we've got a problem. And you'll immediately undercut your whole business proposition, especially when you're a business-to-government solution in the case of these countries. So we came here having done kind of our market entry plan into these different regions around the world. And I just wanted to give you this timeline about when we landed sort of in the UK and set up our partnership in Wales with the Institute of Life Sciences. And I think from here is when I started mapping out like all the acronyms for Welsh partners and learning what each of those like letters meant. Fortunately, I know almost all of them now, which is amazing. And it's good to see so many faces from the organizations who have gone on to become critical partners. And also, coincidentally, that Bloom Standard has one of our core engineering offices is at Texas Medical Center in Houston, which has a bio-bridge to Swansea, which is like, again, I didn't even know that till we went down to Texas Medical Center. They're like, oh, you're at Swansea, we have a bio-bridge. And I'm like, oh man, that's a small world moment. But we can all, I think this ecosystem ought to be very, very proud of what they're able to do with a startup coming from another part of the world to establish their European presence here in Wales. It's quite remarkable. And I've shared this example with our own kind of med tech ecosystem in the Twin Cities, which is very heavily medical device and cardiac. And we have like a Medi Wales in the US called Medical Alley. And I keep telling them, I'm like, you guys can do better. Like Wales has got it dialed in. And so this is our sort of global health map of where we're working right now. And as you can see, Wales is there on the map. Okay, so this is where we're going to get real. This project we want to do with Swansea. It's a 2-phase project, which will be here and then also in Cardiff. we're almost a full year from originally kind of scoping this out and then having some support from Accelerate. And so I'm here to learn, actually, more than I am here to speak, because I don't think the clinical partners we have at Swansea or my team thought a year later we wouldn't have moved quite as far, at least on this piece of it, than we have. And there are a number of reasons, learning curve, administrative burden, like there's just a lot to it, right? But I am telling you, we would be nowhere without the support that we've had, but we have a long way to go. And after, sometime during lunch today, I'm gonna have a talk with Chris and Emma and the team about, like, there's a balance between being aspirational and being realistic. So, Chris, because we were like, yeah, we're gonna do this IDAP thing, right? This regulatory, like, it's gonna speed us along, and we learned about it when they did the very first pilot. So we thought we could take some of our documentation that we've done for our MHRA, for our medical device, and just flip it over to like, oh, we'll do this IDAP application. And then I've got my team in Hong Kong telling me like, we're not ready. We're missing like 3 key pieces. There's no way we can submit for it. And I'm like, look, I got Mr. Aspiration over here, says 100% Bloom Standards ready, we need to do this, and it's gonna smooth our pathway in all the ways that sort of matter. And I got my team being like nervous. They're like, no, these 3 things are missing. So this is where, you know, these tools are available, but if you can't be realistic about whether you can tick the boxes, and because we're resource limited, right? We can only do what we can do. And so these are the tools that we've been sort of looking at in Wales, right? They cover the gamut of hardware development, co-development, the interoperability piece. Can we send images remotely into the hospital for review so that we can refer patients versus doing that online on-board clinical decision support with AI? And then my dream is to do a global health pilot here with the team that we already have in place. And I think we'll get very close to that once we get going at Singleton and Cardiff. Okay, oops. Did I bump ahead? Okay, so these are just like a few little, because I'd be wrong if I didn't highlight like all the cool things we get to do in Wales and UK with the partners here since we've been here. And that was an Accelerate event from last fall, and then last spring, our COO, Jake, got to do BioWales in London, which was really cool. And then when I was here in the summer, the Welsh government did a really nice video feature. So if you go to Trade and Invest Wales, there's a super nice video there. I look terrible in it. But I'm just like, but it's, I mean, I'd be like, I'm not showing a picture of that. I look terrible in that video, but it's a great video. And I'm thankful to the Welsh government for sort of fostering us and mentoring us along the way. These are the 5 things that we're working on here and in our remote offices. So we've got hardware engineers now in 3 locations around the world. We want to have hardware engineers here in Wales, and so I hope that by early of next year that we can lean into some of those resources and actually start growing our team on the ground here in Wales as we move towards manufacturing. I know it's probably pretty hard to see that, but I had to put together this snapshot here of our current clinical investigations. This was submitted to the FDA as part of our breakthrough device designation package. That went in September, and so by US FDA standards, the clock starts ticking. We should know within about 60 days whether or not our breakthrough device designation is going to be granted and that they agree with our predicate pathway for our 510K. And in the US then, what's the equivalent to 510K with MHRA? It's a class 2 MDR, okay. So that is closer to a 5 to 6 month timeline. So sometime in 2024, right now, the plan is that we can get FDA clearance on our hardware first technology while we keep optimizing our machine learning algorithms to get that software submission in. I shared this probably, I don't know, less than a year ago. This was just me doing a little bit of digging on the Wales ecosystem. And I think what I'm trying to show here with these tiny dots is that of these hospital and delivery sites, the places where babies are born and seen for care, really only about 5 of them have any ability to do in-house echocardiography and have a technician that's skilled to do pediatric echocardiography or ultrasound imaging. And this isn't like why isn't there more capacity in Wales? This is normal. This is the same situation I have in my home state of Minnesota. So bringing, again, task sharing, bringing a primary care ultrasound out into the field in a way where we can do simple 3-minute scans that can tell us whether we need to refer that child onward or not is really our mission with the clinical validation work we're doing right now. These are just our patient cohorts moving forward. This was all 2023 data, so obviously now we're in Q4. We are about 100 patients off the mark for Q3 right now, so we have about almost 300 patients worth of data as of last week. Almost all of those patients are newborns. We do have some patients going up to age 2, but almost all are in the first week of life. And then data will be driving additional regulatory submissions going into the end of this year and early of next year. This is also a slide I developed for an earlier presentation, I think this summer when I was over at Singleton campus. We have an obligation. We've invested a lot as a company in time and resources and commitment to developing this team and these partnerships on the ground here in Wales. We have a lot more to do, but anything on this list that ends up being like putting a line through it because it's not working out, I would, as CEO, consider it a bit of a failure. So last time I was here, I went around to tour some manufacturing sites. What can we do, even if we're getting our chips are being supplied from a company out of the Netherlands that you probably are familiar with. And then our boards, our custom boards, are in the US. So can we still do manufacturing assembly here? There was a reason this made sense for us in terms of both our European deployment and our deployment into Asia Pacific. And so all of these are so far, nothing's been checked off the list. All these partnerships are intact. But having a new fully funded PhD at Swansea is an exciting breakthrough, and she's here. Yay, nice, thanks, Megan. And she's gonna be busy, like really busy, so buckle up because you're gonna have a lot of fun. Okay, so the rest of these are just sort of images, I think, to close it out for me. This was this is probably our 4th scientific poster session. We are submitting our first manuscript in December on early data collection. I think this is the first time we have seen a paper published that's demonstrating the correlation between hypoxemia, so pulse oximetry values, and an abnormal finding on echocardiography, all under the premise of rapid scanning, single view, single placement, which is the whole like holy grail for us is our users don't have to move the probe around. They just place it, hit a start button, and the scan tells us whether we have something normal versus abnormal. So this was really exciting, partly because I got to share it at grand challenges in front of people I really trust and respect, and that Mr. Gates stopped by my poster session, which was kind of cool. He stopped by many poster sessions. I would say he's a nerd. Like 3 hours, Bill Gates was in the posters. I'm not kidding. Like he was really like all sorts of, all the questions, which was great to see that. It wasn't just a photo op. And there's real commitment there on the part of global health to advancing medical devices, biotechnology, to provide a meaningful impact in the places in the world that have the greatest need right now. So I think that is all I can share today. I'm going to try this. Diolch. Thank you. Wait, say it for me because it's diolch. Thank you so much. I'm happy to talk to anybody after the session's here, and thanks for inviting me. It was really a pleasure.
Well, I'm just thinking earlier in Anne-Marie's talk about when she used the phrase low resource clinical setting. And I think we've got nothing to complain about in many ways, have we, in terms of the kind of innovation that's been achieved and deployed around the world. Our final speakers to close out this session, I think it's a double act, Sean? Triple act, okay. Okay. Well, if I introduce you and you introduce the rest. So leading the next session, the next speaking is Dr. Sean Jenkins, who's Research Director for ATiC and been with ATiC since its inception, in fact, before its inception, and is now leading the team in Technium 1, just across the sail bridge there, and will be leading the team as it makes its new home in the innovation matrix in the new year. Sean.
Hi, good morning everybody. So first of all, in the interests of true collaboration, this is a three-way session, and myself, Billy and Mark from Swansea Bay. We're going to be talking to you about an initiative that we've developed over the last 12 months called Wales Innovation in Rehabilitation Engineering Network, or WIRE, thanks to Mark's innovative name-calling abilities. A few people have said to me this morning that they're a bit nervy about doing a presentation. It's the first time since COVID. They've just been doing stuff online, or it's the first time they've ever done something in front of an audience like this. I was told that it's always a good idea to try and think that you're talking to somebody you love in the audience, and it kind of puts you at ease and it relaxes you. So today I'm going to be talking to my 8-month-old grandson, Ren, and my 2-month-old granddaughter, Bonnie. So, got a smile for Grampy? They should be watching on the live streaming. So, and obviously you can tell it's about my age range. Yeah, WIRE. So just a brief kind of introduction to ATiC. We've been operating now as a research centre, formerly part of the Accelerate programme, but still working with partners on that programme. And over the last 4 or 5 years, we've worked with a range of different industry partners, third sector partners, and NHS partners. Some of those, since we've transitioned out of the RDF funding, some of those have stayed with us, and we're continuing to work with them and building sort of longer term collaborative relationships. And it's collaboration and partnership which are really core to the team in ATiC. And during the course of that, we've developed some sort of specialisms really, and this is just to give you an idea of the kind of things we do. We've got 4 key pillars, ranging from behavior and psychophysiological measurement, movement and physical performance measurement, 3D reality capture, modeling and virtual simulation, 3D design, additive manufacture and prototyping. Sounds like a lot, and it is, and if you want to chat to us later about sort of what those things involve, then please speak to my colleagues and myself. But fundamentally what we do is we're interested in how people interact with things. So they could be medical products, services, systems, or spaces. And all of those pillars of sort of research capabilities and activities let us help people like yourselves develop those technologies, those innovations in a way which fits people's needs. And that's fundamentally what we do. We're kind of design research driven. So there's a lot of designers, architects, visual artists on the team, but also we've got clinical engineers, human movement specialists, human-computer interaction scientists, and so on. And the collaboration with TriTech has enabled us to kind of overlap and with that clinical expertise in sort of research trials and medical device approval. So it really brings a kind of a balanced approach to undertaking innovation evaluations, which is fundamentally what we do across those sort of those sectors along the bottom there. So during those conversations that we've had over the past few years, we've got to know the rehab engineering units. Started off with Swansea Bay and Dr. Mark Botel and Lorna Tasker, who were our sort of first point of contact, and then extended that to Cardiff and Vale and Colin and his team there, and then up to North Wales more recently with John and Betsy Cadwalder. And what we realised was there's a bit of a challenge. Like anywhere else in the NHS at the moment, there's a bit of a challenge facing those teams in terms of their capacity and their ability to meet the demands on their services. There's also a high degree of creativity and innovation within those teams, but the clinical demand is kind of preventing them putting a lot of their really, really good ideas into action. So we proposed that we build a sort of network to support that. So we were lucky enough to get some funding from the Wales Innovation Network. And over the last 12 months, we've been able to develop that network, and we're going to present to you today some of the sort of initial pilot projects, and my colleague Billy Woods is going to talk about them in a little bit more detail. And then Mark's going to bring you up to date with the project that we're supporting in Swansea Bay University Health Board. But the primary objective of this is for us to bring together academics, industry partners, third sector, and NHS partners, not just within the rehab units, but the broader sort of ecosystem, to try and support innovation in this specific area. And then if we can prove that that works, then start to build this and roll it out across other areas of rehabilitation and other challenges in the community. So we've been working closely over the past sort of 12 months to identify the challenges. So we've been working with the rehab units, we've been working with their leads and their teams to try and understand where the challenges are, what the bottlenecks are in the patient pathway, and how we might start to develop research strategies and innovation strategies to overcome those challenges. So we're in the process of finalizing a white paper, which is based on that activity, lots of interviews, lots of co-creation workshops and things like that, and we're hoping to publish that very, very soon. So, yeah, watch the press on that one. But the underlying reason for this is to actually try and develop sort of clusters of supporting networks throughout Wales that can actually provide services and help some of the innovative ideas that the rehab teams have actually get through into deployment. So, and yes, this will take time, but we've been working sort of in parallel with that, the research we've been doing with on the white paper, and building up some momentum around potential funding opportunities in the future. So we ran some co-creation workshops earlier this year, as part of a proposal for a place-based impact accelerator account, which is ERDF funded, EPSRC funded call, which will be coming out again shortly, and we'll be submitting a bid in March next year. And that's bringing together Accelerate partners, so we've got Cardiff Uni, Swansea Uni, Life Science Hub Wales, but also some new partners, so Swansea Metropolitan University, University of South Wales, potentially Aberystwyth and Bangor. So what we're trying to get to do is bring together all of these academic centres, but also bring together some of the industry partners as well in the region, so that there's opportunities then to take some of these innovations, test them out in clinical scenarios, and then quickly develop manufacturing opportunities and deploy those. So it's a really collaborative idea, and we're pushing ahead with this. This is very briefly a kind of summary of where we're at the moment. We've identified some key research objectives to try and meet with this network, and as I said, we'll be working together with all the stakeholders over the coming months to prepare a bid. This is not a complete thing at the moment, and it's going to keep evolving and keep changing, and we need people to get involved and contribute their ideas to this as well and become part of that network. So as well as putting in the funding bid, we're also going to be developing initiatives and other opportunities to build this network, and you're all welcome to get involved in some form, and we'll be putting a call out for more workshops in the not too distant future. But what I'd like to do now is pass over to my colleague Billy, who's going to talk about the pilot projects, and I'll get out of the way.
Brilliant. Thanks, Sean. So, as he's already mentioned, I want to talk through a couple of examples we've got so far of work that we've been able to get involved in as part of this wire network. They are early stages at the moment, so sort of like one of these projects I'm going to mention is something we're more directly involved in, but we just wanted to give examples of how we can and we will be able to add some value into the wider network moving forward. So the first one of these projects come out of the Rehab Engineering Unit in North Wales, so Betsy Health Board. I haven't got pictures from them, unfortunately. They brought down some examples of prosthetic fingers and toes that they can make. Really incredible. I'm not going to be able to do justice to the level of detail of the things that they were making. They were showing us these examples in the lab. They come to visit us in ATiC to show, and they can colour match. They can use various grades of silicon to match different textures and densities. Really, really detailed, really clever. They can match it to skin tone, and they can grade the silicone and all sorts to make it really lifelike, so at a distance you wouldn't know it as a prosthetic. The problem with that is they were explaining to us that the process for them making these prosthetic fingers and toes is very time intensive. So the prosthetist, I hope I'm pronouncing that right, was explaining that his process for essentially hand carving these out of silicone can take many days, so it takes a long time, and because it's aesthetic in nature, they don't always get the resources and time they need to make them. So they were telling us that they're kind of doing it as and when they can, really, to help patients out. They really want to be able to support more of these patients more often, but it's hard to argue to get that time on top of their clinical work if it's going to take them several days to kind of make these prosthetics. So while they were visiting the lab, the conversation went on to, would there be a way of rapidly prototyping these fingers and toes so they could do that kind of work a lot faster with a lot less resources, so then they could argue that they're able to help these patients more frequently because they're not using as much of their clinical time. So Nicholas Thatcher and Ian Williams so far have already begun working on this. So they sent us some pictures of some examples they've been making so far. So they talked us through the process that they're already doing in the way that they're producing these prosthetics. And then to Nick and Ian are now looking at, you know, what scanning methods can get what level of detail, which kind of 3D printing technologies or materials that they print in can get close to or similar level of detail as what they're already doing in silicon. So this is an ongoing project at the moment, and the end goal would be to be able to say to that team in North Wales, this is how you could do it a lot faster with a lot less time and money, so then they could argue that they can help more of those patients without affecting other clinical duties. Another project that we're involved in, less hands-on but more kind of facilitated at this point. So Dr. Stephanie Wentworth from Cardiff and Vale has previously set up a mobile arm support service for patients that have got muscular dystrophy, motor neurons disease, and other neurological disorders, which has meant that they're unable to use their arms as much for activities of daily living, things like feeding themselves, brushing their teeth, and other activities like that. She's provided a picture from one of the patients she's previously worked with, and this patient's got a couple of arm supports that's attached to a desk. These arm supports can help these patients kind of reach their own mouth so they can still feed themselves and brush their teeth and things like that. But she was talking to me through the issue that the commercially available devices at the moment aren't always fit for purpose, like they can get them, but there's the range of things on the market isn't very good at the moment. So ideally they'd like something developed that's a much more fit for purpose and fit for these patients and what they need them to do. So moving on from that, and in the spirit of the collaboration and the wire network and also the symposium, this one that was done last year, so Iterate Design, they're a design consultancy, design firm. They did a talk last year about a mobile arm support, or an arm support anyway, that was being developed, which is that video on the left. And as a result of seeing the talk at that presentation, Stephanie and Colin from Cardiff are now talking to Iterate Design around the prospect of developing a new sort of, either developing this design further or doing something completely new and fit for purpose for this mobile arm support service. So we're joining in at the moment. We're helping develop those conversations. We're exploring ideas around how we can help get funding to support that kind of work. And this week and last week, recently been having conversations around putting in for an Innovate UK bid to get some funding to now Iterate Design to actually, bring that a step forward, and then we're going to help implement all of that. So that's two very brief descriptions of projects I'm working on. I'm now going to hand over to Dr. Mark Botel from Swansea to go through his project as well. Thank you.
Thank
Thank you, Billy. Thank you, Sean. I always remember the first time I went into a care home as a young rehab engineer with a nursing colleague. We were there to assess an elderly lady with a pressure ulcer, and she had quite complex posture. She was sitting asymmetry, and she was static. She would be static for many hours, often in that same habitual position. And the problem was, I'd look around the room, and I'd see there were 15, 20 other people in exactly the same sort of problem. They were static. And so this problem of immobility is something that's always struck me. Immobility is the largest risk factor when it comes to pressure ulcers, but as I'm sure you're aware, it's responsible for a lot of other problems as well. And the thing is about a lot of these people, these are the ones that are mobile in the care homes. They're the ones that can get to the lounges. They're not bound to bed. And despite their ability to move, maybe aided or unaided, they are static. Pressure ulcers are avoidable, yet they make up for approximately 4% of the NHS expenditure. So there's huge costs to the health service, health and social care, as well as, I'm sure you can imagine, a huge cost with infection and potential death from these wounds. So we set about recently thinking about how can we change this culture in some small way. The brief was to look at a tracking system to provide early warning of immobility. So just to inform people what's going on in their environment and how they can be aware of immobility. I'm aware that I'm doing this probably perfect timing in this agenda because we've been sat here for at least 2 hours, and my 5-minute slot. I will rattle through through this, but I'm sure you're aware you've been moving a lot, but it's not always as simple as that for some people. So it's about us informing, engaging, empowering, a common theme. But as well as us doing something about reducing the amount of pressure ulcers in this sort of setting, we want to improve carer confidence as well as patient experience in general. So we set out with a goal to find out what they want, not just what we thought was important. So a period of discovery to understand, to explore, and to validate our ideas, but to explore what their solutions might be as well. So I won't go into the details here, but a couple of things to pull out is that there's poor engagement from the people themselves, and this is one of the key reasons we wanted to target care homes, because we recognise that that they're not people that wear smartwatches and things like that. So we wanted to look at ways that we could support that environment. And the other thing was that it should be non-disruptive, and we didn't want another alarm going off in an otherwise potentially quite peaceful environment, and that was very important for those that worked there. But we're seeing times of immobility of up to 8 hours from some of the people that we were observing. We also talked to professionals, and a couple of key things from this is that they wanted to make it clear again that an alarm, we don't want to be just providing care when an alarm goes off. So we don't want to be just being responsive. We want to be making sure this is part of an existing culture and not just alarm based. And so we thought about that challenge a little bit further. I'll come on to that. And we want to enhance regular, reliable care for the many. Well, this is a big question, really. Do we do it for the many in that care home, the 15, 20 that we're talking about? Or is this something that's specifically prescribed to an individual that we have recognised is particularly high risk? So a few questions. Like any good engineers, we did some technical scoping, and ATiC were involved in this. We had some very common key requirements of the technology. We looked at different approaches to measuring movement. As you can imagine, on the person, a very common Internet of Things type approach, on the seat, or maybe remote and visual, and that's where my initial thoughts were going. But in the end, we honed in on the fact that we wanted to be using sensors on the seat, because that's more closely related to what we're interested in terms of the loading, the posture and the pressure when it comes to seating. Skip over that one. Around this time, met the wonderful Joe at a startup company called SitFit, based in Cardiff area, and they're doing something similar, but with office seating. So watch this space for this technology for those that are sedentary in their office seating for periods of time, giving you information about not just sitting time, but about posture and mobility requirements when you're sat at the desk. So we thought, okay, let's integrate that. Let's get the hardware we can develop our own software that's fit for our application. Let's integrate it with Common Cushion interface. So we've only just in the last few weeks developed a very simple API communicating with cloud and an Android device, which will be an always-on display. This is just a proof of concept at this stage, but we're excited to try it in the care homes. This is what it'll somewhat look like. And it's just going to be a background early warning, if you like. This will turn red after 4 hours to indicate that person has been static and not relieved their pressure over 4 hours. And as you can imagine, because we've got those sensors, we want to do more with that as well. We want to spot asymmetry developing and that sort of thing, and gently inform the care environment what's going on. So up next is testing, various ways we want to do that, and ATiC are going to be heavily involved in that. Also, we're looking at sort of options for follow-up funding to take this further. And I just want to say a big thank you to, firstly, Arch, a regional collaboration for health, and Sean Charles and his team there, through which we had a very small slice of Welsh Government funding to have a go at this. They believed in the vision. To say thank you to Jenny Brady, who for recently throwing in her energy and expertise into this project and helping out with these slides. And of course to ATiC for pulling together this fantastic wire network. And I'm really excited about the bubbling jacuzzi that's created between us all. Thanks.
So I'd just like to say thank you. I won't keep you any longer because I know the coffee's getting cold. But if there's anything we can do to help out with your innovation journey, then please get in touch. We may not have the answers, but I'm sure that somebody in the room or somebody that we know would be able to help you. And that's the most exciting thing about these kinds of initiatives, is it's about the network that's being created. So hopefully you'll do a little bit of networking now over coffee. And how did Grampy do? Eh? Got a smile for me? So thank you all. I'll speak to you later. Cheers. Delith is Programme Lead for Digital Health Ecosystem Wales at the Life Sciences Hub Wales in Cardiff. And Delith and her colleagues are going to talk a little bit about immersive technology. Thank you, Delith.
Well, good morning. It's absolutely fantastic to be here this morning. I think Sean mentioned earlier people talking about doing presentations. I think this is the first in-person presentation I've had to do for a long time. So it's absolutely wonderful to see actual people looking back at me and not just sort of names on a screen. So fantastic to be here. We've got sort of about an hour or so before lunch to talk about immersive technology, and I'll let my colleagues introduce themselves as they come up. So my name's Delith James. I think we've heard the digital health ecosystem mentioned this morning. I might rename it now to the Digital Health Jacuzzi Wales, because my role really is about finding out about innovation and those bubbles underneath the water. So I'm going to briefly explain what we do at the Life Science Hub as well. But my role is very much about bringing people and systems together. And I really hate that you've just all been networking, doing all the things that we encourage you to do. And I've asked you to stop doing that and come and listen to me. So I hope that you do carry on with the networking a bit later. But I hope you've heard of the Life Science Hub Wales. It has been mentioned a few times this morning, so I'm really grateful for the shout-outs. We're an arm's-length body of Welsh Government, and we really exist to bring together innovation and collaboration between industry, health, social care and academia. We've got really simple strategic aims, and that's to improve the health and well-being outcomes for people in Wales and improve efficiency and value within Wales, within the health and social care system, and drive that economic business growth and development through jobs. And we do this really by creating connections. We support industry engagement, and we work with health and social care in Wales to understand their challenges and needs. I think one of my most favourite parts of my role is talking to clinicians and the people on the ground to really understand what the barriers and the problems that they're experiencing in doing their day-to-day work, and looking for those solutions and innovations to help support them. And we invite companies and innovators from across Wales, the UK and globally to work with us in Wales. So how do we do it? Well, we convene, we bring together the health, life sciences ecosystem, and we integrate and we support a coherent, coordinated, collaborative approach across our partners. We want to accelerate access to that transformative innovation, and we advocate as well, influencing at a UK level, showcasing excellence and opportunities. I wanted to talk a little bit about the support. We've heard mentioned this morning already some of the barriers and problems that industry experience when trying to get adoption within NHS and social care in Wales. And I wanted to talk a little bit about the services that the Hub can offer to help support with that. So we've got project management services, and we've got project leads at the Hub who can support industry, health, social care and academia with particular collaborative projects, providing that additional bit of support. We heard about the issues that people might have around that administration, having processes in place, but we can help support people to do that. We've got a sector intelligence team that produce market reports and do rapid scans. So if you've got an idea that you want some support with, you've got an issue that really needs that innovative solution, if you could come to us, we can have a look at what's currently available on the market and provide you with a report that lets you know what's currently available. We've got business case development, again through our sector intel team. So if you've got a pilot or a project that you've been working on and you're looking to have that adopted within your health board, we can provide some support to help develop that business case for you. And also we've got funding support. So we've got information about opportunities around funding collaborations, and we can provide support through our funding specialists to help you. If there's a Wales collaborative bid, they can provide feedback on those applications and give advice and support that way. Partnership development and facilitation, and that's my role. I think very much sometimes I'm described as a bit of a matchmaker. I love bringing people together, so I work quite closely with clinicians, find out what their problems are, and then talk to industry, quite often at lots of different events. In the last few weeks, we've taken Widdy's robots to Het and talked about the things that are happening in Wales. And just last week, we took a couple of clinicians with us to the MedTech Global event, which was really exciting because we were able to talk about the things that are happening in Wales and really demonstrate the things that we can do really well. Communication, support and amplification, I'll touch on that just in a second. But we also do signposting. So I think it's very rare where we can go into a meeting and we don't have the opportunity to signpost people on to further support or access to different partners. And then we do have quite a fantastic network. We've got a website which we can monitor the number of clicks onto the website, so we hold a lot of information available to people on there. And we've got things like the case studies of innovation that we've been working with. So for example, I've seen on one of the slides today about Pain Check, a fantastic pilot that we're working with throughout the Hub that uses AI and facial recognition technology. So we've got a case study on the website. We've got lots of press releases about the work that we're doing, so it's well worth a visit. We've also got a database of over 3,000 contacts that we send our newsletter out. So if you've got an event or you want some information disseminated, please do come to us and we can pop that onto our newsletters and circulate that. We've got our social media channels, so I don't know if you follow us on Twitter or LinkedIn, bit of a shameless plug there, but please do follow us and see all the different things that we've got happening there. One of the other things that we do is hold some events, and we have a special interest group at the Hub around AI technology, which is a well-established group, and it's been running for a couple of years. We've got about 130 clinicians and academics that join us at that particular group. We meet on a quarterly basis virtually, and we talk about Wales-specific projects that are using AI. We talk about regulatory issues, the barriers to establishing projects, etc. But also we invite industry along to that and talk about the art of the possible. So that's quite an exciting way of seeing what's available and talking to industry and finding out about their barriers and what their challenges are to adoption. So that was a bit of a whistle-stop tour of the Hub. But my sort of call to action from that is really that I'd really encourage you to get in touch. We love talking to people, finding out the things that you're looking for. I've had many a happy marriage through my sort of matching service, and I'd love that to continue. So please do get in touch and let me know how we can help you. But I'm going to hand over to Hugh now, who's going to talk a little bit more about the sort of collaborative work that we've been undertaking at the Hub.
Good morning, everyone, and thank you for inviting me here today. My name is Hugh. I'm a emergency medicine consultant by trade, and I've only just come off nights last night, so I was called out 3 times. I feel like I'm just about caffeinated enough that I should be able to stand up throughout this, but if I do look like I'm lagging a bit, feel free to throw something at me. I also work for Cardiff University, and that's half my other role, where I am Programme Director in Emergency Medicine degree, as well as the acute end of the undergraduate course. And recently we made the Clinical and Innovation Lead for the medical school at Cardiff. But I'm here today to talk to you about the Immersive Technology Special Interest Group, which I'm the chair of, or the first chair of. The thing that I wanted to kind of first bring up is what is our biggest problem? What is our biggest problem in Wales for innovation in this area, particularly in the world of immersive technology? Keeps on skipping ahead, I'm not sure why, sorry. I think it's because we're still working in silos. I know of clinicians who are working on similar projects in different places, in different health boards. We've got people working actually within the same department sometimes that are actually working on very similar projects and don't find out till about 6 months down the line that we've been working in the same area. Even within the HEIs as well, not just between the HEIs across Wales, but also within a particular university, actually within the same college of university, sometimes within the same school of a college of a university, we find out that we're both 6 months or a year down the line in a certain area. And one of the things that we're keen to do with this new group is to start to break down those barriers. So I thought I'd start off just with some lessons learnt from a particular project which I felt broke down some of those barriers before we go on to evaluation and research, and I'm only going to be touching on that because one of our other speakers is talking about that. Then integration, future projects and how not to work in silos, and then how I feel like our immersive technology special interest group, which has been run by HIW and the Wales Life Science Hub, can help. So lessons learnt. We did a project a little while ago. It started around 2.5 years ago, and it was called the Wales Virtual Hospital. And in that, we basically went cap in hand to the Accelerate programme, and we were asking for some money to develop this project. And within this project, they then put us together with their usual suspects, which were St David's University and ATiC, who did a fantastic amount of work for us on evaluation. We also were put in contact with a certain company and the other HEIs that were involved in healthcare education and all of the different health boards. And we thought, really, we're all after the same thing. We're after a similar product that can help us. And that product, we initially had £180,000 from EU funding and then Welsh Government funding. the Wales Virtual Hospital is what we came up with in the end, and this is something which we were trying to cut down on some of the problems that we had with other products we were buying in. So first of all, time to create. We had problems with that in terms of sorry, the slides are skipping ahead faster than I can talk through them, and I'm not controlling them, I don't know why. So problems with the time to create. We've had certain products that we spent maybe 14 months trying to create a certain learning event around, and by which time the guidelines we were trying to teach was already out of date. We've also had some problems in terms of access. So access into the student records or into NHS e-learning for Wales. We want to be able to put that data directly from a product directly into those databases. And also access in terms of what we're using, because of course these fantastic XR products, some very fancy ones that you can put on your head, are not fit for purpose for everyone. And we've got to cater to our students and trainees across the board. And it's great that that product will work for 299 out of the year group, but we also got to cater for that one person who can't use it, who feels unwell with it, etc. We also then got to try and distribute that product across many different disciplines across Wales, and that would mean access via an LTI to be able to sign in with your NHS e-learning, your NHS password, or maybe your Bangor University, your Swansea University, or St David's University email and password. And then we also had some problems with the expense of it. So if I was to describe that a £24,000 project is something that only created 16 minutes of content. That's what we paid before. We wanted to be able to reduce that down so that for the health boards it was zero cost, other than the clinician's time. And of course, because it was zero cost, procurement are then no longer interested. They will sign things off. It's one of the biggest barriers, I think, for immersive technology to get into the health boards and universities, is that final step of getting across the threshold of procurement. So this is what we came up with. Wales Virtual Hospital, free software developed and owned by all the Welsh HEIs and NHS Wales. And I'm not going to go into the product too much because, we were supposed to be having someone to come and talk about it a bit later. But effectively, it's a system where you can create new software. It's a bit like PowerPoint. And then after that, you can deploy that to your learners, and it doesn't matter where they might be. They might be in any part of Wales. It might be that you need to deploy it across multiple devices, but you just do it once. And then you can also analyze what's happening in there as well. So where the students are looking, are they monitor fixated, or are they actually looking at the patient? What their module scores are, what the critical questions are. Perhaps they scored 99% but gave the wrong drug and killed the patient, so obviously they can't pass. But eye tracking software, and of course the most important thing there, being able to push it back into your existing systems. So the things here are all the things that we wanted as clinicians and academics across Wales for this type of software. And it took us 2 years to get there. So we had meetings every Tuesday afternoon, every other Tuesday afternoon with people from multiple health boards. Well, every single health board was represented. Every single HEI with healthcare was represented. And as a result, we now all own part of this, and it's free for use in Wales. But that is I feel, like a good example of breaking down the silos, breaking down the barriers within our healthcare and higher education institutions, and to work collaboratively, the word that's been brought up several times this morning. So moving on to evaluation and research, and I'm just going to touch on this very, very briefly because we have someone to talk about this in a second. But it's no longer... wow. It's no longer good enough, I think, just to say we have this fantastic idea. We have gone through that with multiple people, 10 people. They all said it was great. We need to have something more robust behind it. We need to have more critical review of that type of technology before we bring it into our healthcare system and our institutions. And to do that, being based within a university, so I'm going to try and go back to this, being based within a university where we can have access to multiple students, where we can have access to a bit of data crunching as well. But it's not all about quantitative data. The thing that seems not to want to show on this slide here is a control arm and an intervention arm where VR was used or not. But actually the more powerful data was brought up from the qualitative data, and that can be done in smaller groups than the 180 that we included. The next thing I want to talk about was integration. All of these systems are great, but unless they integrate into what we already have, they're near enough useless. I can guarantee you that from knowing one of the IT bods within Cardiff University, that if someone came and said, this product is something that we should use, and we would look at it and go, you know what, yeah, it is. It's very, very good. It's actually educationally sound. If it doesn't integrate with our existing systems and that student data is not pulled through, we're probably not going to be interested in it. And so integration from the get-go is key. So I'm trying to get back to this. But the other thing here is about it being part of supported technology. So within our institutions currently, if we have a problem with Microsoft Office or getting into our emails or using Learning Central, a learning management platform, or Exerti or any other type of learning management, e-learning platform, if there's no one there to back you up, that you can ring and say, I've got a big issue with this, I don't know how I can overcome this particular stop that I've got in producing content, then again, it's a huge hurdle. So be able to integrate it and then have support within your IT system so that you've got someone who you can ring or a team of people that can walk you through it is of huge importance too. So future projects, this is just one at Cardiff University, but in fact, there are very similar immersive rooms. It's not all just about the headsets, it's about other types of technology as well. This is being built with the broom still in the corner. This is what's across the way, the fantastic immersive room they got over in St David's University on the other side of the bridge. And this is from some universities in England. But wouldn't it be great if during the next phase of this development that we were to do this together as well? Create software that we can use across Wales, maybe work with companies that means that we can then get that for free and they can sell it to across the border as much as they want. But at least we get to develop it to start off with. The systems being used now are actually are very similar in nearly all the health boards or universities. It's one of three different types of devices that are kind of being pushed out across the different immersive rooms. So actually to develop that technology would be really, really useful. And it's not just about VR. We discussed VR so far. We've discussed immersive rooms so far. It's about augmented reality as well. Some of the fantastic work that Wrexham University have done on overlaying different types of wounds onto patients as well is great. And of course, all of that helps with our simulations, with our education. A lot of the problems that we find at universities and in the health boards is all to do with the set up and set down time. And of course, this cuts it right down. So, how can we go forward with that kind of philosophy of all Wales collaboration going forward in immersive technology? I feel this is the way that we can do it. So I was invited to chair the Life Science Hub Wales and the HIW new group on immersive technology. It's quite a long name, so we call it IMTEG-SIG. We are meeting either quarterly or maybe every 2 months, and we're going to be inviting industry to come along as well. And we certainly will be trying to do that at least twice a year, purely on the basis that the technology in this area is advancing so far, so fast, that if we don't meet every 2 months, then we're going to fall, twice a year, we will fall behind with seeing what tech is available. I think this is a picture of the Life Science Hub, but of course we're trying to make this an all Wales thing. It's not going to be Cardiff-centric, and we'll try to move around. We have clinicians and academics from across all health boards and all HEIs already involved in this group, including ATiC as well. The main thing I think this group can produce is a repository of projects. We have all worked separately in this area across Wales for a number of years, and there are some fantastic projects that have been completed. But unless you know about them, you could be trying to reinvent the wheel at your university or your health board. And so by having a list of past, present and future, maybe aspirational projects, all in one national register for XR projects, I think would be the most useful project out of this special interest group. Somewhere where you can go and work out who to connect with for a project that's been already been completed, where to go if you're trying to find current projects that are halfway through being set up and you want to get involved rather than starting again, or maybe, as Delith was talking about before, the matchmaking service of trying to get those companies, funding and healthcare and academia all together in one place for future projects to be developed. We want this also to be a place where we're going to be able to give some advice, not guidelines, but advice on evaluation and how to ensure that integration with your current systems is baked in from the very beginning of making any product. And that's about it. So our website is being translated, or soon to be translated. It will be up and running soon. And I think I'm now going to be handing over to Rescape, and Simon from Rescape, who's going to be telling us about one of the fantastic projects, I think, which is mainly patient-based, and we've got someone else coming in to talk about an education-based one a bit later on. So, thanks very much.
First of all, thanks very much indeed for the opportunity to come. I've been asked to talk about the development of our product and how difficult it is to actually get it integrated into everyday use in healthcare settings. So that's where I am today. Rescape are based in Cardiff. They've been around for about 4.5 years. The origination of the company is that we actually spun out of a media company. So it's a full-service media company. It's the biggest one in Wales. It's called Orchard. And our CEO had actually got interested in immersive technologies from a media perspective. He then went to a TED talk and heard a palliative care consultant speak about the difficulties that patients had in communicating in those very difficult periods. He had a penny drop moment and he thought, actually, we could use immersive technology to help with the problem. So he went and spoke to Prof. Mark Tobert, who was the TED talker. They had a conversation. We did our first piece of pro bono work for Velindre Cancer Centre. And what we were trying to do, the problem they had was that they had lots of patients who weren't turning up for MRI scans. And they weren't turning up because they were absolutely terrified. So the first piece of work we did was that we filmed a virtual tour of Velindre. So we literally pulled up in the car, you saw the car park, saw the reception, walked into reception, met the receptionist, then went into the waiting room. You can't wear it in an MRI scan, but you could hear the MRI scanner, and there was an interview with someone who had just undergone an MRI scan, and they talked them through the experience. And what they found was that if patients could actually experience that before they went to Velindre, they were far more comfortable about going. They found that their DNA rates dropped significantly, so people's anxiety was calmed. They went and had an MRI scan. Obviously, that's great for the patients because they're under an MRI scan, but it's great for the system because we're not wasting MRI slots, which are obviously very, very important. So that was the way the company evolved. It's quite important for me to tell you that because my experience is I've had 25 years of working for pharmaceutical companies. I've only joined in the last 18 months. So previous to that, these were sort of marketing people, creative types who had developed a product and thought, well, we'll just go to the NHS, tell them it works, and everything will be fine. And obviously that wasn't the journey. So what I'd first like to do is thank John for so eloquently describing the difficulties that smaller medtech companies have in trying to go to the NHS, which is a giant leviathan, and get them to embrace these technologies. There are a huge number of hurdles to overcome. I think the difficulty is that quite often the NHS is used to working with giant pharmaceutical companies or giant medtech companies who have enormous budgets. So it's not a difficulty for them to organize a clinical trial, get the necessary evidence to say this works. When it comes to smaller companies, it is really, really difficult. So we, as I said, we're about using immersive technology, and we do that in two ways. We have a therapeutic arm, but we also have a training arm. I'm first of all going to cover the therapeutic arm. We developed the first Class 1 medical device in the UK that utilizes virtual reality, and it's for alleviating anxiety and reducing perception of pain, and it does both of those things. And we've developed it to be able to be deployed in healthcare settings. Excuse me. The product now has been available since Q4 of 2019. Unfortunately, we had the pandemic in between, so similar to John, our progress was halted for a little while hospitals were out of bounds, but we're back on the trail now, and we are very much starting to gain a toehold. We are very, very early in the adoption of this technology, and similar to John, what we have to do is we have to uncover those innovators who are willing to give this a go, who are willing to actually consider that it could be a useful therapy. What is quite interesting is that the evidence base for using virtual reality for pain and anxiety goes back well over 20 years. So this is not as new as many people consider it. What has happened now is that the technology has caught up so that you can deploy it independently. Previously, you would have to be tethered to computers to have the computer power to do it all. There were lots and lots of barriers. So we've only recently got to a state where we can deploy it independently, and that's why you are now starting to see virtual reality headsets be deployed in healthcare settings to be able to help treat patients. Currently, at the moment, we are in around 80 healthcare environments in the UK, mainly hospital-based, but we're also in some hospices and we're in care homes. If you think about where is pain and anxiety in hospitals and care homes and hospices, or maybe society in general, it is absolutely everywhere. So we see the potential for virtual reality to help a huge number of people is enormous. The beauty of VR is that it's really low risk, it's non-invasive, and it's a really effective intervention. So that thing is a win for patients, a win for clinicians, and a win for the NHS. And we've known for a long time that pain is a biopsychosocial problem, and for way too long we've only really treated it with pharmaceuticals. So what this gives us is an opportunity to actually treat the patient holistically, something we've been talking about for a long time but not necessarily doing. But we now have the ability to actually help them to address the psycho and the social side of things as well as just the pharmaceutical for the medicine. All right. As I said, we also have a training arm to the company, and we were actually dragged into the training arm because we'd established ourselves as the experts in virtual reality in healthcare. What we found is that people were coming to us and saying, oh, we'd like to develop some training modules. We're not really sure where to go, so they came to us because we knew the name. And after the third or fourth inquiry, we thought, well, actually, we should probably do this. So we took on board some people who had experts in doing this. We entered a couple of competitive bids, and we won an SBRI project to develop an emergency tracheostomy training module. I think one of the things that separates us from some of the other VR companies out there is that we are very much about VR first. So we will only use virtual reality where there is a benefit to it. We don't do it for everything. There are lots of elements of our training where you can read it on a tablet or on a computer screen. We will only immerse you in virtual reality where there is a benefit to doing that. There is, globally, there's a huge undersupply of healthcare staff. What that means is there is a significant need for more efficient training tools for medical students as well as the new and existing staff. And we believe that virtual reality is going to help to solve this problem. The emergency tracheostomy model that I spoke to you about, we developed that. It's been finessed. We're working with the ALSG, which is Advanced Life Saving Group. They've taken the module on board, and they've actually run a clinical trial for us up in Manchester University. So Dr. Brendan McGrath, who's based in Manchester, has done a clinical trial, and what they did was they took our training module in virtual reality and they compared it to their face-to-face training. Well, what they wanted to do to make it a bit more interesting was to split the VR arm into two. So they did one session where the students would come to one central location, and there would be tutors there to help them use the VR and explain how to do it. And then there was another cohort who did it at home. So basically the headsets got sent to them at home, and they did it independently. So there was no need for them to come in, no need to hire a room. The number of staff required to train was significantly reduced. And what we found in that trial was that all three cohorts got the same learning objectives achieved. So they were equally effective at doing that. And what we did find was that when people did it at home, there was a significant saving in the carbon footprint. And obviously with the NHS drive to net zero, that's going to be quite an important motivator going forward. But also they didn't have to hire a room, so the costs were reduced, and also the number of staff required to supervise was significantly reduced. So there is definitely, in our belief, going to be a large role for virtual reality training to play going forward. Currently, we're in the process of developing 7 modules in collaboration with Swansea University. So, to echo what's been said throughout the day, collaboration is absolutely vital. It's really important that we understand what the learning objectives are for that cohort of students. We do that by working with professionals in the field and make sure that all the training we develop is appropriate for the needs that are demonstrated. I think one of the other benefits that people have mentioned is that with virtual reality training, it's incredibly consistent. When you've got a human trainer, we all have good days and bad days, and sometimes you're on top of the world and sometimes you're not quite as good as you want to be. With VR, and it's all recorded, you know that that training is going to be incredibly consistent. So we think that is going to be a vital part of making sure that we can educate and train the next cohort of doctors and nurses and clinicians that we all require. We honestly believe that every patient should have access to immersive therapies, and we believe that every clinician should have access to high-quality immersive training. One of the problems, again, I'm going to be echoing what John said earlier, deployment is incredibly important. And we're asking people to use a new technology. I'm working with doctors and nurses and play specialists in pediatric hospitals on a really regular basis. And one of their biggest fears is, if we take this on board, who's going to operate it? Is it complicated? Is it likely to break down? If it does break down, who do I phone? What do I do if we're in the middle of a procedure and I've got a screaming child? And all those fears are really well-founded. But what we need to do is be able to demonstrate that that's not going to happen. The technology is robust, and the only way that we can actually demonstrate that is to get people to try it. So for us as a really small company with very limited resource, we have to give people a trial. So we have to take our kit and give it to a hospital free of charge and say, have that for 4 weeks. Obviously we undertake training sessions, so we show them how to use it, but we've got to put that technology in their hands, let them trial it for 4 weeks, and then they will come back and sort of, they will decide that actually, yes, it's really useful, or no, it's not for us. But in order to be able to develop it or to utilize it properly, we've had to develop it so that there is no Wi-Fi requirement. We know across the NHS, the Wi-Fi it's appalling pretty much everywhere, isn't it? It really is. So we've had to develop it to make sure that there is no Wi-Fi requirements for that. The other sort of benefit that we found from doing that is that we don't have to engage with the IT teams in the NHS. So that is a really positive thing. There is no implementation, there is no installation process. It's an independent plug-in and play situation. So it all comes in a case that you can see there. It's on wheels. You can just wheel it in and it works everywhere. What we talked about a few times this morning and what I've heard is about the impact of technologies and what does it actually do. Sometimes we get bogged down in worrying about the implementation process and we've got to do this and we've got to do that and where's the evidence. Actually, when you hear, we did our first feasibility study in an intensive care unit in the Royal Glamorgan Hospital. Kerry Lynch was the consultant anaesthetist who led the trial. And in that feasibility study, what we did was we treated patients in ICU. We also treated family members, because obviously they're incredibly anxious as well. But what we also did was to treat staff. The staff in ICU are also really stressed under huge amounts of pressure. So we treated them as well and gave them the opportunity to utilize this new technology. What we found, not surprisingly, is that it worked across the board. Everyone who was anxious or in pain showed improvements, and it was all done by self-reported outcome measures. The gentleman you can see with the headset on, he was in intensive care unit for a couple of months. He'd gone into organ failure, was in a really bad state. He was having 20 panic attacks every day. He had 2 young children and his wife. It got to the stage where they couldn't come and visit him because it was too upsetting for the family as well. Through using Dr. VR, we got him to reduce the number of panic attacks from about 20 a day down to 2 or 3. It got to a manageable standard. I'm not saying it's a magic wand, but it had a really significant impact on him and on his family being able to actually come and see him. He felt incredibly isolated in intensive care. Calmed him down enough so that the family could come and see him, which was a huge impact. This gentleman then required surgery to amputate a toe, but wasn't well enough to undergo a general anaesthetic. And the only option for him was to have it with a local anaesthetic and with the VR. And he said without the VR, he definitely wouldn't have been able to undergo that operation. This is the sort of the impact that it can have. It's really significant. This young man had to come to a hospital every 4 to 6 weeks to have quite an invasive procedure done. Impacted his life hugely. For a week before the appointment, he would start to say he was feeling unwell, didn't want to go to school, didn't want to engage with anyone else, started to become withdrawn. We have managed to change his perspective on those hospital visits. Now he has to go, there is no option about that. But now when he goes to a hospital, what he's focusing on is, can I beat my highest score? Has anyone caught me up? Am I still going to win? His perception of that hospital visit has changed completely. It used to be, I know I'm going to have a horrible time. People are going to be holding me down, and I'm going to be enduring something really unpleasant. So we have changed his perspective massively. And again, the impact on the family life is huge. His parents are much more relaxed. They don't have all the trouble with having to get into school before. It sounds like a really small thing, but it has a really significant impact out in the real world. And as I said, we treated staff as well at the intensive care units. These are the sort of results that we're seeing. 99% of people who underwent it said they would recommend it to their colleagues. 90% of people felt more relaxed after they did it. Nearly 90% said it actually lifted their mood and it made them feel better. I'm sure you'd agree if there was a drug that came out with these results, we'd be in quite a hurry to get it adopted or get it through the regulatory process. We've got some big projects that are ongoing at the moment. We're looking at how VR can impact an aging society. So there are some problems that we've isolated with elderly patients that we think we can address in VR. One of the big things is movement, so we can definitely use VR to gamify situations to encourage movement, so that's something that we're looking at. But also loneliness is a huge problem for the elderly population, and from our early investigations, being lonely doesn't necessarily mean being on your own. We spoke to lots of people in care homes who were surrounded by people all the time who felt incredibly lonely because they weren't surrounded by like-minded people. So one of the things you can do with VR is you can put people in a virtual room who have similar interests or similar groups. So you could have like a Sunday quiz on certain topics or whatever, bring like-minded people together. So those are the sort of things that we're looking at. We'll just put people in groups and make them feel part of a community, because that's incredibly important. We're also using AI. It seems to be a popular theme. If you're not using AI now, you are definitely falling behind. So we're going to look at using AI and music to try and personalize the spaces that people are inhabiting. We need people to come back to VR and use it on a real regular basis. So the way that we can do that is to make it feel like it's their space. It's somewhere they feel really comfortable. And we think that music is going to be a big part of helping to do that. We're absolutely clear as a company that the evidence base is the way forward. You are going to have to keep building that evidence base. But what we are, our sort of plea to the NHS and to NICE and to the regulatory bodies is to understand we don't have unlimited amounts of money to be able to undertake these massive clinical trials, but we can generate some real-world evidence, and we are really keen to collaborate with anyone who's interested to help generate that. So if there's anyone here who has been listening and their interest has been piqued, or they think there may be a use for them to adopt virtual reality, I would say please get in contact with us. We are very, very keen to collaborate. And thank you very much for your time.
Right. When do you want to do the video? Right at the end? It's going to be easy because we have to sort of jump out of this and then jump onto that stick.
Is that all right if I jump out? Will you be jumping out on it? Will you jump out on it? Yeah. If you can do it now, that'd be great.
Do the video first.
Do the video or the presentation. If I can get on there.
Do the video.
It's just my presentation, actually.
Oh, right. So it's a new PowerPoint that we've got. Okay.
Apologies, I'm being very awkward here.
Right, on the stack.
There you go.
That's it.
There you go. And then it's just...
Got you.
There you go.
Loading.
There you go. That's perfect. Brilliant, Chair. Thank you very much. Well, good afternoon, ladies and gentlemen. Thank you for having me here today. As you can see, I'm not Robin Davies in your brochures. I'm George Bellwood. I'm his colleague and business partner, but I'm the co-founder and CEO of Virtus Tech, and I'm here to talk to you a little bit about what Virtus Tech does, what we've been working on, especially with the Wales Virtual Hospital project, which was a collaboration project between all universities here in Wales and health boards. So this project was pretty much for clinicians and academics coming together to build this e-learning platform tool that we were able to sort of move forward. Virtus Tech is a no-code virtuality platform that allows organizations to build their own immersive simulations and deploy out to their employees or for their students across any academic or any training facilities. So firstly, obviously, we all know that virtuality is a really hot topic, especially a really useful technology tool. They can be great and come with such amazing stuff, but they do have their limitations. I'm sure a lot of you might have seen this when you come into doing projects. You can have anywhere from very long delivery time for any particular bespoke created ones for you. Simulations can be quite costly sometimes. That's obviously when you want to try and go for grants and everything. You might have a bit of a limited device access to this, so obviously VR headsets, you know, the Rescape, which are doing such amazing work, as they said, they only use VR headsets for the pure reason when you need your students or your employees to be in a VR headset. We have the same sort of philosophy of that one, which is if you need a VR headset, use it, you know, for that immersive side of it, but if you don't, but there's a lot of VR companies that do just focus on that sort of device only. And then non-configurable, so again, if you have a bespoke created simulation for you and you want to make any changes and anything like that, it can become more costs on top, or it can actually be impossible to sort of do. So what is it that is what we really have built? Well, it's called DigiSim, so it comes in sort of 3 pillars here. We allowed the clinicians to be able to create their own simulations using the content that they've recorded in simulation rooms like they would normally do with their students during academic years. They would take that content, put it through the creators mode and be able to sort of drag and drop their simulation content in, so you can bring your own materials in, and then that can be deployed out to the simulation mode. And then the simulation mode is where the trainees and the students will be using the simulation, if you like, and doing the learning through the platform. And then we have our data mode, which then tracks how the students and the trainees have been interacting with the system, and then that's fed straight back to the clinicians and academics, and then they can make any adjustments that they need based on that simulation. So with this sort of solution, we've been able to actually reduce down the delivery time to, we've had some clinicians who have used it with the partners of the Wales Virtual Hostel. Within one day, they've been able to record something in the morning, go into the afternoon, over lunch, create the simulation, and in the afternoon, they deployed it out to their students. They were able to have the ability to create unlimited simulations. So, you know, it could be a case of they wanted to, you know, go from an easy to a hard level for the students to learn as they sort of go through it all. They have the ability to use any device possible. So the simulation mode allows this to be actually accessible on VR headsets, any VR headsets, but also on desktop, mobile, you know, tablet, because as we understand, if you've got a classroom full of 350 students, then you're not going to be going out to buy 350 VR headsets, you know. Gets very expensive. And then again, fully configurable allows them to go in and put their own materials in. So what we've sort of been seen as is the PowerPoint of VR, if you like, where you can create your simulations and deploy it out. So I've got here just a quick video just to show which of the simulation here. So this was one with Cardiff University that we worked with for the basic life support. As you can see here, this is a time scenario that was created that basically of the new system here that we've updated, and we also worked with ATiC as well, so they did a lot of research into it. You can pop your question in, you can save it, you can edit it all, you can then drag and drop any of your answers into it, or what sort of hotspots you'd like to go into it, so information hotspots, answers, so correct answer, wrong answer. So it's very much a case where the student will be fully immersed, go around, looking around, clicking on the hotspot, and then the feedback is what key is. So the clinicians can pop in their own personal feedback that they want, and then they can go between different scenes. So they can go from 360 images to 360 video straight from the simulation and inside. So again, it just gives the clinicians and the academics the power to be able to build their own simulations, personalize it, customize it the best as possible. So again, what it really brings is it goes beyond limitations. It became, being a device agnostic organization brings its huge benefits, especially to things. I can see I've not done a very good job in the middle one there, but it's scalable as well. So again, getting this out to the students as well and making sure that, not only on VR headsets, I know that a couple of universities are having their own immersive rooms that they've got, but they're also getting the VR headsets for students to visit and come and use it, but then scalable to allow them to do this whilst they're at home on their desktops, laptops, and surprisingly, there's a lot of students who are buying VR headsets who can have access. And then frictionless. So what we have created was a very special API that actually connects up with all the major learning management systems. With these learning management systems, it basically means a single sign-on. So it basically means you don't have to create any new accounts and anything like that. And through the creators mode, as sort of the admin users, you would then have your cluster of different, you know, either students or staff members or anything like that, that you would then allocate a certain simulations that you want them to go through. Through the LTIs or the APIs, the integration here, it also automatically feeds back through the data mode that we've got within the platform. So when students are actually being tested on this academically, all their answers and feedback can be easily piped back into Blackboard or Canvas or Moodle or any of the other learning management systems. So this makes it just a really easy to use, frictionless, as you like, process where you can have it all in one section. It doesn't mean that you have to be clicking on many, many different tabs and everything like that. That's something that, you know, we've been learning during the project of the Wales Virtual Hospital, where academics didn't really want to continuously having to log into different areas to look at, you know, this and then having to export it all out of that. This is something that just does automatically straight through the platform. And as I said, I know I bang on about this with the device agnostic side of it, but we have got the capability of getting it across any device possible. So it doesn't mean if you just have to stick with the one kind of brand. You can do this offline and you can do it online. So there's a lot of questions asked, especially when offline mode, when you have it just purely on the headset. Data can still be tracked on the VR headsets when you're offline. So when you do connect to the internet, the data is just cached in the headset, and then once it's actually uploaded to or connected to the internet, it is then uploaded into the data mode, allowing sort of the academics and clinicians to view how their students have been using this. As I said, we've been working with you know, a bunch of partners here in Wales. It became a very big collaborative project since COVID. I think this is sort of what spawned this, which was clinicians wanted to create and academics wanted to create something, their own personal one. I know there's a lot of universities now that are investing a lot into their media and starting to create different types of media for them to use as part of their sort of modules, if you like. So every health board and university had this as a free sort of offering from TriTech, and for the Wales Virtual Hospital project, this is what came out of it. It's free to use for your university, your health board, and for your students. We are looking at creating a marketplace, so this is actually something that's sort of spawned up as a bit of a project. A lot of the universities have obviously been swapping a lot of the media across to each other. Or, for example, if you've got one university that's actually created a simulation, there's no point in having another university creating the exact same one. Instead, they can just take it straight off the university through the agreement that we have on the marketplace through the Wales Virtual Hospital, and then they can customize it themselves, you know, on top of what they want to do, so their learning objectives, their learning outcomes, and everything like that. We're also opening it up to VR companies, so we have a good number of VR companies here in Wales, but also in Canada and in England. As we sort of saw it from one event, there was a Canadian VR company that created a simulation on X-rays, and obviously we had a university learning manager there who said, I would love to have that, because that's definitely something that the students could really benefit from, and it's something we can't even teach or even sort of train on, shall I say. We can only teach them through books and sort of images. So that was created, and so they're now joining onto the marketplace, and this allows sort of the universities and health boards to see what sort of projects that they've got going on and connecting up with them to sort of join alongside with them and sort of tap into that, if you like. And then finally, we've just got some sort of work that we've done outside of Wales. So we had an organisation from CDC, I don't think their logo's come up. So the Centre of Disease Control, we met them out in America. We showed them a little bit what they do. They've got their own sort of virtual reality employees, if you like. they've got about 10, 12 of them, and they build, bespoke simulations for their own establishment. But they've used our stuff because, they found that with the Wales Virtual Hospital as well as other stuff, they were able to build something a lot quicker, deploy it out, and again, a little bit more simpler, a bit simple for them. Doesn't need to be too technical, and then they can get this across. So, again, the learning outcome was 10 times better, and they were able to reduce their development time by a significant amount. So that was a really big sort of plus and positive. So again, we're sort of looking to collaborate with a lot of different VR companies to get them onto the marketplace, and B, to sort of share the knowledge and everything like that. And Wales Virtual Hospital is free to use, so if you're interested at all, please come and speak to me afterwards or anything like that, and I'll be happy to sort of get you signed up and set up. So that's it. Thank you.
So we've got one more speaker for this session. I can see the food's out and everybody's tummy's rumbling, so if you could just bear with us. Delith has suggested that we skip the Q&A session at the end of this, and you can meet up and talk over lunch. So our next speaker is Dr. Mikhail Toombs. Thank you.
Thank you. That's okay. Right, I know you're all hungry, so I'll try and be as quick as possible. I'm based at Cardiff University, and I'm based at the Centre for Medical Education. I'm not a technologist, I'm not working in industry, and I'm not here to represent kind of anything that I do at Cardiff University particularly, but the focus of my talk is going to be very much on evaluation, scholarship, and pedagogy, and why it's so important that we embed that in what we do. Now, throughout this morning, I heard a lot about deployment and implementation, and how do we convince stakeholders to actually use the technologies. And it's about longevity, it's about sustainability, it's about scalability. How do we convince them to actually take this on, and that it is as good or even better than what they're doing? Now, when we talk about evaluation, we talk about treatment and diagnosis, so using technology for treatment diagnosis, but we also use, and this is the examples we've had in the previous couple of talks, we use technology an awful lot in patient education and also in the training of health profession workforce. And we use a lot of it also in undergraduate courses as well as postgraduate training. And when I prepared for the talk today, I found that there's actually an awful lot of research. There's a large body of evidence that accumulated and done a lot of the work for us that looked at evaluation and the efficacy of this intervention of technology and the use of extended reality in training and in also in patients' education. But what they found, and there's a 2023 review there, and they actually synthesized reviews. So they found lots of papers from all over the world around patients' education. And here as well, that's 133 studies that reviewed the efficacy of the use of extended reality in medical education. There's a lot of research out there, but they all have overarching theme. There's kind of a common finding in these reviews. And what they're finding is that we need to do more evaluation, and we need to do better evaluation if we really want to be able to implement, to convince those stakeholders to use the technology and to its full potential. So more evaluation, more scholarship. We need to disseminate these findings, because what happens is we don't actually know if we hear. This is a review of the published and some of the stuff in the grey literature. There might be lots and lots of stuff and really good stuff going out there that we don't hear about. And they're calling out for more evaluation and more scholarship, so we'll be able to convince the implementation and deployment of the technologies. So why do we want to do more evaluation? Why do we want to engage in more scholarships? We want to do more evaluation, and this is what they're saying, these researchers, this is a call out from these reviews, is that we want to determine the feasibility of the program prior to its implementation. So we want to be able to convince stakeholders that of their value. We also want to see if they were implemented as intended. We want to measure the effect of the program, and I will show you now that actually effects of the program, there's more research on that. There's less kind of throughout the program, and also there's less research around the mechanisms that lead to program outcomes. Because if there's anything that we've learned from COVID, and this is the unintended outcome that the pandemic have taught us within educational institutions, is that yes, we want to use more technology, but we really do have to upskill our staff. We have to upskill our students. And in fact, it's actually more expensive than face-to-face teaching. Because if, for example, conferences like this, if we wanted to do it online as well as face-to-face, the amount of resources, the challenges, the things we have to think about, it's just a bit easier to go back to the good old days. Well, not so good, but the old days, because you really do need to invest a lot to maximize its potential. So, the difference being is that we have got most of the studies that you find around evaluation of extended reality in healthcare focus on outcome evaluation. And really what they do is they measure the impact. So you decide what you want to teach, and then you measure the impact. And this is versus program evaluation. And program evaluation is the kind of evaluation that we do to try and understand why is it working? Or why is it not working? What are the challenges that we try to overcome? So a lot of the research we're finding focusing on outcome rather than program evaluation. There's a few there, but not many. So let me show you a bit. I don't know if you can see. So you probably will be familiar with Kirkpatrick model of evaluation, and where the lowest level of evaluation is looking at reaction. Basically, are they enjoying it? So a lot of research has been done at that level, but also at the level of learning. So the kind of post-test, what have they learned? Are they feeling more confidence now, and so on? There are very few studies that look at actual impact and results and behavior. And that's what we want to be able to demonstrate. And it's very difficult, if you run a training course, it's very difficult to actually evaluate impact and results because there are so many confounding variables. There are so many things that could impact that. And it's very difficult to control that, for the fact that it's just the training, especially when it comes to technology. So it's not surprising that most of the research looks at reaction and learning, and that's absolutely fine. So here's the findings. This is just to show you that the majority of the research around extended reality use within medical education basically look at level 1 and also at to some extent at level 2 as well. So much more that, very, very few looked at behavioral changes, benefits to patients, benefit to clients and families and communities, and very few, actually just one of the studies looked at change in organizational practice and change in professional practice. And this is the kind of stuff we need to be able to evidence if we want to increase the use of extended reality technologies. And here, this is not within the healthcare. This is within the construction safety industry. And it's a kind of stuff, this is just showing that a lot of the evaluation being done is focusing exactly at that reaction and learning level, and not an awful lot looking at behavioral and so on. So this is where looking at objective measures, things around which, like the virtual hospital is measuring the eye tracking, where people are looking, the number of errors that people are making, the decisions, the tick boxes. So there's a lot of that. But actually, a majority of them also looked at questionnaires and interviews of perceptions. Did you enjoy it? Did you like it? Did you feel that it met the learning outcomes and so on? And what I'm trying to present here is an argument, really, that we need to do more. We can't just focus on the outcome measures. And also, what these studies show us is that the technology provides as good a solution, not necessarily a better solution. But if to do that, stakeholders have to invest an awful lot of resources and money, then we are struggling to convince it to take them on because it's as good. So why take on if it means that I have to invest an awful lot of resources and time and everything else? So this is where the call is for a more extensive program evaluation, rather than just focusing on outcomes, looking at context, asking patients, asking families, asking educationalists, asking everyone in terms of, are we actually addressing the learner's needs? Is there enough pedagogy in there? Our objectives very clear. Thinking also about the input, the materials, the instructor's method, the physical environment, the equipment, thinking about the process, the teaching, the classroom activities, and then thinking about the product. So they're calling out for more. Now, it is more resource intensive. We understand that, but we need to at least try, if we can't do all of it, to do more of these aspects in the evaluation that we do of these technologies. So, final slide. I think I'm talking faster. So, evaluation should be considered from the outset. It shouldn't be considered as an afterthought. And this is because there's nothing worse than you've run a hole, you developed something, and at the end you say, oh gosh, if only we could have analytics that will tell us, they did this or they didn't do that. If from the outset you know what you're looking for, you would also already have the analytics collected at the end that you can use for evaluation. And I'm not saying that outcome evaluation is not valuable. It's definitely valuable. It's also easier, so you can understand why it's being done. It's a really useful tool to allow us, to measure effectiveness against preset objectives. But we really do need to think more about program evaluation. But that all thing considered, it is more complex. It does require more resources because it's that kind of qualitative elements within evaluation. But it's more likely to highlight the factors that contribute to these outcomes, which will allow us to convince the stakeholders in terms of implementations and deployment. And if you wanted, if you're interested, I'm an academic, so naturally, I use research and I use references, but if you wanted to read, I kind of went really quickly through them, but these are the papers that I used to build this. So thank you very much. I think it's lunch.
Okay, so thank you everybody, Delith, Hugh, George and Mikhail. Lunch is ready. If we could come back to our seats by 2 o'clock, that would be really good. We can make up a bit of time then. Enjoy the lunch. So, this session's related to medical technology in a really broad sense, and we've got some interesting speakers. The first of which is Georgia Gay. She's the Business Development Officer for Cyberdyne Incorporated, and yes, they did take the name from the Terminator film, and you'll see the relevance of that in a minute. So I'd like to ask Georgia to join us. Thank you.
Hi, hello. thank you for coming to listen to my talk today. And what's been really nice is actually listening to all of your talks as well and seeing that we have so much in common with regards to the people that we serve. I suppose I should probably start on my slide. And I've spoken to a few of you today asking about what I do, so I'm really sorry if you have to hear my spiel again. And unfortunately, Catherine Knighton, who's meant to be doing the next slot, who's my manager, could not come along today. So unfortunately, I have 40 minutes, which I promise I won't fill. And also with regards to, obviously, this is the slump slot. So if anybody wants to get up and have a wiggle around because they've just eaten their lunch, that's also totally fine. So first of all, who am I? So I'm Georgia, and I have the unique role of working for Hampshire County Council and also working for Cyberdyne. That probably sounds a bit strange, but my background is tech, and I've got this unique ability and unique role to come in and work with medtech in a social care setting and also in a health setting. So I'll tell you a bit more about that. And this is Catherine, who was supposed to be with me today. Unfortunately, she couldn't make it. She is the transformation lead at Hampshire County Council. She runs loads of projects, but one of the main projects that she runs is one that I'm involved with called the Cobot project. And it's as interesting as it sounds, so you get to hear a bit more about that come the end of the presentation. Cool. So who is Cyberdyne? And as Sean kindly alluded to, we are fortunately or unfortunately not the company from the Terminator, but we are equally as interesting. So we are a Japanese robotics company that were founded in 2004 by a chap called Professor Sanghai. Professor Sanghai is the guy in the middle. He's a pretty clever guy. He's not only the CEO and founder of Cyberdyne Robotics, but he's also, I've got to read it out because it always confuses me. So he has a PhD in engineering, but he's also the Executive Research Director at the Centre for Cybernetics Research in Japan, as well as a whole list of other things that are on his CV. So he's a pretty clever guy. And Cyberdyne was created because I'm not sure if you guys know much about Japan, but they have quite an aging population problem. So obviously to have a growing population, you need to have a birth rate of around 2.4. Japan are on about 1.2 at the moment, and so he foresaw all of the problems that come about with regards to an aging population. And he wanted to create something so that as people got older, they could have more mobility for longer and retain quality of life. And that's when he created the HAL range. So we have Eli, my lovely assistant today. He's sporting one of our devices, and I'm sure he'll give you a little walk in a minute. This is the lower limb device. We also have two other devices. We have the HAL lumbar, and we also have the HAL single joint. Now, HAL stands for Hybrid Assisted Limb, and these devices are very, very unique. Yes, they are exoskeletons, but what makes them even more unique is how they work. So a lot of exoskeletons that you may have come across in the past utilize stimulating the muscles. What's unique about the HAL device is it actually works utilizing the wearer's intention. So, Eli, could I get you to come through to the middle of the stage? So Eli has just spent half an hour with me where I've been fitting him into the device, okay. So we've been sat around for a little bit, so one of the electrodes has come loose. But what's actually all over Eli's legs are electrodes on particular muscle groups. And that is because we utilize the wearer's intention by picking up on the wearer's bioelectrical signals. Now, bioelectrical signals are sent from the brain to muscle groups, and these signals leak onto the surface of the wearer's skin. And what we do is we can pick up even the faintest signal that comes through. So then utilizing and completing that person's intention. So if Eli was, I've turned him off because one of his electrodes has just come loose because we've been sat around for a little bit. But if Eli was to walk, the device would pick up on his intention to walk and complete that with him. So instead of just stimulating the muscles, it's helping rebuild the neurological pathways. And this device is the lower limb device. So this is probably our best and most requested device. It's used globally within rehabilitation clinics. It's also part of workers' compensation in Germany. It's part of public health service in Japan and also in Malaysia. So you can find these across the globe, and really I want to introduce it to the UK and introduce you guys to it. So it's predominantly used for patients who have had spinal cord injury, neuromuscular disorders, or stroke. And what's really cool about it is it can target, so say you have somebody who's had a stroke, it can work and just, you could isolate, maybe it's the left hip and the left knee that needs work, and you could put a manual assist on one side so that the wearer can just use it as they would normally, and then it can assist them with the side of the body that needs the help. Also, we have these really fashionable shoes that come with it. They can monitor and show you the kind of center of gravity and whether you're getting heel to toe with the patient when they're walking. So, Eli, you can take a seat now if you like. And if anybody has any more questions with regards to this, then please feel free to come and ask me afterwards. So what's really cool is I've had some people ask me, well, what happens if you've got somebody with a complete spinal cord injury and they've got no signals that are able to be picked up on? And, you know, some months ago I may have said, oh, potentially they wouldn't be able to utilize the lower limb device within their treatment. But something that we've recently been able to do is we've had a couple of people come in with complete spinal cord injuries. And to begin with, on their first sessions, we've utilised the electrodes on the arms and got the wearer in the device and moved the arms at the same time as the legs. And then after a certain amount of treatments, we've been able to pick up signals on the legs. So, you know, that's still in its infancy, but it's something that I'm happy to share with you guys and happy to explain afterwards if you're interested. What I thought would be interesting is to actually show you a case study. So we've got Kim is somebody who I've shared on LinkedIn. So if you follow me on LinkedIn recently, you will have seen this. So she came in to us with a C5, C6 spinal cord injury. She had really, really reduced ability to use her upper half, her arms, and she couldn't use her legs at all. She was in a wheelchair. So she came in for just over a year and worked with us. And, well, let's show you the video so that you can have a look for yourself. So as you can see, this is the first session. The ability to actually lift the legs is not possible without the help of the physiotherapist. So this is after the 6th session. I'm also really pleased to report that Kim now can walk without the use of aids. It would still be for short periods of time, but she's at the point now where she doesn't need to utilize a walker or the HAL device. So this was on her last session. As you can see, her gait cycle is completely different to the first one. So with everybody who comes in for lower limb training, we always do a 10-meter walking test on the first session, and then we do it periodically throughout the training, and then we'll do it again at the end. Ooh. So now to talk to you guys about the single joint. So the single joint is exactly what it says on the tin. It is a device that also utilizes the electrodes and the wearer's intention to move. but it focuses on individual joints. And this is particularly useful if you have somebody who's not able to get out of bed, and you want to start being able to work particular groups before they are able to stand. So in the EU, we currently can use the elbow, the knee, and the ankle single joint. But I've also got a really cool case study to show you what we've done with regards to our centre in Malaysia, where they've utilised the single joint on shoulders. It's not available in the EU yet, but it's really cool, so I thought I'd give you a little example of it. What's good about it is it's in a small box, so it's easy to move around, and it just allows early stages of recovery to kind of be picked up before potentially you're able to get somebody in a lower limb device. It also can focus on the ankle, and with regards to the lower limb, it doesn't have a specific part that focuses on the ankle, so you can do training with ankle work with the single joint and then move into the lower limb. So, this gentleman, sorry, before I show this, I just want to give a nod. Please do not record these next ones just for, I'm allowed to share them within the room, but client confidentiality. So this gentleman had a C5 segment injury. This just shows his ability and mobility pre-single joint training. As you can see, he's got significant mobility loss in his shoulder. This is during the single joint training. So as you can see, this little monitor at the front is part of the ways in which you can monitor the signals that are being picked up, and you can change whether it's changing the sensitivity or increasing the torque tuner. You can also monitor it on a phone. A phone comes with it. So this is, again, utilising electrodes. So he's the one who is making this device move. It's not making him move. And then this is after one session with us, with the Hywel single joint. So that was increased mobility after just utilising it for one session. And then finally, we'll come on to the Hywel lumbar, which is my personal favourite and one that I work with every single day. And what's cool about the Hywel lumbar is, as you can see from the image, it's very unique in a sense that it's not just a medical device. This is also used in industry globally. We utilise it in the UK within the care industry, but it's also used within anything that has strenuous moving and handling needs. And so in Japan, they use it with regards to building sites, manufacturing. And what's great is it can be used to rehabilitate trunk stability, or it can be used as a protective and preventative device, making sure that you're in a correct moving and handling position. So this is my favorite case study. I'm just going to give a nod. This is another one that, please do not record this. And this lady is 82, and it kind of shows to me that you can be of any age and kind of increase that mobility. She's 82, and she's in a care facility, and she's utilised the lumbar device to help with her trunk stability. So as you can see from this, she walks incredibly slowly, and she has to use a walker. Can you see that there's very, very little trunk stability there? She's really, really bent over her walker. Something that's common when regards to, I'm picturing my grandmother, for example, after having a fall and losing confidence in the walking, and then it's kind of a use it or lose it. If you're not utilising that part of the body, then all of the weight's now going into her upper body. And then this is her sit to stand function. So she's unable to sit to stand unaided. So what we did is we did 10 Hywel lumbar sessions with her, just simple sit to stands, and then sit and kind of hover to help rebuild her trunk stability there, and her sit to stand motion. We did 10 of these sessions, and I'm pleased to report that this is where she's at now. She's able to stand unaided, and this is her walking function. So as you can see, her posture's completely changed. I love this because I think that by showing you this example with this patient using it in a rehab setting, you get an idea of actually what it can do in a protective and preventative way. It's really interesting. I mean, it's happy and sad. I've been at 2 events in the last 6 weeks where I've done demonstrations and got people in and out of the devices, and I've had 2 women on separate occasions who have both had back injuries, and they work within the caring sector, and they've been unable to go back to work because of, so they're working but unable to do any of the normal day-to-day tasks that they would have been able to do before. And both of them came to me and cried because they had normally had so much pain just from standing still and walking upstairs, and by utilising the lumbar device, they could move around with ease. So now I'm going to move on to the part that Catherine would be doing, so I hope that I can do it some justice. So why are the cobots within Hampshire County Council? So you may have gained a bit of an understanding from what I have just explained with regards to the lumbar device, but the cobot is what we call the How lumbar, and we renamed it that because How lumbar isn't really catchy. Collaborative robot is what we call it within the UK. So, the starting point. Why did we look to bring in any kind of assistive tech within the caring industry? Now, I'm sure that everybody here is aware of the fact that we have a huge shortage of carers. In 2017, we did a study within Hampshire. By 2025, we would be at a deficit of around 6,000 carers. And there was something crazy, and that was before the pandemic. And obviously, with regards to the pandemic, that's kind of become even worse. What was scary is something came out that if every school leaver, every 16-year-old when they came to leave school that year, if they all decided to go into the care industry, we would still have a deficit of carers. So we needed to find a reason why people are leaving the industry, and find a way in which we can support our carers. So one of the things that came back was a lot of people were leaving the care industry due to musculoskeletal injury, and they were getting to a certain age and they just couldn't do the physical manual labour tasks, especially if they had received an injury from elsewhere. So it was cutting their careers short. So we wanted to look, as well as looking into other methods, we wanted to look at a way where we could support them and protect them and help retain staff at the same time. So instead of me rabbiting on, I'm going to play you a video now, which is fine for you to record if you like. And this is kind of what we've been through recently. So. Yeah. One of the things that's interesting, and I'm not sure if I said just now, is we actually utilize the lumbar device, the cobot, without the use of electrodes. So it has a manual assist mode, it has an a user assist mode, and then you can actually use a combination of both. Obviously, we utilize the electrodes when working with those with weaker trunk stability who are in rehabilitation, but we found it's not necessarily ideal to be putting electrodes on carers. There was a few pushbacks with regards to fake tan and electrodes and that kind of thing. So there's a solution for that. But yeah, in 2017, we saw that there was this problem. We had a company called PA Consulting who works with us with our assisted tech within adult social care. And so they went out, searched around, and Cyberdyne came up with the Hywel lumbar device, because Hywel lumbar device is used in the care industry in other countries. And so we thought we'd give it a go. So in 2018, we secured an LGA funding with the Isle of Wight to explore the kind of perceptions of the cobot as a potential solution. And phase 1 was UK paid care sector, and phase 2 was kind of user requirements, strategic outlines of case and regulatory requirements, and doing all the paperwork. And then by 2019, we kind of scoped a Pathfinder, which began in January 2020, which is obviously not a great time to be doing an assistive tech Pathfinder, obviously because later in the year we came up with other challenges, for example, COVID-19. But what was interesting, actually, there was a benefit to it, because what we found with regard to utilising the lumbar device is that people were able to give care, especially if you've got a care package that's like 1.5 people really, so you have to put 2 carers on each package. You could narrow that down to 1 person because of the use of the cobot. So yeah, it was kind of a bit of a shift of plans, but it actually worked out as a cost-saving exercise and also as a protective and preventative exercise. So we concluded in our 6-month Pathfinder and decided that we had enough evidence to kind of continue the journey a bit longer. So we went out to tender and began our contract with Cyberdyne in October 2021. So here's some feedback that we've actually got directly from the carers, and I think it's important to add this. So I guess the big question is, did the cobots work? The majority reported that service user reactions to the cobot were positive. Care workers in the community, especially domiciliary care and reablement, were particularly positive and enthusiastic, and when given the opportunity to try the new technology. And these care workers found that the cobot was mostly beneficial. Now, that doesn't mean that we haven't had challenges. One of the biggest challenges for us has been a cultural shift. There's a lot of people who see the cobot as, is this going to come in and take our jobs? There's also the idea of actually physically putting on a piece of tech to go to work. And so it's kind of changing those ideologies and working with carers to feel more secure within their roles and show them that this is a protective device to use to actually support them. So how does this help with our wicked problem? So the problem, if the problem was simple, we would have solved it already. And if one device was going to come in and solve the whole problem for you know, the deficit of carers that we have and reducing carers on care packages and things like that, then we would have done this long ago. But it is a tool in our tool belt with regards to reducing the amount of carers that were required on packages and also protecting those carers and keeping them in the industry for longer. So the interest and emphasis around the work has allowed us to kind of kickstart a real cultural change within Hampshire. We've built up some amazing networks across our care providers and partners in health as well. And we've started action around actually updating our moving and handling techniques. So we're now kind of unifying and bringing together one kind of training with regards to moving and handling. And we've started talking to lots of different councils with regards to this. So we have reduced the number of carers on packages. So it's 250,000 so far, but there's more to come. And we've had carers tell us that the cobots have made such a difference in their physical well-being. So there's a lot of learning around introducing and embedding new technologies and those ways of working. So it's kind of become even more evident that there's a lot of myth busting that needs to happen, and a lot of upskilling that needs to happen around moving and handling generally. So what's next? So it's actually a really exciting time with regards to all of these devices. This year has been about spreading the word, actually introducing people and giving demonstrations, getting people hands-on with the devices. So cobots will continue to play a vital role as part of our practice. And we also have a collaboration with Southampton University, where we've got a PhD student that's funded, that's actually studying the impact of the cobots within the care industry. So we're getting some real life outcomes and been able to kind of quantify the feedback that we're getting and the research that we're doing. And we're also talking to various other universities with regards to these products. And something else that's potentially on the horizon is the use of these devices in rehabilitation. So for me, this is also very keen, because I went over recently to Dublin and worked with a rehabilitation centre out there just as a trial couple of days, and was hands-on with clients using it in a rehabilitation setting, and just physically seeing the outcomes in front of my eyes, that we're now looking at different ways in which we can provide the lumbar device. So some of that might be private rental and use of training up physios that go and see individuals, or it might be as part of hospitals and things like that. We've also been invited to hospitals like the University Hospital of Southampton, and done demonstrations there, and they're potentially looking at it for their nurses or surgeons or anybody who's either stood up for long periods of time or doing excessive moving and handling. So it's really exciting. And obviously, you guys might have a lot of questions with regards to these devices, so please come and find me at any point to ask away. And hopefully, you're all still awake.
Okay, thank you, Georgia. Thank you, Eli. I've got some WD-40 in the car if you... Okay, right. I'd like to welcome up our next speaker, Professor Peter Kennedy, consultant orthopaedic surgeon from Hywel University Health Board. Peter's going to talk robots again, but in a completely different application now.
Thank you, Sean, and thank you for the introduction. So we're going from cobots to surgical robots. So that's my title, The Role of Robotics and Prince Philip Hospital in the Delivery of Joint Replacement Surgery. I've got some conflict of interest, but nobody else shows them, so I'll just hide them as well. So I'm originally from Belgium, and in Belgium there is a very, very good reporter. He's called Tintin, and he's very investigative. I love a bit of metalwork. I like to take my team to strange places to learn how to do things. I do a bit of sailing, and I love a powder day. So that's me. So what are we going to talk about? So we're going to talk about joint replacements, the outcomes, new technology in robotics and races. And as Chris has said, and I'm going to go one slide back. No, I'm going to go one slide forward. We need to have a little bit of a history lesson. So the history in joint replacement is quite important. And when John Charney developed his total hip replacement, which what he called the low friction arthroplasty, he did it with one priority, and the priority was making the patients better, making them more mobile, getting them out of bed and getting them walking and working and enjoying a good life. And his compatriot, John Insall, he was from the UK but moved to New York. He also developed Insall-Bernstein knee. So both implants are not existing anymore, but they're the predecessors of the current implants. So when I did my thesis in Sweden, we looked at the pathway for patients, and you can see the old lady, Mivanwi, going in for hospital, And if she's lucky, she'll have one hip replacement, but we saw that quite a lot of patients will have revisions, and many patients will have a second operation. And usually for everybody, it ends badly. But what we do in the meantime is we provide them with a new life. So why do we replace joints? So first of all, we replace joints to relieve pain, to aid in regaining mobility and quality of life, and to add a full life in the old age. So keep people active, keep people independent. So I'm not sure whether the video will be working, but so what is an ideal total joint replacement operation goes like? No, not working? All right. So what this video shows, or should have shown, is that the operation takes place, and as soon as the patient wakes up, he walks out and... Okay, so there's the video with the sound. So you won't see any blood, so don't worry. So I think the surgeon is happy with his work. And that is ideal, you know, this is absolutely ideal. Patient wakes up, shakes the hand of the surgeon because he's very pleased with the outcome of the surgery, of course, and walks and dances away. So that's what you really want in surgery. It's not always the case, but that's what the ideal surgery would be. We wouldn't need any beds at all, so patients would walk straight from the operating home, and there would be no bed blockers. Kier would have all these beds to put all these lung patients in, and you know, we would be cheaper. So, but it's not all singing and dancing. You know, the outcomes are not always as good as we hope. The expectations the patients are getting. You know, now the patients want to climb Mount Everest with new joints. We know that joints live for about 25 years, but that might not be enough if you put them in at the age of 20. The demand is growing, and we're not sure whether we will cope with the demand. The training of our junior doctors and registrars is struggling a little bit, and certainly has taken a big hit when COVID hit. The accuracy of surgery is not always the case, and even in many hands, but also in my hands, when we look at a post-op X-ray, we always sometimes say we could have done a better job. And every surgeon might have an off day. And medical legally, orthopedic surgeons are not spared from one or two complaints, especially leg length inequality, making one leg longer than the other, dislocation afterwards. And this was, you know, well versed already in the beginning when Bill Harris, a surgeon from Mass General, wrote his book on vanishing bone. And there was two concerns that he dealt with. He was one of the inventors of the new plastic, which you know, the original plastic was only lasting for 10 years, but now 20, 25 years is pretty common in plastics. But he wrote a book about vanishing bone, and looking at how to deal with the problem of the polyethylene wear and the cement disease, but also how to deal with the problems of mortality following surgery. But how do we measure success? I think that's a very successful procedure. You know, the panel is where it needs to be, but it took 4 hits. So I don't think that's very successful. So when we look at outcomes, we look at patient-reported outcome measures, and they've got generic and disease-specific outcomes. You've got experience, so what the patients do think about the food, whether the surgeon smiles, whether the nurses are smiling. We also have the clinician-reported outcomes, which is mortality, because some people still pass away, unfortunately, very, very minority, but also when they have to have reoperations, when they get readmitted in hospital, but also administrative measures such as length of stay. And more, there's more and more interest in value. So what is the value of the procedure, which is not really a figure, but a concept. So new technology is necessary, and we dealt with new instruments. If you look at the instruments that Insol and Charlie were using, they're certainly not the same one as we're doing now. So we use navigation, we use patient-specific instruments and robotics, but we've always been aware that there is a need for stepwise introduction of innovation in orthopedics. So we heard about innovation earlier on, we heard about vision earlier on, but you know, if you introduce something, you need to be able to say that it's better than what's happened before. And one of my supervisors in the past, Henrik Malko, wrote quite a lot about the stepwise introduction of technology and implants. Do we need new technology? I'm going to show you x-rays. So if anybody doesn't want to see x-rays, please close your eyes. So this is a patient that came to see me with a problem of his knee. So for the non-clinicians in the room, this is an arthritic knee. But what is very important of this knee is that the alignment is not correct. So he had a fracture before. So he had a road traffic accident when he was younger, and he has got what we call a malunion. So that's the tibia, the shin bone. So normally that piece should sit completely underneath there and in line. This gentleman's problem is not the old fracture, but this problem is he's got very arthritic knee. And he can't ride his motorcycles anymore, and his daily activity of daily living is very, very poor. So he wants something done. He's seen a couple of my colleagues before. They said we can't do anything about it. But then comes technology. And I think with technology, we're able to provide this patient a new lease of life. So show you the same pictures again. So that's when you look at it from the front. And this is the operation, which you cannot do with the traditional methods. You have to have some kind of assistive methods. And in this case, this patient was treated in Exeter by a surgeon who's quite innovative and uses the robot we're going to talk about. So same for the lateral position. And this is a perfect position for the implant. And I had an email back from this patient, and that's what he writes. So after 5 weeks, he's already very pleased with the outcome. And normal patients after knee replacement after 5 weeks don't say they're very pleased with the outcome. So stepwise introduction of technology. So and where do we come in place now? So what are the current problems in arthroplasty? First of all, dislocation, the hip popping out of joints, longevity in young patients, and patient-reported outcome measures. We know it's a very good operation, but it's not a perfect operation. We know that 90% of the people are happy, but that makes 10% of the people unhappy. In hips and knees, it's even worse. Infection and periprosthetic fracture are also problems that we encounter, but we don't think that technology will help for those, certainly not assistive technology. And knee replacement, same problems, instability, which is pretty similar to dislocation, but not really dislocating, longevity in young patients, patient-reported outcomes. We know that 80% of knee replacements are not happy, and we would like to make that figure lower. So what do registers tell us? And my background is in register research, so big data. We know that long-term outcomes data is still missing. Our NGR, which is the UK Joint Registry, there's no data on robotics as it's not part of the minimal data set, so the NGR doesn't record whether it's a robotic-assisted operation or not. The Australians, however, are a little bit more positive towards technology, and they've been embracing computer navigation robotics for quite a while. So they've been publishing on 3-year survivorship in unicompartmental knees with good results, and as well as a reduced revision rate for dislocation in total hip replacement with navigation. So navigation is one step before the robotics. So now what do they say about knee replacement? So if you look at the figure from the back, it's very difficult to see. But what you can see is the green line is the robotic assisted, and the lower you go to the horizontal line, the better. And the higher you go, the more revisions you got. So the computer navigated non-technology assisted is slightly worse than the robotic assisted. However, because the figures are still low, it's got a trend to statistical significance, but it's not statistically significant yet. So if you then look at the total knee replacements, you can see for primary OA since 2015 is that there's also a difference in line. They're very conservative what they're saying, because in statistics, if you don't have statistical significance, you can't really say that it's better. So there is a trend, but they're on the fence and say, well, maybe we're not there yet. But if you look at the next figure, when you compare patients that are under 65 and over 65, you can really see a divergent line. So for the young patients, robotics might really work. But this is not an RCT, and the gold standard in surgery and medicine is RCTs. So we've evaluated so far using systematic reviews, learning curves, surgeon stress levels, and it all seems to be better. Surgeons are better in using robots as long as you embrace technology. We also have some studies about plans versus achieved. So what you plan prior to surgery and what you achieved after surgery. We use CT scans of all these patients, and we know that positioning is better, alignment is better, there's less impingement. We can guess the sizes correctly. So for members of your team about stock and having a more lean theater where you don't have to open 20 trays for an operation, but instead only 4 trays, this helps. We are aware that proms are better, patients are recovering better, there's less complication adverse event. But what are we comparing in all these big studies? Are we comparing implants? Are we comparing surgeons? Are we comparing the execution of a plan? And what about the outcomes? Are we really recording the outcomes properly? So we were very lucky, thanks to the efforts of Chris and Leighton, to be considered for the robotic surgery trial in Hywel. So this is the surgical team, and you can see many smiles because they're very, very pleased and very, very keen to get going. You got the robot in the background, and this is a different type of robot than the Da Vinci robot. So the surgeon is holding the control and is standing next to the patient. So we're next to the patient. So it's computer and robot assisted surgery. It's not pure robotic surgery. So when we entered the Race and E study, this is the advert from the website from Warwick. You can only see happy smiling faces. So presumably you've seen lots of happy smiling faces in previous presentations. That's what we want our patients to look at. We had our site visit on the 26th of January 2023, and we commenced very, very shortly afterwards. So we had a first learning study where we had 10 patients that were guaranteed to have the robot. And followed that, we're doing 35 patients that are be randomized. So all patients will have the same preparation. So they'll have the CT scan, they'll have the same x-rays, and they will not know whether they have got robot or not. So the only person that knows it, or the only people that know, is the surgical team, and everybody else is blinded for the outcomes. And that is really whether we can see what the outcomes will be, whether it's going to be any different. So what they're going to measure is they're going to measure in-hospital and imaging. So they're going to test again planning versus achieved. They're going to measure surgical time. They're going to measure the pain scores very early after surgery, the opioid use, because as we are aware, there's an opioid problem. A bit more in the States than here, but we still use quite a bit of opioids following surgery, need for transfusion, time to discharge. But also what is very important is what are the patient-reported outcomes. What does the patient think of the surgery? And we traditionally do Oxford hip scores and Oxford knee scores, but we feel this might be a ceiling effect. So there's a new score that's now been tested and validated, which is called the forgotten joint score. So if you forget that you have got an artificial joint, that's a great sign. So you want to live a normal life and really don't think that you've got an artificial joint in there. So all these smaller figures which you can't see from the back, these are all the secondary outcomes. But there's also Raise the Hip study. And we had a Raise the Hip study, and these are the slides they sent me yesterday, so I had to put them in yesterday. But we're not the Golden Jubilee Hospital. I would have loved to be there, but I'm not here. I'm in Prince Philip. So Golden Jubilee Hospital is doing 3,500 joints a year. We used to do about 1,000 a year, but since COVID, we're doing about 300 a year. So for a high-volume hip surgeon, it's very painful to see how the decline of the service. But we're going to get better again, so we're positive. So what the Raise the Hip study does, it's once again, we're looking at PROMS, forgotten joint score is once again the new score that we're doing, but also we got secondary outcomes. The team is still very, very keen. The patients are very keen to be registered. We're very proud to be part of the research group. Because the choice was between Cardiff and ourselves, and I'm not sure whether there's any Cardiff representatives here, but having the upper hand over Cardiff always feels good for a little town like Llanelli. So why did we get the luck of getting involved in the study in Prince Philip Hospital, and PPH's Prince Philip Hospital, or as some other people, Prince Peter's Hospital, but that's not true. So I think what they were looking for is the real-world experience. So we've been hearing about real-world experience before. Not everybody is a Cardiff Hospital or a Stanmore Hospital or a Golden Jubilee Hospital where you do high volume. So yes, I'm a high-volume surgeon, but I'm in a relatively low-volume unit, so it's a real-world experience. So if it works for a unit like ourselves, it certainly will work in the rest of the world. There was previous great experience of the research team with the R&D team and involvement. We got the NGR legacy, so we've always been earning golden stars in the NGR for our good quality work, not only with data collection but also with the results. And there was a great understanding between the sponsor team, which I don't tell you in a secret, is Stryker, and the team at AGD, so the theatre team. We had good cooperation, the surgical teams, my colleagues and myself. There's a strong MDT with the wards, the physiotherapist, and also the team at TriTech and R&D made them feel very, very comfortable with the speed of the paperwork and how we got things done. And really a very big thank you for Chris, because originally we weren't allowed to start because of a financial problem within the health board, but renegotiating it made it work. And as you've seen on the picture, the eagerness of the team to make it a success has really been a big drive. So in conclusion, the orthopedic team in Prince Philip is a part of a national multi-center blind RCT, comparing surgeon versus surgeon and machine. So You know, you've got the surgeon and a surgeon and machine, and that's why I tell my patients, you know, the operation will not be done by the robot by itself. It's still me controlling the robot. The race and knee replacement is well in the way. The hip replacement, the first hip replacement will start on the 13th of November. The patient's fully aware of that, so he will be the first patient. The experience of the patients, the staff on the ward, staff in theatre, the R&D team and trial team is great. You know, they're really very keen on taking part in this study. And a real world experience encompassing value, because, you know, value, getting the patient central in the outcomes of the study is really good, and seeing whether it will deliver value for the NHS. Other outcomes of interest, and I think that's the way forward. You know, I've been mainly a quantitative researcher so far, but I think doing some qualitative study on this and looking at patient experience, not only problems but patient experience, but also staff experience, and looking at the broader picture, what it feeds back to the team, I think is very important. And this is my last slide. Thank you very much for your attention, and I hope I didn't disturb you too much with the X-rays.
Sorry, need me specs. Thank you, Peter. Right, our next speaker is Dr. Daniel Harris. He's the lead pharmacist for cardiac services in Hywel University Health Board. I was panicking then. Yeah, so stage is yours.
Thanks, John and Chris, for inviting me along. Let me just see if this works. That way. Yeah, thank you. So, I think quite a few of the speakers today have given a bit of a flavour for current stresses within healthcare and sort of the picture for the future. We've got aging population, inevitably growing proportion of that population with risk factors requiring work, whether it's orthopaedic work or cardiovascular work we come into. And it's certainly fairly evident from a population around us that we've got a population with high amount of cardiovascular disease and an even greater proportion of the population with risk factors that are going to lead into cardiovascular disease in the future. And that's a problem for us. Fortunately, I think in cardiology, we've got a very good evidence base, and it's not really a case of figuring out what we should do for people. We know what to do. It's really a case of how do you deliver care to such a large proportion of the population. So this project I'm going to present on is really about firstly describing the population with cardiovascular disease, so not just coronary artery but stroke and peripheral vascular disease as well, and then identifying sort of opportunities to improve the outlook. So what proportion of this population is not receiving optimal evidence-based medication, and then figuring out and evaluating the service to deliver that care to them. So it's a project's partnership between Hywel Health Board, Swansea Bay and Swansea University. It's sponsored by Amgen, which is a biotech company brass-plated in California, and we received an unrestricted educational grant for this work. We're very grateful for. Amgen very much take a sort of arm-length approach to this and don't get involved in sort of the day-to-day data collection and sort of logistics of the project. They're an arm-length sponsor. So why are we doing this? Well, we know atherosclerotic cardiovascular disease is the main cause of death across the world, particularly in Wales. And the most effective way of preventing cardiovascular disease and death from cardiovascular disease is providing evidence-based treatments for lipid management and hypertension. This first sentence, it doesn't say a lot really about the standard of health within a nation. If you look at UK, we have, it's number one killer in the UK. It's also number one killer in sort of developing nations as well. And I guess maybe the aim of a good healthcare and a good sort of health across a society is maybe to be realistic, that you're not going to prevent it in everyone, but hopefully you can push it to as far along in someone's lifetime that it get, you know, you develop it at your natural expiry, so you're not living with multiple diseases at a given time and living quite miserably very often. So I guess maybe the goal of our healthcare system should be to sort of push this down the line rather than, it's nice to keep people alive with it, but it's better to sort of keep people living longer out of our healthcare system. And inevitably the best way to do this for this patient group is lipid management, blood pressure management. Maybe that didn't quite answer why we're doing this project. This is a study from our colleagues at Swansea University, and they looked at population that high risk of developing cardiovascular disease or haven't had it yet, and they risk stratified patient groups. So on the left hand side, it's high risk patients receiving lipid-lowering therapy. On the right hand side, it's very high risk patients receiving lipid-lowering therapy. And what you see is that the high risk group, I think it's around about 2/3 of uncontrolled lipid levels. In the very high group, even a greater proportion of uncontrolled lipid levels. Maybe this paints a slightly better picture. This is a study we published a couple of years back. We created a national cohort of patients that had coronary artery stenting. So a contemporary group of people presented to NHS hospitals. 95–98% presented with a heart attack. The remaining were sort of elective patients undergoing coronary artery stenting. Once you had the stent put in, the key thing is you take antiplatelet therapy, stops the stent blocking up. After that, it's all about risk factor management, and lipid management is a fairly simple thing to do. What was interesting in this group of about 25,000 patients, a third of this group didn't even have a lipid level taken in the year following the stenting procedure. So we spend an awful lot of time, rightly so, developing techniques to put stents in people, and then sort of miss the opportunity to keep this group of people out of hospital in the future. So a third had no lipid test taken in the year following stenting. Of those who did have a lipid test, less than half met the previous ESC standard lipid levels, 1.8 millimoles of LDL cholesterol. Less than a quarter met the updated guideline standard. And when you look at people so below the threshold and above the threshold, you see that this higher risk group here are receiving less intensive therapy and more likely not to be receiving therapy than the other groups. I think this is kind of selling to us that there's a gap in the provision of very quite simple, highly effective, cheap drug treatment that keeps people out of hospital and living for longer. So that tells us a little bit about why we're doing this project. So there's two elements to this. One is at the population level, so it's using the SAIL data bank to describe the prevalence of atherosclerotic cardiovascular disease in our population and describing the proportion of people who are going to go on to develop this, so a primary, high-risk primary prevention group, and then evaluating how we're managing this group optimally and what is the opportunity to do things better for this group of people. I suspect many of you know what the SAIL data bank is. It's housed in Swansea University, and I guess it harvests patient data, anonymous patient data from our primary care system. So if you see a GP, you know, it documents why you were there, diagnosis made, medications, tests requested, and so on. And it also does this for people entering hospital as well, so we can see the other element. So when they come in, how long they're in, diagnoses made, and so on. And then it also, any interaction with the government body, whether it's an education system, social care system, prison system, we have that information together. Now, there's lots of places that have this kind of data. Many data banks have much larger data sets, or much more, much greater population than Wales does. But the real beauty of SAIL is that you're able to match people up through different data sets. So you can see management in primary care, hospitalizations, they sort of socio-demographics and ethnicity, where they live, even if they have a gas boiler in their house or oil central heating, the languages they speak, and so on. So it gives us a much greater granularity of information to to conduct this research in. I think this is really important because when we took on this project, there's tons of information, or you'd think there'd be lots of information out there saying what the picture of cardiovascular disease is like. There's actually not a lot of contemporary data that's of use. A lot of it is conducted from systems where you only have access to components of the overall picture, so maybe just primary care data or just secondary care data, so you can never really stitch together what it is we're doing and the scale of the problem quite like we can do in SIL. So that's the first part of the project. I guess my colleague refers to this as stamp collecting, and you can do these projects all the time and get them published. But I think it's the second element of this we call sort of posting the letter, is where you describe the problem and then try to find a solution to it, or at least know what doesn't work as a solution. And this is undertaken, so the second part is at a practice level. It's undertaking or delivering a pharmacist-delivered, MDT-supported cardiovascular risk optimization clinic that focuses on lipid management and blood pressure management. And at the end of this, we'll evaluate sort of the efficacy and feasibility of delivering this approach, and at least have a slightly better understanding at the end of it, whether a system like this works to solve some of the problems we identify in the stamp collecting exercise. Oops. This probably doesn't quite describe the complexity of the team and how we brought this about together. So maybe it's just start with the university team at Save Data Bank. We've got a team, clinical academics, myself and some cardiologists from Swansea and how of our health boards, team of data scientists, really high-level statisticians and project managers that can make this work for us. And I think the key thing is here, data science is a bit like the emperor's new clothes. There's lots of people that are kind of selling this idea, but you really need to have a team of people that know what the clinical questions are to be answered, and a team of data scientists that can deliver this and bring everyone together. Otherwise, it's easy to get data out of these systems, and if it's not to be that meaningful, we've got a very good track record in delivering these projects. So this is the team from Swansea, and then I guess we've got a team then from across two health boards. And a colleague before, I think, alluded to the fact that there's quite a lot of competition between neighbouring health boards, and while everyone thinks they work together, the reality of it, especially those working in academia, you often don't like people in the department next door to you, let alone in another institute. So it's really, I think it's quite a tribute to people who brought this project together. We've been able to stitch two health boards that inevitably often competed for the same resource and the same staff, and a university together, and got funding from a sort of international pharma or biotech company to do this. And this is just, I think, a small picture of that overall team. A close friend of mine asked, why did Amgen come here? They could have gone to MIT, Harvard, Oxford, Cambridge, London. And maybe there is something in the infrastructure that we've got, unified health boards, linked data, organisations that are willing to work together to bring it to fruition. So phase one, the gap analysis. So as I said, we've got the Save Data Bank. It's got all hospitalisation records going back to about 2020, and it has about 90% of primary care data. And the aim of this project is to identify those with atherosclerotic cardiovascular disease and those at risk of developing it, and also plotting that trend line over time to see, I think it's quite important for us to see what has changed in healthcare over 20 years and how that picture is continuing to change, particularly if we want to do some future modelling. Then asking questions within this group: are they receiving the appropriate preventative medication? Are their risk factors controlled? And where the risk factors are not controlled, are they receiving suboptimal treatment? So that's our gap and opportunity to improve things. And then maybe validating a novel sort of risk factor tool for identifying high risk patients. There's lots of these out there, and inevitably what they tell you that old people, people with lots of other comorbidities, particularly diabetes, particularly people who are overweight, go on to have further events. You don't need us to tell you that. But I think what we ought to be thinking about is developing a prediction tool that tells us who the patients are that may benefit most for more optimal, aggressive pharmaceutical management. And then the phase 2, the population gap closure. So this is evaluating, it's one pathway across 3 different models of care across the 2 health boards. And the first part of that is, can we identify people who need our treatment? And that is, you'd think would be easy, but it's a little bit more difficult than we initially thought, but we're getting around that. Then once they identify and come into our service, reviewing the risk factor control, it's not just for hypertension and dyslipidemia, but weight management and various other glycemic control and so on. Optimising the treatment according to our standards of care, so NICE and ESC guideline recommended care. There's nothing experimental here. We're just implementing what should be standard of care. And at the end of it, and the other key point to make is evaluating the accuracy and efficacy of near-patient lipid kits. That's quite valuable for us. That if you review a patient and they've got high risk factors for cardiovascular disease, you then got to send them away to have a blood test. That takes a ridiculous amount of time and effort, and then you've got to bring them back into clinic. So actually, if you can figure out what their lipids are like from a finger prick test, then kind of eliminate another 2 steps in sending someone away for a blood test and bringing them back again for further review, particularly when one of the resources we're very low on is personnel to deliver these programs. And then sort of at the end of this, evaluating and getting patient feedback from PROMS and PREMS data and evaluating the health economics of it and the efficacy and feasibility of delivering this service across different settings. Now, in terms of, I said, is one treatment pathway across 3 different settings. So the treatment pathway, so patients brought in baseline to sort of basic recording of the clinical risk factors and blood taking, collecting of PROMs, an evaluation then of whether she have additional treatment, inevitably probably prescribing some additional treatment or recommending some lifestyle changes and bringing them back after 2 to 3 months to evaluate response to treatment, side effects, and where we go to next. And then the program allows us to have sort of multiple repeat follow-ups with these patients and the telephone consultations in between with the nursing staff involved. I think from the about 30 or so patients we've got through this so far, most are requiring probably 2 to 3 appointments. There's a handful that are much more difficult to manage, intolerant to many of the medications we try, and we're probably going to have to bring them back a few more times. So that's the pathway. And I said it's one pathway in 3 different settings across 2 health boards. So there's 75 patients recruited from Swansea, 75 from Hywel. Patients recruited from Swansea we see in either in Singleton and an outpatient setting or in some of the local GP services in its vicinity. And then 50 patients in a primary care hub in Hywel out in Ceredigion, and then 50 patients split, so 25 in a GP practice locally, 25 in Hywel. So that's the pathway. Expected outcomes. So I think from the population level data, it's really important for us to know how many people are out there with atherosclerotic cardiovascular disease, as a coronary artery disease, stroke and peripheral vascular disease or multivascular disease, and then what proportion of that group are suboptimally managed. And then I guess it's understanding what that gap looks like, how much you can close that therapeutic gap and what that would mean for life expectancy, life saved, reduced admissions to hospital, and so on. And then from the clinical pathway evaluation, it's understanding, I guess, the logistics and the feasibility of delivering this care pathway in different clinical settings, and understanding, you know, the differences maybe between sort of delivering care in very urban settings like where we currently are to very rural settings out in Hywel. And then gathering patient feedback, preferences from the staff involved in it and the GPs prescribing referring these patients into the pathway, and putting together an evaluation of these two aspects of the project. Progress. So on the data side of things, we've already got a first manuscript for review. It's documenting, I guess, the time trends in presentation of atherosclerotic cardiovascular disease from 2010 up to current date, bridging the pandemic, so we're able to have a little bit more insight into how the pandemic has impacted diagnosis and treatment, and implications for the future, and how we've sort of delivered risk factor management across this period through sort of multiple guideline updates and, you know, I guess the development of treatments and so on, and we can evaluate where we are against a gold standard of care, I guess. Primary prevention gap analysis is underway, so we're now looking at those who are high risk of going on to develop disease, particularly diabetics who are very high risk of developing disease, and again evaluating whether they've been treated according to the guideline standards. We've got patients up and running, enrolled in Swansea. We've got some going through right to the final stages. And we've got recruitment set up in Hywel, so I think probably by the end of November, we're about 50 to 60% way through our recruitment plan. So it's going to plan. Next steps. I think part of the reason for doing this is to maybe lead to a sort of pragmatic randomized control study, so we can upscale this service into a wider population and provide a stronger evaluation of it. But even without that, what the plan is, I think, is to have the real world data, the population data that describes the problem, and a service evaluation that will hopefully go some way in addressing the best ways of delivering care, and that we can take to the executives within the health board, policymakers in government, and so on, to lobby and say this is the scale of the problem, but we're also providing potentially some of the solutions to it as well. I think that's my last slide. So, any questions?
Next here. Thank you, Dan. Our final presenter for this afternoon's session is Professor Keir Lewis. He's Medical Director of Respiratory Innovation Wales and Clinical Lead for Respiratory Medicine and the TriTech Institute at Hywel University Health Board. I've been really impressed with the timekeeping of you clinicians. On point.
So no pressure then, Sean. Okay, thank you very much. And forgive my voice. This isn't a smoker's voice. It's man laryngitis, I promise you. So I'm going to talk about telemonitoring for chronic obstructive pulmonary disease. This is a lung disease that disables and kills people. It's mainly related to smoking. It can cause a lot of disability. It's one of the main reasons why the ambulances are queuing up outside Morriston and Prince Philip every winter. So it causes a lot of devastation. Can we do something remotely using different and modern technology to help people stay at home for longer and to live a healthier life? These are my disclosures, and I'll spend more than a few seconds, so please welcome to read them. And I really want to tell you a story. So I'm going to tell you my personal story about how I've got interested in telemonitoring, the past, talk about what we're doing now, and actually some really interesting future studies that are being planned. And you can see how long ago this was. This was one of my original slides. You can see from the monitor and the hairstyle that this goes right back to the 2000s. And this is where we started with a better breathing project funded by Europe when we were members of the EU. And this was a randomized control trial looking at something called DocuBlue monitors in people's houses. It doesn't project well, but on each of those monitors, you can see oxygen levels at the top from day to day, and you can see questions on green, orange, or amber. Do you feel better, worse, or the same? And these people completed this every day, and the idea was, if someone deteriorates at home, can we pick it up early, and can we treat it before it becomes a full-blown attack that needs admission to hospital? It was a small, randomized controlled trial with full ethics. And I'll just show you some themes that are going to come again and again, and what I've tried to learn to make things better as we move along. So one of the first theme, number one, they were 40 stable patients. For proof of concept, you need to get patients who are stable and keen in the beginning, just to see if they can use the kit. Don't pick people who are really unstable and got a lot else going on in their lives. They'd all had something called pulmonary rehabilitations. They were highly educated, highly motivated patients. Finding number one, which is a theme again and again, the telemonitoring was really well used. We put this piece of kit in the house, and 96% of people used it. And that compares with about 35% of people who use asthma inhalers, or 40% of people who use inhalers for COPD. So less than 1 in 3, 1 in 4 normally use inhalers, but 96% were using these monitors. This is remarkable. We did statistically reduce GP visits. They went to see their GP less when they were on the monitoring system, possibly because they thought someone was watching them at some point. And they went to see the GP less for other conditions, or less ingrown toenails, less diabetes, whatever it was. It wasn't just respiratory, which was interesting behavior. No difference in hospital bed days. Okay? Theme, an important theme that comes again and again. No change in quality of life. They were just as happy or just as miserable anyway. But monitoring someone, will it make them feel happy or better? But we have to do these, what Peter calls prems and proms. But we learned a lot about patient selection and early infrastructure. And the theme is not just the patients and technology, it's your infrastructure. What Darren was saying about the infrastructure of the hospitals and the practices. That's where technology falls down in the NHS, as we mentioned last year, is the NHS infrastructure. Then we got quite confident and cocky, and we thought we were going to do a large randomized controlled trial funded by Carmarthenshire County Council, Docabo, and another company called Tunstall. And it was a complete and utter disaster for various reasons. 120 people were supposed to be randomized. We stopped at about 30 patients for various reasons. Then we were given a lot of money with a few other countries, and we were the lead looking at chronic conditions. Can telehealth work across not just health boards, not just trusts, not just UK, but can it work across Europe? And this was a 21 million euro grant, and Hywel led on the COPD arm, but we also looked at diabetes. So we led 5 countries. You will see some of these countries in a minute. It was Scotland, Galicia, Spain, Norway, southern Norway, Belgium, Germany, and Wales. Here, when people were admitted to hospital and they were sick and they were scared and they had low oxygen levels, we decided we'd try to randomize them into research, and they'll agree anything when they're in hospital. That's one thing I've learned. And as soon as they leave hospital, they think they've had enough and they don't want to know you. So again, nugget number 2, if you've got really unstable patients, you've got to really bond with them at that time. And the only place we found it was feasible, and this was using special criteria that were predetermined, was in Galicia, in Spain. Surprisingly, because they had the telemonitoring system already there. The infrastructure was there. Possibly worked in Germany, and I thought, well, Germany had to recruit 40 patients, and they recruited 40 patients in a week. I thought, that's amazing. That's ruthless German efficiency at its best. I thought, how could they do that? And then we went back, looked at the data, and they recruited in their patients from a nursing home. So I'm thinking, hang on, you're telemonitoring people to look at their OBS and their SATs when there's nurses in the nursing home doing it by the bedside anyway, being sent to the nurses who are free-fit away. Not a lot of good evidence for doing that, really, but they recruited very well. So you want to recruit them, and this was United for Health, and please look at this. This helped warn European policy and Department of Health policy that if you're going to use telemonitoring, be very careful. And I thought, that's it. I'm going to do no more now. I've had enough. I'm going to quit while I'm behind. And if you look at the evidence base in clinical journals for telemonitoring, this is a very famous pyramid, a value-based pyramid is called. So the most cost-effective thing for COPD is still the flu jab at the bottom. For the GPs, £1,000 per quality adjusted life year. It's really effective and it's really cheap. Second best thing you can do is them to stop smoking. Third thing is pulmonary rehabilitation. And then you've got all the drugs. And the most expensive thing at the top was telehealth. Up to £40,000 to £180,000 per quality life year, QALY. Then all the meta-analyses have come out now with the randomized trials. They all say it's popular, patients love it. They all say it's really well used, 96% of people use it, really good. Possibly improves quality of life, not really reduces emergency visits, possibly it doesn't reduce bed days, and there's no consistent effect on exacerbations and no effect on days in hospital. And you think, so if we do monitor it, we're not making any impact. If you're going to have an exacerbation or pneumonia, you're going to have it whether you're on a monitor or not. If you treat it earlier, does it make a difference if you haven't got very good treatments? And that was a theme that we found on 3 different projects, and it's interesting that the meta-analysis has come through again and again. Those are the themes. So I thought, okay, let's go back and do something else instead for 10 years. But, and this is a but, technology is changing anyway. It's happening all around us. Whereas people using exoskeletons to walk, where there's new implants, it's changing. Patients are becoming more tech-savvy all the time. They are far more tech-savvy than we give them credit and more tech-savvy than me. Digitalization of care is happening. It's happening whether we're part of it or not. It's happening. All our records are going to be digitalized in my lifetime, I hope. And also, those of us who are on the front door, we know our traditional systems are breaking. What we're doing now in the NHS is not working. We know it's not a nice place to live and work, and it's getting worse. So why keep doing the same things? Let's change our ideas. And particularly with telemonitoring and technology, I've learned in different technologies, I don't think randomized control trials are the right answer for these kind of technologies. Can anyone think why RCTs are no good for technology? Any ideas? So time taken, Peter said. So by the time you do a randomized trial, that technology's moved on anyway. An RCT will take 5 or 6 years to come back. Your mobile phones will change every month. So we'll be doing randomized trials on an iPhone 6 at this point, knowing we're now on iPhone 15. So the technology's moved on. One of the other things with randomized control trials is they're pure in their selection. So they're good for looking at something called efficacy. But in the big respiratory trials, we've gone back, and these are mega-breaking respiratory trials, for example, in COPD, only 5% of our patients were eligible for the top COPD trials in the world. 95% of our daily patients were excluded because of other illnesses. And then we apply that then to everyday life. It's wrong. So we need to start thinking about real-world studies, like Peter was saying, in the dirty real world, small places outside the Golden Triangle, and think differently. And then, of course, COVID came along, so we had to go virtual, whatever we did. And telemonitoring and telecommunications started to take off big style. So I'm just going to present some of the present, just what happens at what we do in a moment. This is a company we've been working with called NuvoAir. And on this one, our nurses just refer, and the company, a digital coach, contacts the patients and teaches the patients online and through the phone and through their grandchildren how to put the technology on their phone. They monitor themselves. They do not ask the nurses to monitor. The NHS does not own the data. Okay? The patients own the data, and they send alerts. If you've got certain things happening, the company sends an email to the respiratory nurses. The nurses don't have to look at the data every day. And we can do things like blow-in test at home. So we connect a little peripheral to a mobile phone, and it goes straight to the phone, up into the cloud, and we can look at it in the cloud. And that's a breaking concept. It doesn't go into NHS terminals. We don't need IT, IG governance issues to own the data. It goes into the cloud, and it can be mapped and analyzed directly from the cloud. The other thing we've done differently is we have a clinical meeting every 2 weeks. We have half an hour where the company and my respiratory nurses and the team, we have a 10-minute, 25-minute chat before I go to clinic, and we look at recruitment and retention, and any particular patients are doing dodgy things with their monitors that they shouldn't be doing, we keep an eye on them. And that regular touch point, less than 20 minutes, drives the project, drives the communication. And that was a real golden nugget I find, that anyone, when you commission a service and a company says, here's the monitors, off you go away and do it. And we don't hear from them again until the next bill is due. It's that ongoing relationship that deals with real problems in the real world, I think, has helped us. So this is a bit out of date. Of the first 65 people onboarded, 80% love it, and I want to keep using it. And these are, on average, 69 years old people. And they like it and they can use it. 71% are using it for more than each day for the last year. So that's massive adherence. And weirdly, they're doing spirometry, which is a blow-in test in their phone every week. And those of you who know anything about lung function, that's when you have to blow into a machine. Because we can't do spirometry in primary care anymore because it's COVID. No one's been trained how to do it, or they've forgotten they don't want to do it. We've just gone back to the patient and said, why don't you do it for your phone and send us the results? Bypass primary care, bypass secondary care, and just go straight to us. Can patients do it? Yes, they bloody could. This is amazing. So 80% of patient spirometry was grade A to C in international standard guidelines. They were hitting the right level. That compares with 37% good quality spirometry in primary care. So patients being coached could do it better than doctors and nurses coaching them. This is a spirometry. So I was amazed by that. I didn't think that could happen, but it can be through the phone in their own house. And the other thing is, when someone comes to hospital for a lung test, they're running around or being wheeled around in a wheelchair for 30 minutes trying to find a parking space. Then they can't find a parking space. Then they're being panicked. Then they walked into outpatients. There's 30 people there. You go, and then wait, do a lung function. Back to see the doctor. Oh my God, there's a doctor. And weirdly, their lung function's all abnormal because they're still hyperventilating. But doing it in their own home, in the afternoon, in the morning, when you're relaxed and you've been coached, far more reliable, far more predictable, and we can pick up changes, not just when there's no car parking, but when things really are going wrong. So we found, again, only 4 months monitoring, no differences in emergency attendances, no differences in days in hospital. But what would you expect in 4 months? But a massive reduction for the first time in nurse home visits. We've only got about 3 nurses left. The others are all off sick with bad backs because they haven't been wearing the exoskeletons. But the ones who are left, only 3 of them left, how can we make them work more efficiently and feel needed? So they're not driving halfway up Ammanford one morning and then across to Trimsaran and then to Ceredigion and then back. They can do 20, 30 patients in an hour through a phone and only see the 1 out of 30 that's deteriorating. So they're working more efficiently and they're massive reduction in visits and they're learning to trust the technology. And then by touching base with people like me once every 2 weeks, they can bring problems to me direct. No difference in quality of life. This is a bizarre one. So people with lung function was only 30% of their lungs are working on average. They took on average a median of 2,000 steps a day. I thought, what, these people who were on oxygen, 2,000 steps a day? I was amazed by that. I'd be quite chuffed if I had 2,000 steps on my average day in work. Either that or they tied it to their dog. So they got sensors working. And I think that's a really interesting patient-reported outcome. Not how breathless you're feeling. How many days, how many steps? It's quite objective data. And some of them, on the sheer right of the graph, we had about 5 patients doing 10,000 plus steps a day, with lung volumes of 30% of what it should be for their height and age, who are officially breathless, disabled people. So I'm learning that how far you walk has got nothing to do with how breathless you feel or how much lung function you're measuring. But that'll be a great outcome for drug trials. Can your new drug make someone walk more than 4,000 steps per day? That means more to a patient than their lung function test, doesn't it? And we can measure this with technology now in their own beds, in their own houses, in their own streets, in their own shops, in the cigarette shop, in the vaping shop. We can do it. This is a little bit of humble pie in public, and I'm proud to do it. And this is someone whose lung function at the top was deteriorating. So this is the top, just one way, but the top 3 lines measure how good their lungs are on their phone. And they deteriorated because the air quality got worse. So we just mapped it onto into a usual a weather app, used AI, and now, as the deterioration got worse of air pollution, people's lung function deteriorated. And we measured it in their own homes again and again, and it was changing. When the heat wave happened in the summer, all these people's breathlessness scores went off the roof. And so we can now plot this for the first time. And these are not people with asthma. These are elderly people with chronic, irreversible lung disease. But it is reversing. It's changing. It's changing with the weather, with the pollution, with pollen counts. So I'm learning about this condition. I'll see more about it this, and I only see him for 10 minutes once a year in my clinic. But I suddenly get this amazing rich data, and I understand COPD more now than I did 2 years ago. This was a lady who was definitely diagnosed as severe COPD. So we gave her tests, blow-in tests in clinic. We gave her steroids, and she didn't get better. So we said, it's not asthma, it's called COPD. It's irreversible. And the lung function is at the top. And then she started doing it at home. And see where the top red square is? I don't know if there's a laser pointer here. Nope. This square, that first square. So she did the blow-in test on her own, relaxed in the afternoon without looking for car parking spaces. And the lung function kept getting better in the afternoon. And I thought, why is it getting better in the afternoon if it's so-called irreversible progressive? And it's because my clinics have always been done in the morning. And people with asthma get tight-chested in the mornings. And for 20 years, I and other people like me have labelled her as COPD. She's a 50-pack-year smoker. She had irreversible lung disease, bad quality of lung spirometry. But in the house, it's getting better. So we changed her treatments to asthma. And that small red square, it doubled. The lung function doubled in about a week. And she said, it's the best I've ever felt, Professor Lewis. So I got it wrong. And she had all the criteria for COPD in every textbook. I went back, have I made a mistake? And then she got worse again towards the end when the air quality changed. And this was true reversible asthma. And we picked this person up, and she was about to be referred for lung transplant, costing £1 million. So we changed the diagnosis and changed the quality of life. So what I've learned again is individual projects you don't learn from, but a series of projects over 20 years, you start to learn themes. And so you build an ecosystem. So we can say, let's test lots of technology and build an institute, something like TriTech, something like RIW, where you can check different tests. And different companies will come to us now saying, can we test our equipment in your setting? Can we do this? Yes. So we've got NuvaWare and another company called Tunstall. 2 different models, one on the right, one on the left. And I know Gareth's in the audience, so he's going to shoot me down if I get these things wrong. So Gareth Davis did 99% of the work on Tunstall. The process, one was onboarded by the company themselves. The other model, well, you give it to Delta Wellbeing and Carmarthenshire Council, and you get hold of the patients, not us. Process on the left, we met every 2 weeks. Process on the right, no feedback whatsoever. And again, thinking about feedback, when patients do a monitor and they like feedback, like when you, how many times have you done a questionnaire online and then heard nothing? And then they send you another questionnaire, I'm not doing that again. It's the same. They send in all these sats and monitors and go, well done to you. The company said, you've done well today. This is good for you. And it's all automatic, but I feel really good. Okay, I'll keep doing it then. And you will just keep monitoring the system, and the system will learn. The other model, one used a phone, one used a tablet, and they bought tablets for all people, or they convinced the health board to buy tablets for everybody. And that's quite a lot of money. And people don't like extra kit. They like simple things that they carry every day, a phone. Finally, we actually showed a reduction in nurse visits. We got 1 year data coming up in December, but at 4 months there was definite, and the cost is different. So that's where we are now. And technology is getting better and better and better by the day. And all we have to do is build ecosystems within the NHS where we can test it rapidly and feedback rapidly and test again. So there's literally 1 ring to rule them all, and 1 ring to find them, 1 ring to bring them all in the darkness, bind them. Yeah? That's the 1 ring. You wear a ring and it measures your oxygen levels, your pulse, your body temperature, and you don't even know it's on if you want to choose to wear it. Now that comes a long way from a docubo clunky thing we have to connect to an Ethernet into the TV socket. So the technology is not the problem. We're looking at some wearables now. So whether you put a monitor in your glasses that someone like ATiC are looking at, and you can actually scan people's eye movements to see if they've got early dementia, because the eye movements become more erratic as you can't remember things. That kind of technology is here. Wearables, vests. How many of you got an iWatch that's monitoring you right now? When you don't know, you can do it, yeah. So it does work. A lot of people are presenting. I've got atrial fibrillation, Professor Lewis. Have you? I've got sleep apnea. Have you? Show me, and they show you the data. It's great. So they're wearables. You don't even know it's been worn. There's some things where we can actually measure movement of the chest. And there's a place in Bristol where they've got infrared cameras and movement sensors that can actually measure your respiratory rate just by video recordings day and night. You don't even know it's doing it. Now that sounds big brother, doesn't it? But respiratory rate is one of the things that people like me are interested in. And then there's another next technology. The future is here now where you can implant things into you. And that's getting scary. So you can actually, I know myself and Chris are supervising a PhD student in Swansea is trying to develop a patch to measure intradermal pH and carbon dioxide in your skin. You can't measure it on a probe for your finger, but can you measure it in the skin? Like a sticky patch, like an elastoplast. And that can be connected to your phone within the next 5-10 years. So these kind of things are coming. It's not the technology. So if you're going to build an ecosystem, you need to have a location. I personally think it needs to be cloud-based. Please don't go near your IT systems in the hospitals and IG governance. It's just easier. But the other reason I like it to go cloud-based is because it becomes patient-centric. The data's not owned by Hywel. That patient can move to Swansea. That patient can move to Galicia. She might end up in a nursing home in Germany. The data will be there all the time. And the systems can connect to the data. Now, why can't we think like that instead of it has to be in Hywel? It also allows machine learning. And when you've got enough data, like background pollen, your respiratory rate, your age, how many times you've been admitted to hospital, and more you do it, AI and machine learning can build, so it goes from just monitoring to prediction. And it'll predict for Keir Lewis and only Keir Lewis, not the average patient. So it'll learn from you and it'll give you a personalized prediction model. If you've got enough data, the more data you give it, the better it predicts. And AI is, we're starting AI on some other programs at the moment. And again, going back to the location, if there's things called electronic health records, EHRs, you can map it onto any electronic health record anywhere in the world. So that data has to go outside just the NHS. Just has to have the right governance to be able to access it, and the patients can sign a form to say, yes, people can use it on my behalf if I give them my code. The thing I've also learned is funding. Small little projects come and go. Wales does suffer from pilotitis more than most countries. We do it, we don't learn, and we don't cascade it, and then we start again, and someone else in North Wales might think that's a good idea, whereas someone else in Hywel has already cocked up on it. Why don't we just go for infrastructure? We go for longer term funding and learn, and it's an ecosystem. You fund the system or the person, not projects. And I think we are starting to have that kind of arguments and discussion. For tech, any tech, that's the way forward. It's not drug trials. So painful nuggets that I have learned in the last, just for telemonitoring. So that one, patients, pick people who use healthcare, but they're motivated. Hospital avoidance is probably better than assisted discharge for various reasons. Once they're in hospital, you're really on the back foot. The idea is to keep them out of hospital in the first place. I think the technology is amazing and it's changing, and I'm trying to keep up with it. Feedback to users, let them know they're being results. Wearables and smartphones are the way forward, not extra bits of clunky kit in the house. People don't like it. And I actually always use techies to onboard. Never, ever ask respiratory nurses to tell people about onboard them onto a trial and technology. The company knows far more about their technology than nurses. Worst thing you do is give it to a respiratory consultant to try and onboard people. We know from the Tunstall project, you're giving it to primary care, and there's so much pressure at the moment. We just couldn't get people to, didn't we, Gav? I was blackmailing GPs, bribing GPs. I was having kind of dodgy photos, phone calls, please do it. And they struggle to engage, didn't they? Not because they're lazy people, because they were swamped with so many other things. So let the company, let a designated team like TriTech or someone else on board, and just let the clinical teams do the clinical bit and nothing more. And the infrastructure, again, think about ecosystems. And the way I'm thinking about it now is if you're going to base business plans and business models, I'm going away from the fabled bed days. Our finance director says, how many bed days are you going to save me this year, Keir, with your projects? Now, bed days don't exist, and they only if you look at bed days, the hospitals are going to be full whatever we do. They will be full. You can't say I'm saving bed days anymore because they're gone for other reasons. And it only started with Thatcher in the 80s and the GP fund holders what bed days meant. Before then, no one actually cared and used it. What I'm using it for now is technology to help efficiency. Can you make staff work better? We know a mobile phone can help a district nurse work better, as opposed to going back and dialing in on a public phone box. Do you really need a randomized control trial to prove that? Or can you just get staff feedback and show that you're driving less miles and saving the environment? And that kind of real-world evaluation, looking at staff efficiency, I think we're missing the trick here with technology. And it could be technology across any disease. Staff efficiency is really important at the moment, and staff well-being in the NHS. So in TriTech, we look at patient outcomes, infrastructure, but we look at staff outcomes. Will that nurse stay more than a day? You know, are they off sick all the time? Can we stop them being off sick? So thank you very much. That's some personal nuggets on a personal story, just using technology and telemedicine. But I think some of the themes can be adapted to any tech at scale. Thank you very much.
Thank you, Keir.
Yep. Any questions? Okay, so as I'm listening, Leighton's watching. So as an ex-R&D director in the NHS, you learn certain tricks. And one of them is, so for example, in TriTech, we will have an adoption form and we'll ask them 4 or 5 questions up front. And if they answer the wrong question, we say, no, you have to answer this question. So I like now doing service evaluations. And it can be a subtle difference. What's a service evaluation? What's a research trial? And there's about 3 or 4 definitions you can apply, just screening questions. So with technology, it's just little things for people in the audience. If it's got a CE mark or equivalent, if there's no randomization, so you can do before and after, not randomized, what's the third one? If the technology is being used for the process it's designed for, so you can't use it for something it's not got registered for, then nearly always you can do a service evaluation. And a lot of companies have got kit that already has been built. You know, the cobots are a great example. They've got everything. They've got the ISO markings. They've got the CE markings. They just want to test it in the real world. And that's where the gap is. A lot of these companies just come and go within 6 months. They need the data really quick. So time is money. You haven't got time to go through an ethics committee and answer the same questions the company's already done. They want to say, can I work in the real world in the NHS? Is it cost effective? Is it got value? So we've got people who can answer those questions. And they're far more interesting, I find. So we bypass ethics as far as possible, legally possible, but don't tell Leighton I said that. Service evaluation, look up that. It's not an audit, it's a service evaluation. Okay, thanks.
Thank you, Keir. Always inspiring and motivational. And we've got a coffee break now, so we can carry on the conversation and then restart in about 15 minutes, if that's okay with you. Thanks. The final session is going to be a team effort by colleagues from Digital Health and Care Wales, and it's going to revolve around, well, digital technology and data, but particularly big data. So I'll leave them to introduce themselves, but I think Rachel, you're going to start, aren't you, Rachel? So we'll start with our wonderful colleague, Rachel Jemin. And then we'll go from there. So I think that's everybody now. Ready to go? So you can use the clicker, or I find that more easy.
Thanks, Sean. Hi all. Thank you for staying with us to the end of the day. So hopefully we're going to keep you engaged and help you understand a bit more about the work that we do in Digital Health and Care Wales. So I'll just go through the different speakers. We'll introduce ourselves as we get to it. So I'm Rachel Jemin, Head of Research and Innovation, and I joined Digital Health and Care Wales back in January this year. And this was off the back of the development of the Research Innovation Strategy that we launched. And I'm going to talk to you about that a bit in a minute. But first of all, I'm going to talk to you about Digital Health and Care Wales and some of the work that we do. So I don't know how many of you are familiar with the organisation. You probably will have heard the name, but if you're anything like me before I joined, I didn't really understand what they did, what they were doing, what was happening. So Digital Health and Care Wales was set up in April 2021 as a special health authority. So we're part of NHS Wales, and we're really there to help support the digital and data services within NHS Wales. So we are used across the health boards by the NHS staff, and the technology that we're developing is there to help to make a difference to the services, so the way that services are run and the care of the patients. So we have developed different products and services and networks to help support care, and also to help link it so that we can look to how to better support people. We're a growing organisation, so in the last couple of years we've been expanding our workforce, our skills mix, and the services that we offer. And we're really hoping to work towards effectively supporting our different partners in transforming care. So we have several values that are integral to what we do, and these are really important, particularly today, looking at collaboration, so how we work together, innovation, so the differences and the changes that we can make, inclusion, so that we are making sure that we're including everyone, excellence, so having that impact in the work that we do, and also compassion. So some of the different things that we do really support the frontline staff. So looking at how we can modernise the systems. So we heard from Keir earlier about how the digital ecosystem in healthcare needs to be updated. So this is some of the work that we are doing, so that we can really give clinicians that information about patients, and so they can have it available where they are and where they need it. We're delivering new digital solutions to support care, and this is for cancer patients, to help nurses, to modernise their critical care units, to update our hospital pharmacies, to work in the community with prescribers, and also to support patients to have better access to their own records. So as most of you will know, we've got the NHS or Wales Patient app that is now in public beta testing. We also use data to provide insights and look to how to improve the health and care services. So Gareth's going to talk to you a bit more later about the data that we hold and the work that we do with it. But by using this data and these insights, we can really help to transform care. We want to help patients to manage their own health and recovery. So we've heard about telemedicine, we've heard about the different changes, but actually we need to give people access to their own digital health records. And we need to make sure that these apps and these different things that we've got happening in different health boards are actually linked together and working together. We know that cybercrime is an issue. We've got a dedicated team that is looking after this and trying to keep our records safe. And we also work to several digital standards to make sure that we can have faster development of different digital services. And importantly, we need to protect our data assets. So we need to make sure that our data is safe and secure through adopting a cloud-first policy. So within the organisation, we have 5 strategic missions, and I'm not going to go through all of them today, but specifically I want to talk to you about Mission 4, which is driving better value and outcomes through innovation. So as a learning organisation, we want to lead and enable high-quality health and care through world-leading data and digital research and innovation. So it's quite a bold statement. It's also quite a long statement, but really what we want to do is to use the data to improve outcomes. So we want to release that value from the data to advance research and innovation and improve our patient outcomes and support NHS services. So there's lots of innovative projects that are happening within Digital Health and Care Wales. I've mentioned the app. We've also got the All Wales maternity records that we're digitalising, and there's many, many more. So if you have a look on our website, you'll see a whole portfolio of the different work that we do, and I'm happy to talk to anyone or signpost them if they want to pick up on any of those areas. But what obviously my area is research and innovation. And when we launched the Research Innovation Strategy back last October, we had 4 clear strategic aims that we're looking to deliver on. So our first one is really looking at the assets and resources to support research and innovation across Wales. So in practice, what does this mean? So how can we as an organisation help support you in undertaking research and innovation? So one of the ways we're doing this is through better access to data. So Jen's going to talk to you a bit about the secure data environment and the ways that we can enable access to this. We're also looking around the infrastructure in terms of clinical trials, so looking at developing find, recruit and follow-up service so that we can better identify patients who are eligible for clinical trials, invite them to participate, and then support the data collection in order to follow up. And the hope is that this will improve recruitment into trials, but also retention into those trials, so that the data that's coming out of them can have a real impact. We want to focus on our quality and impact. We want to make sure that the work that we're doing is really important. So we have spent quite a lot of time setting up a governance structure within house so that we can actually make sure that the work we're doing is meeting the needs and the priorities of our partners and of the public. We want to be in a position that we can say yes to partnerships. We want to work more closely with people. And today is a great example. We've done quite a lot of work with ATiC and with University of Wales Trinity Saint David's over the last few years, particularly focusing on our collaboration with WIDI. So I'll come on to that shortly. But the other area that I really want to mention is culture. So we are looking at how we can better upskill our staff so that they are motivated and willing and want to be involved in innovation and research projects. So we're looking at what training we can provide. So again, working with WIDI, we're looking at some of the innovation modules that we can produce that can support training, not just within DHCW, but in the wider NHS. We're also linking into the business change programme. So I don't know if any of you are aware, this is a great programme that looks around the leadership within healthcare and how we can motivate and help people to make a change. So the partnerships and networks are really important. It links back to our core mission and it links back to our values. And as you can see, we are partners with a lot of different organisations. This is not an exclusive list, there are others. But particularly important is our WIDI partnership. So this is the Wales Institute of Digital Information. And this partnership is with Trinity and University of South Wales. And we're focusing on 3 main areas, which is looking at teaching, how we can support the training that we're offering within the NHS and also to people who in the future may look to come and work within the NHS. What are the skills gaps? What are the move in technology that we need to address? Looking at workforce and organisational development, so looking at that talent pipeline, and also looking at research and innovation projects, so how we can work with each other and collaborate to undertake different projects. SAIL was mentioned earlier. We are a trusted provider of SAIL, so a lot of the data that they have flows through Digital Health and Care Wales. So Gareth helped with the anonymisation algorithm, so he developed those. And so we are a trusted provider of that information. So we work really closely with SAIL and a lot of our projects as well, and I'm sure Jen will pick up on some of that work. We work closely with all of the universities, and we also are part of the life science ecosystem, working very closely with Health and Care Research Wales, Life Sciences Hub, MediWales, etc. And this is really important because actually it means that we'll have a bigger impact if we're working together. So it's really easy for me to talk and say, these are our vision, these are our missions, but actually it doesn't really give you an idea of what we're actually doing. So I just wanted to give you a brief overview of a project that we ran called ID8. And this was a really collaborative project which was run with Welsh Health Boards, Swansea University, the Value in Health Unit, Health Analytics UK and Pfizer, who actually funded the study, to create a health event linkage using outcome-based agreements. So we were looking at people with breast cancer and looking at metastatic disease to understand which of the medications would actually be able to show within an outcomes-based approach. So could we then use value-based procurement models moving forward in order to actually look at patients who have gone through this and move towards that model of care? And we know that sort of following this pathway, that outcome-based agreements have the potential to align incentives of the companies, so the people who are providing the medication, and those who are actually using it in the therapeutics, and also for patients and populations, so we're able to look at ensuring there are better outcomes and improving those outcomes and experiences for patients. So this was really a proof of concept study to really understand how we could collect that data, how we could use that data, and then how we could link it into sort of financial flow mapping. So bringing together all the partners, it was looking how we can take that research innovation project and actually make a difference and move it through that transition and come up with something that could have an impact and could be used to transform services and delivery. So my message really today is there's lots of opportunities and lots of things that we're doing, and we really want to work with people, we really want to get involved, and we really want to be able to drive better value through outcomes, through using innovation and using the data. So our ultimate aim is really all about the patients and about the services and how can we break down those barriers to show better outcomes. So I'm going to hand you over to Jen, who is going to talk to you a bit about the secure data environment.
Thanks, Rachel. So hi, my name is Jen. I work in the National Data Resource as a Senior Product Specialist, and I'll just set the scene slightly. So the National Data Resource is a very large programme of work that's currently being undertaken across NHS Wales, although I admit there are a large portion of us that are DHCW employees. And the core NDR is looking at implementing sort of a national database within the cloud, which is very exciting, and Gareth will touch on that slightly in his slides. But there's a smaller team within that programme called Advanced Analytics, which is where I sit. And we're looking to enable analytics, particularly advanced analytics, across NHS Wales and with partners across 3 work streams. So there's the capability work stream, an innovation work stream, and then tools, which is where the SDE sits. So I guess the question is, what is an SDE? So an SDE is, or what we're looking to implement, is a secure platform where we can do collaborative data work. So that's between both NHS, so health and social care, but also academia and industry. We're currently we've just moved off a pilot phase, so we're in a service in transition phase, with the ultimate aim being a live service on the NHS catalogue. But we are delivering a service right now, so there are people in it today emailing me problems, which is good fun. So I guess the question is, why would you want to use an SDE? What's the benefit? So when I first started working with the NHS, and particularly with Gareth, I was a contractor and I got given a laptop. So you have to go into Cardiff, you get given sometimes more than one laptop, you've got to cart them around. There's obviously a cost associated with that for the NHS for providing that kit, time for the team to set me up and give me access to the right areas and the right data and the right software. What the SDE does is it removes a large amount of that burden. So instead of having to have a laptop, you can log into our platform from any computer, as long as you've got an internet connection. And that platform will then host all the data you need for your project or your piece of work, as well as the software tools that you would need to undertake your work. It also has sort of the high standards of privacy and security, and we do have a governance wrap around it where we help people work through the governance, which can be a stumbling block for a lot of projects. The current tool that we're hosting our secure data environment on is called SERP, so the Secure E-Research Platform. And anyone that's used SAIL, I know SAIL have been mentioned quite a few times, it's the same tool that they use and they provide it to us to host our SDE on. And then the wrap we provide our side is, we do, as I said, that governance support. So we'll support projects on getting their DPIAs signed off, so that's a data privacy impact assessment, but also checking that there's the right data sharing agreements or contracts in place. We'll also prepare the data. We might have to acquire it depending on the project, or we might get it from DHCW. provide any linkage, put it in the platform and make sure it's ready for the users. We also have quite a comprehensive suite of user guides, if I say so myself. So there's lots of videos and we provide live support so they can email us. Oops, did I do that? They can email us problems while they're in the platform and we'll work through issues on screen. Just an example of the types of projects we support. So we've done a large amount of training events and hackathons. For example, right now we're supporting a learning program with finance analysts within the NHS, so upskilling them on some more modern techniques with data. We also do hackathons regularly with the Bosch Modelling Collaborative, where we support challenges for their participants within the SDE. Additionally, Rachel touched on Ideate, so that was undertaken in the SDE, so with a commercial organisation. And then we're looking at projects with sort of NHS project teams and academia, and quite often collaborating. Right now we're in the governance stages of some projects around natural language processing with Swansea Uni and Swansea Health Board on how we can get information out of things like epilepsy clinic letters or radiology reports to help clinicians and researchers. As I said, we are a live service, so any project that thinks they can benefit from using the SDE is more than welcome to get in touch with us, and we can talk through if it's of use to you. There's an email address on screen. I'm not sure if the slides are going to be shared. And that's everything from me. I'll hand over to Gareth unless there's any questions. Go.
Granda. Yes, I'm Gareth John. I head up the information delivery team within the ACW. And then just a segue really there, I think what I'm going to talk about is NHS data. The idea with the SD is it's an environment to collaborate. We obviously have our own internal NHS environments which we'll use on a daily basis. Whether there might be circumstances due to tooling or capacity, we might choose ourselves to use the SD, but it's mainly to actually allow NHS, non-NHS to collaborate, come in. And there's lots of examples which we'll cover, which might sort of, we will need that support really. So my team, include a team who acquire, process, basically transform NHS data into a format that analysts can use within the DHCW's National Data Warehouse. We make those data products available to information specialists, analysts, all parts of NHS Wales and sometimes beyond. Again, we are a provider of data to sale, and we do work with other academic partners. So I've also got a team of analysts who produce national reports and dashboards and carry out a range of analyses for a number of different stakeholders, clinicians, etc. So first I'm going to talk about the NHS Wales data that we have within our data warehouse, and then I'm going to talk about some collaborative work we've done with clinical colleagues. We started out as a data hackathon. You can see on the pack we've said DHCW data hackathon. We're not going to actually do a hackathon today, but we're going to introduce the concept. So I think, in these events, we tend to focus on flashy things such as interactive dashboards and, predictive tools, and that's good, they're all, but you can't do that with any data, without any data. And I think we sometimes underestimate the time, effort and skill required to create a nice curated store of data. And I think, so what we tend to see is just the tip of the iceberg often. We see the analyses, reports and flashy dashboards, but below the surface, actually majority of work needs to take place. So there's data storage, information governance, security, and then transforming that data so it's in a sort of form that's amenable to analysis, machine learning, etc. And I think, some of the value we need to add within our own data warehouse is, the checking completeness of data, reporting that completeness back to users, removing duplicates, reporting errors back to providers of data such as health boards. We do try and improve the completeness and validity where we can. So, for example, if there are missing NHS numbers, NHS is a key part of facilitating linkage, individual level linkage within a data environment. We're able to trace that against some of our patient registers. If information is provided in the wrong format, maybe outside of the sort of given agreed information standards, we can reformat some of that. And I said linkage is a key component of what we do and the environment we provide. So person level, again, it's using just basically NHS numbers. But we also do event level, pathway level linkage becoming more of a thing now where we want to just link related events. So there's some algorithms we've developed, for example, linking ambulance data into associated ED attendances. And there's a lot more of that happening as a growing area. And again, we're working with sale colleagues because that's another different challenge in the way a sale receives data, it receives ready anonymized data, so sometimes their ability to do that event level is slightly compromised. So we're looking at methods, how we're going to enable that in the future. We also supplement raw data. So a lot of the raw data we receive is very much codified, administrative, internal system codes, clinic codes. So we try to supplement within Awareness with meaningful text, groupings, natural hierarchies of that data. And there's lots of other analytical, useful stuff we do, such as comorbidity indexes. We add those on healthcare resource groups, which are used for finance, and other sort of statistical measures. So there's a lot more added, and every analytical project comes along, we're sort of building, if we think actually this is a reusable, derived information, we got that, it's built into the warehouse, it can be used for the next project. So it's always growing. And in fact, we work closely with our IG team, information governance team, make sure everything's legal and proper, people have the appropriate level of access, and then sort of pseudonymization is a big part of that. So probably for 99% of cases, the analysts don't need to know who the individuals are, but they need to still link those records together from different sources. And pseudonymization facilitates that. And again, that's part of what we do for sale. So this is just an example of some of the key data sets we've got with some of the volumes. So some of these, for example, admitted patient care, child health, and Welsh Demographic Service, we've got around 30 years worth of data. So, pretty impressive historical record. Only we have that. The health boards would have archived off a lot of this information. And then there's also some very large data sets. So the Welsh Results Reporting Service contains requests, results data from a number of different departments, such as radiology, microbiology, and blood sciences. So very large volumes. There's 2.4 billion results within the WRRS, and obviously growing very quickly. There are some notable gaps. Again, there's some data sets I haven't shown on the slide just for space, but probably the main notable gap we've got is GP, individual level GP data. So we still, within Wales, very much rely on the SAIL data bank. So the NHS itself doesn't have that linked data, GP level. So SAIL is a big part of that, but something that we are working on. And as Jen said, there's the ongoing National Data Resource Programme, or NDR programme, which is hoping to address some of these gaps. And I think that will really result, the NDR will result in a sort of increase in volume, variety of health and care data, which is available to users within NHS primarily, but obviously other people will benefit downstream. And also improve the range of analytical tools, as Jen has explained. And the NDR will be hosted on the Google Cloud platform, which brings with it opportunities and challenges. It'll bring with a range of different data types, far more than we're used to. We're used to very much SQL Server, nice simple tables, columns. Whereas I think, we might have image data, other different data types, a lot of unstructured data, like free text. But there's actually opportunities in that as well with the free text. I think Jen has explained there's a couple of projects we're working with the SD around clinic letters and radiology. We're trying to extract analytically useful information from those. I think that's going to be sort of one of the big objectives for us to expand our data offering. We want to make radiology reports, clinic letters, more analytically useful. So NLP is a big area. There are some off-the-shelf tools in Google, but also we want to work with partners who've got experience in this area, just to accelerate things on our side. So that's the summary of the data. Next, I did say I was going to showcase a collaborative project we've done with some specialist palliative care colleagues. So this explains our sort of journey from an initial data hackathon all the way through to the launch of a national end-of-life dashboard. So it's a joint presentation with Anthony Byrne. Anthony's a palliative care consultant within Cardiff and Vale. He's not with us today, but he's recorded a few clips. So Anthony's going to start off and introduce the hackathon event. This was back in May 2022. Yeah.
Hello, I'm Anthony Byrne, a palliative care consultant in Cardiff and the Vale University Health Board, and I'm delighted to share my experience of working with the team at Digital Healthcare Wales and the collaborative journey that we've been on towards the development of a population dashboard for the last year of life. This project actually started as a hackathon supported by the Welsh Modelling Collaborative back in May of 2022. And I was fortunate enough to be invited along as a problem owner, along with my colleague, Dr. Idris Baker, who is the National Clinical Lead for Palliative and End-of-Life Care in Wales. And at this virtual event, we were given the opportunity to interact with analytical and information specialist colleagues from DHCW. And the reason for doing that was we wanted to explore opportunities to better understand what was happening to the palliative care population, particularly their needs in the last year of life. And this has been a long-held ambition for specialist palliative care community in particular, because we had very little understanding of what was happening to our patients in that last year of life and the sorts of interactions that they were having with different services and the systems of care that were wrapped around them. But we'd really struggled to put together data about the type of care being received by individuals, and particularly the types of services and organisational interactions that were happening, and particularly from outside the specialist palliative care field, so that we were getting an understanding of the population as a whole and not just those that were known to specialist palliative care teams. And given those difficulties, I guess it's not a surprise that we went into the hackathon not overly optimistic about the types of data that might be available. And so our sense of expectation really wasn't very high at that point. But what was clear to us from the outset was that the analysts and the information specialists had already done a huge amount of work. They'd done some background digging into the data sets that might be available based on the problem that we presented to them ahead of the meeting.
And so that some of the ideas we showed Anthony and Idris were basically recycled, a lot of them, from previous work we've done in unscheduled care. And it was a case, so there was analyses, visuals we had. It was just a case of just tailoring them to basically the sort of palliative care end-of-life context. And that was quite useful because it was quite difficult. It was a virtual event. Otherwise, blank bit of paper would have been quite difficult to get discussions going. But this was, at least they had something, which it was engaging. They had something to see, comment on, and we could discuss. And they could see the breadth of data that was available and how we could potentially be used. And this encouraged them to come forward with some of their own ideas. It meant that within a very short period of time, we would be able to broadly agree what the objectives would to be for this two-day event. It meant the information specialists could go away, do the analytical and development work, and the clinicians, if they wanted, could go back to their clinical work, and there'd be sort of various check-in times during the day, the 2 days. And so the challenge we set ourselves was to create a cohort of individuals who had died in the year 2021. And the idea then was to bring together all information we had within our data warehouse, as much as for those individuals in their last year of life. And the focus very much on unscheduled care interactions. And then we want to analyse and visualise that data in a way that was understandable and engaging to the users. And so, again, this is all based on data we already had within our data warehouse, which included the Office for National Statistics registered deaths data, and that was used to generate a cohort of nearly 34,000 individuals. And then, obviously, we wanted to capture the healthcare interactions for this cohort. So we used a wide range of data sources from our data warehouse, some of those hospitals, some of them pre-hospital. We also have specialist palliative care contacts, and also data from our National Patient Register, which is the Wales Demographic Service. The tool we used to visualise was Power BI, and that ticked a lot of boxes because we already existing skills within the team. There were existing templates, as I said, visuals that we'd used. It provided the necessary degree of interactivity for the users so they could filter and look at different conditions and drill into different age groups, etc. And we were already licensed to publish these dashboards. So that ticked the box. And then one of the first things we showed, and what first templates we showed was what we call our patient on a page. Now, in this case, each row here is an individual. Obviously, we've given these people a random number, but that is an individual. And it's shows all the sort of interactions they've had with services in their last year of life. Up to the date of death is shown in as the red bar there. So the different colours represent contacts with different services. You can see going across the top. You've got 111, GP out of hours, WAS is the ambulance service, emergency department, admission, admitted patient care, specialist pilot care, and obviously got the death date here. And using this, it was quite a good way of engaging the customers. They didn't really worry about any statistics or numbers here. This just showed, this was like dynamite to Anthony and Idris because they'd never seen their patients in this context. They knew patients that they had directly treated in their specialty palliative care context. But there's a lot of people who, in the last year of life, don't even touch palliative care services, and then also they didn't know about these unscheduled care contacts around. So that was really useful, really engaging, and it was a good way of eliciting further questions from the problem owners. So, for example, they wanted to know how many days during the last year of life did these individuals spend in either an ambulance or a hospital. And we could see from this that the intensity of use increased as you got nearer to the date of death. That wasn't unexpected anecdotally, but what was quite useful, we were able to sort of contextualise this in terms of some numbers. So we compared to a control group of a similar age, similar sex, and we discovered our cohort sort of spent 12 times as many days in a hospital ambulance than a comparable group, and 25 times as many days in the last 3 months. So those are numbers that actually Anthony and just could take away, compare, how does that compare health board by health board, track that over time. Is that good or bad? That's up to them, I think. But they've got a number now they can actually build into any business cases, whereas previously it was more anecdotal. And I think then, from ourselves, our reflection of the hackathon is that we were pleased what we were able to achieve within 2 days, just 2 days. Lots of engagement and enthusiasm for both information and the clinical side. And what was great, and thanks to Anthony and Idris, is we felt we were equal partners in the process, creative process. It wasn't just sometimes a clinician can lead the discussions. It was very much a meeting of minds, us bringing our strengths, clinicians bringing their strengths and their knowledge and context of the service. So we think it was quite a nice template for how to successfully collaborate and bring in information together with healthcare decision makers, really. But don't take my word for it. And here's what Anthony thought about it. And so with the support of the Value and Health Centre, we were able to actually put this work on a more formal operational footing. And we actually held a dashboard launch. So from May 2022 with the hackathon to February 2023, we'd actually done the development to actually launch this into a fully fledged national dashboard published. There was approximately 50 people on the launch course, a lot of enthusiasm, a lot of interest in people, and saying, well, actually, we would like to use this in this context, different stakeholders, etc. So a really nice success story. And I think it's a good template. So I think, when Sean asked us today, he said, well, actually, could we run a hackathon, or at least could we get some ideas together for a future ATiC hackathon? Now, I think with the registration went out, I think ideas were asked for, but I don't think we had much in. And maybe that's because people were coming quite cold to it. But now you've got a bit of an idea of how it sort of works and what the expectation, and I think those links are really important, that you're linking in with decision makers, and then you understand what you're doing is important and potentially is going to have an impact. So I think we're going to do it a little bit different way. We've got Rachel's going to do a Mentimeter, so it's going to be a bit interactive. Well, interactive, you have to type on your phone, as interactive as that is, if it works. So we're going to try this, and we'll probably finish a little bit early today, because it's... Will we? No, it's not that early. We'll see. So, yeah, thanks.
We'll try and see if it will work. Okay, so I think what Gareth has shown you is a real example of the work that we're doing and actually how that can translate into having clinical benefits. So what we really want to know from you is actually what can we do to help you work with us? What kind of questions have you got that we could use, that the data could answer? And now there's sort of a better understanding, hopefully, of what data we hold. How is that going to make a difference? So if people are able to use the code, I don't think I can show you the results on the screen, but we can go through them. You're welcome to come down so that you're closer to take a picture. Yes, 8899 2650. Well, I'm not singing a song, Gareth. If you want to come and sing, you're more than welcome. Otherwise, everyone will be leaving and not filling out the Mentimeter. Okay, so I can see some of you are in. The code again is 8899 2650. So hopefully the first question that you'll see is, do you want to use data? This is good. I can see what the results are. It's going well, because this could have gone really badly if everyone said, no, we've got no interest. Please just let us go home. So the majority is obviously, yes, we want to use data. That's a great start. We want to have people who are interested. We want people who are engaged, and we want to be able to provide that data and the resources to use it. And I think what the really good thing that Jen and Gareth both touched on is the governance side, that we really do provide that wraparound support. So being able to sort of get those permissions in place for you. So we're used to doing that on a routine basis. We've got a dedicated team, and actually we can help overcome the obstacles. So yes, the majority said, obviously we had one who said, I could be persuaded. So if you get in touch, we will persuade you, and then we'll be able to help you to use that data. Okay, so the next question, what could we do to help you work with DHCW? So what can we do differently that is going to make you want to come and work with us? And it could be anything, like telling you how you could actually get in touch with us is probably a good starting point. We've mentioned the information governance. We've got the data, we've got the platforms to be able to use it, but how can we get you to want to come and work with us? So how-to guides, easy access. So we have got some how-to guides and videos with the secure data environment. We've also got some clear processes. So with the data request service that we run, if you wanted to have access to data, but you wanted somebody to help support that analytics and give you sort of the feedback on that, then that is something that we provide as well, so we can share those links to services with you. For example, we're doing a project now with Blood Cancer UK, so we're working very closely with SAIL to deliver on that, and so we're putting the governance in place, getting the data together, and then once we've got that information, we're working with Oxford University to then develop a dashboard to present that. Biscuits, good one, yes, we can provide biscuits at meetings as long as they're in person. One of the things somebody put is, why not SAIL? So we work very, very closely with SAIL. We're not here to try to replace them, but what we're looking at is really more around that transformation and actually how can we help support changes in clinical care, so how can we help with that innovation side. SAIL are very much focused on the sort of more initial research, so we're looking about more transformation. And actually what we want to do is be able to use the data to create these dashboards which can then go live and can be used. So rather than looking to build something that is purely for research. Clear offerings. You're right, we need a clear front door, and it is something that we're working on, so it's very clear to what we're doing, what we're offering, and how you can get in touch. Workshops is another great one, and with the NDR, there's a lot of different events. So the big data event was run back in March, I think, and there's some follow-up events that are being planned where we can look more on a practical level of the different offerings that we can do. So we'll take all of this feedback back, and we were going to make a plan for how we address it, and we'll feed that back to you, because you're right, you know, you need to have the feedbacks of what we're going to do, so that we'll come back to you through Sean and say, you know, based on this, this is the plan. Funding, that is one that has come up, and unfortunately we don't have the funding for it, but we do have the skills and the resources to support it, which can help negate some of the funding requirements, and we can also support those funding applications with our networks and colleagues. Okay, so this is the big one. What we're looking to do is to run a hackathon with ATiC. So we are looking for a question that we can then help work with you to develop, so that we can build a dashboard or run some analytics or do something fun with that data that is going to have an impact. So have you got any questions that you can give to us that we can then take away, and the pressure's not really off you because you've got to work with us, so it's sort of nominating yourself for more work. You should have brought your tuba. You could have played for everyone during the lull. We'll add that onto the recommendations, that when we do these Mentimeters, that we do something to occupy the silence, which isn't just me talking. Yeah. NLP work that we do with this. For epilepsy, there's an existing NLP artist which we're going to try out and be a little bit so it's that because they can't hold themselves in that way, so last night we can't and we can't use it. Yeah, we rely on say for primary care analysis of research that are sitting within the NHS. Part of the reason with the TriTech is it's got potentially got personally identified information with embedded within it, which sale can't have. Types that. Yeah. We'll all, just in case. He will keep talking.
Sorry. Yeah, so sales got its place. That's what I'm saying. But there are certain things where, and particularly as in that translational stuff, where you want to try out things against real world data.
And it may be that we bring sale in as a partner into the question. So we've had a few that have come out. And I don't know if this gives us the names of the people who have suggested them, but we will find a way around that. So some of the ones that we've had is, could we create a disease prevalence map of the health boards in Wales?
That might be a sale one, because they've got the primary care data, yeah. So depending on the disease, if it's a disease serious enough to warrant hospital admission, then we could probably do a proxy nationally, but yeah, we could do something. Depends what it was. Yeah. We've got a cancer register.
We have got, so there are...
There's a unit that does cancer, so we don't need to replicate that.
So there are some dashboards with different diseases which are already in place, which are accessible to people working within the NHS, and some databases and dashboards which are publicly available. Yeah. But yeah, it comes down to the diagnosis and what we can, if we've got that information. Pre-surgical contacts prior to hip and knee replacement related to the surgery. So yes, as long as it's from the point of referral from primary care and looking at secondary care contacts.
We've already got a route in, so with under the Value in Health programme, we work with Phil Thomas from Cardiff Vale, who's a hip surgeon. So there's a hip dashboard, actually, hip and knee dashboard. And it's got some prom analysis as well in it. So I think it's one of those areas we'd be interested in, you know, getting some other views in and see what else we can do with it. So yeah, that sounds like a good one.
I'm guessing that came from Peter. Have you seen that dashboard, Peter?
Yeah. So yeah, sounds like a good idea.
So that's a good example. If there's something that's already existing, is actually can we modify, can we build on that and add in the additional questions to it. So we had one the other day around mesothelioma because our lung cancer dashboard doesn't pull out that data to the depth that they required it. So how could we move that forward? I'm really conscious that it is nearly 5 o'clock and you probably all do want to get home. So I'm going to do one more. Inequalities across Wales. So areas to target for specific interventions where inequalities are present. So yes, that is something that we could potentially look at. There are areas where we wouldn't necessarily have all of the...
Well, it depends what we're looking at, doesn't it? I guess, you know, we've got the ability to geographic profile and sort of from a deprivation point of view profile, you know, all our records. So it depends what we're looking at, what conditions, what services. Yeah, but it sounds feasible.
Brilliant. So what we'll do with the questions that we've had, so we've had 10 questions, and like I said, I'm not sure if it gives us the names, but we will come back to you and ask, and we will arrange an event with ATiC to be able to look at these questions in more detail, and it may be, and we'll work out the best way so that we can look to see how we can answer these questions, how we can work with you, and then look at what the next steps, if we need any funding, etc. So we will be in touch to arrange that. Is that okay, Sean? Brilliant. Thank you very much. And if you do have any ideas, questions, anything, then our emails are on the slide.
Thank you so much, guys. Perhaps, I know everybody's probably really keen to get off now, but if you did submit a question, you might want to just make yourself known to the team at the front. But we will send out some emails after the event to everybody that's registered, just to kind of let you know what the next steps are going to be regarding the hackathon event. So watch that space. So I think I'd just like to say a few quick thank yous, and then everybody can go home. Thank you to the guys who've been providing the technical support. We had a few challenges yesterday and this morning, but we managed to work our way through it. Thank you to all the speakers who presented. I found it really, really interesting. My mind is buzzing. It might be the caffeine, but the content of the presentations as well. And if one thing that's come across for me today is technology is amazing and it does an awful lot, but I think what's even more important is the people in the room. So a few people have said to me this afternoon, you know, we need to kind of think about the way we develop this event in the future, which is what we're planning to do, to create more opportunities for people to talk. You know, the presentations are really insightful and inspiring, but actually the real meat is in the sandwich, I guess, is in between, when we get the chance to have a chat over a coffee and come together and share ideas. So what we want to do is get your feedback. If you use the QR code again, there's a very quick online form. We didn't include a question about whether you want a jacuzzi next year, but you know, if the feedback suggests that, then we'd be willing to try and get funding for a jacuzzi. Final thank yous are to obviously to the guest speakers, but also to the amazing ATiC team who've helped put this event on, and everybody else who's been involved behind the scenes, catering and the estates team and everything. So I probably missed a lot of people, but thank you very much. I hope you've had a great day, and hopefully we'll see you again this time next year. Cheers. Bye-bye.